I welcome you all to the STAR OG conference, and it's looking over the new horizon. This is a global virtual conference on 16, 17, 18 April, and let us start the star-studded event today. And for the first session, it's on the challenges in obstetrics and gynecology. It is my privilege to have chairpersons, Professor Dr. Pradeep Samre. He is teacher of all teachers, and he's a well-known ex-HOD of BJ Medical College. Good morning, sir. It is our privilege to have you here. Dr. Kiran Patore, famous gynecologist from Nasik, and Dr. Sanjay Das. He is a well-known obstetrician and gynecologist from Orissa. And let us start with our first talk. It will be on thrombocytopenia in pregnancy by Colonel Dr. Atul Seth.
Good morning to all of you. I am Dr. Atul Seth. I am a gynecologist and I serve in the Indian Armed Forces. The topic on which I am going to speak today is thrombocytopenia in pregnancy. Now, this is not an uncommon situation that we encounter. Thrombocytopenia is when the platelet counts are less than 150,000 per microliter. And it is the second leading cause of blood disorders in pregnancy, the first one, of course, being anemia. It affects about 10% of all pregnancies, and which is a substantially large number. Women are more commonly diagnosed with platelet disorders during pregnancy for the simple reason that these women, when they come to us for antenatal care, we do a blood test and we see the platelet count. Most of them are asymptomatic. It is just on routine testing that we find that the platelet counts are low. Now, going to the first MBBS days, what are the basics of hemostasis? Well, the platelets play a critical role in hemostatic system. The primary hemostasis consists of when the platelets adhere to the site of endothelial disruption, the platelet clumping takes place. This is followed by platelet activation, in which the von Willebrand factor, ADPs, and serotonin take part. Now, this serves to recruit other platelets into the growing platelet plug, which acts to stop bleeding. And thromboxane A2 and serotonin lead to vasoconstriction, which helps in hemostasis. The secondary hemostatic phase begins when the coagulation pathway is activated on the surface of the activated platelets to form a fibrin meshwork, which serves to reinforce the platelet plug. If we want to discuss the etiologic classification of thrombocytopenia, well, it could be simple that it could either be because of increased destruction or decreased production. And the third one is sequestration. Sequestration means hiding. 70% cases of thrombocytopenia in pregnancy are gestational thrombocytopenia, followed by preeclampsia syndrome. The next one is immune thrombocytopenic purpura, which accounts for about 3% cases, and all others taken together account for about 6%. Broadly, if we divide them into pregnancy-related and not pregnancy-related causes, gestational thrombocytopenia, the hypertensive disorders, and acute fatty liver of pregnancy are the pregnancy-related causes, whereas the ones which are not related to pregnancy are pseudothrombocytopenia, ITP, TTP, HUS, and so on. There is a long list there. So coming to the commonest cause first, that is gestational thrombocytopenia, about 5 to 11% of all pregnancies are affected, and they account for about 75% of cases of thrombocytopenia in pregnancy. The exact cause is unknown. However, there are two main associated factors, and that is accelerated platelet activation is suspected to occur at placental circulation, and accelerated consumption of platelets is due to reduced lifespan of platelets during pregnancy. These patients are usually asymptomatic with no history of abnormal bleeding. The thrombocytopenia is usually mild, and it is usually an incidental finding. there are no specific tests to definitely distinguish gestational thrombocytopenia from mild ITP, and gestational thrombocytopenia usually develops in the mid-second to third trimester. Now, what you see on the type is in a small font because I do not want you to read it. What I want you to read is the summary of what comes out of these studies. That is, the antiplatelet antibody tests, either alone or in combination, cannot be used to distinguish ITP from gestational thrombocytopenia. What are the clinical manifestations? There are no pregnancy history of low platelets or abnormal bleeding is noted. There are no confirmatory available tests, and platelet counts usually normalize within 1 to 2 months following delivery. There is no pathological significance for the mother or fetus. There are no risk for fetal hemorrhage or bleeding complications are observed. So now, if we just summarize, these are patients where the low platelet count is an incidental finding during pregnancy. The patients are asymptomatic, and they usually come back to normal after the pregnancy is over. So what do we do about them? Well, if a patient comes to us in preconceptional phase, so we know that gestational thrombocytopenia can recur. So if there is a history of gestational thrombocytopenia in previous pregnancy, you can just keep a tab on this patient. During the pregnancy, we can monitor the platelet count periodically. Where there is no treatment which is as such requires for gestational thrombocytopenia, and invasive approaches to fetal monitoring like fetal blood sampling are not indicated at all. What about delivery? Well, the mode of delivery is as decided by the obstetric indications. Epidural anesthesia is usually safe because, as I said, the platelet count is not very low. The antepartum anesthesia consultation obviously has to be decided in consultation with the anesthesiologist. And after delivery, we must document the return of maternal platelet count to normal after a period of time. Our anesthesia colleagues, and sometimes us along with them, are very much concerned about epidural hematoma. So, ladies and gentlemen, only 2 cases of epidural hematoma have been reported in gravidas receiving epidurals in labor. One patient had gestational hypertension and lupus anticoagulant, and the other patient had an ependymoma. All other cases of non-pregnant epidural hematomas occurred in women receiving anticoagulants. Historically, anesthesia recommendations were that epidurals should be withheld if the platelet counts were less than 1 lakh, but this may be a little subjective recommendation. 3 series have been published of gravidas undergoing regional anesthesia with unexplained or initially unrecognized thrombocytopenia. The combined total was 105 women with platelet counts less than 1,50,000, and out of these, 51 had platelet counts less than 1 lakh, and no anesthesia complications were reported in these series. It is absolutely unnecessary to do a bleeding time. When gestational thrombocytopenia is suspected, blood platelet count falls lesser than 80,000, a diagnosis of ITP cannot be excluded. And in this situation, prednisone in a daily dose of 10 days for 10 days before birth can be administered in order to increase the platelet count in case it is ITP and avoid possible anesthetic and obstetrical risks. In gestational thrombocytopenia, there is no therapeutic answer to steroids, and the lack of response is an additional argument for the diagnosis of gestational thrombocytopenia. So what it means is that in case it is ITP, the patient will respond to steroids. In case it is gestational thrombocytopenia, the patient will not respond to it. Thrombocytopenia associated with hypertensive disorder, this is the second group, and this is what we all see very commonly. Preeclampsia accounts for about 5 to 21% cases. The platelet counts are usually moderately low, and they rarely decrease to less than 20,000, and this correlates with the severity of the disease. The pathophysiology in hypertensive disorders is increased platelet consumption and vascular endothelial damage, which increases the platelet activation. The clinical manifestations could be in form of HELP syndrome. The perinatal mortality here is high because of complications like placental abruption, asphyxia, and extreme prematurity. The fetal growth restriction is common, and neonates may be at an increased risk for thrombocytopenia. Delivery, we all know, is the ultimate cure for the preeclampsia-eclampsia syndrome. However, it can be delayed for 24 to 48 hours in case of prematurity. And HELP syndrome with thrombocytopenia does not by itself require a cesarean delivery. So we should maintain a platelet count of more than 20,000 for vaginal delivery and more than 40 to 50,000 for a cesarean delivery. Now, this minimum count is controversial, and the decision should be made on the overall clinical picture if the platelet fall below 50,000 per microliter prior to cesarean delivery. If thrombocytopenia is severe, regional anesthesia and pudendal blocks may be contraindicated. Dexamethasone for maternal benefit is not recommended by ACOG task force. The HELP syndrome, please remember, can occur postpartum, and thrombocytopenia associated with acute fatty liver of pregnancy is sometimes very severe with a platelet count less than 20,000 per microliter. Coming to the third, that is ITP. This is about 1 to per 1,000 to 10,000 pregnancies and accounts for about 3% of thrombocytopenic gravidas. Now here, the IgG antiplatelet antibodies recognize the membrane glycoproteins and coat the platelets, which are then destroyed by the reticuloendothelial system, predominantly the spleen. The antiplatelet antibodies may cross the placenta and can now affect the fetus. Now this is different from the gestational thrombocytopenia, which we discussed earlier. Minor bleeding complications include purpura, ecchymosis, and melena in the mother, and major bleeding complications can include intracranial hemorrhage leading to neurological impairment or death. ITP is a diagnosis of exclusion. The following may be noted: that there may be persistent thrombocytopenia, increased number of megakaryocytes in the bone marrow, and exclusion of systemic disorders or medications or drugs in the absence of splenomegaly may hint toward a ITP. Approximately 80% of cases are associated with antiplatelet antibodies, although these are not required for diagnosis. ITP can be classified into newly diagnosed, persistent, and chronic, depending on the duration of the disease. There may be some bleeding manifestations and sometimes severe hemorrhage. The neonates may be affected in about 12%. Intracranial hemorrhage is rare and it does not appear to correlate to the mode of delivery. Vaginal delivery is safe. Cesarean delivery should be reserved for obstetrical indications only. So we shouldn't feel that intracranial hemorrhage will be less if we conduct a cesarean delivery. A scalp blood sampling for the fetus and risk for the percutaneous umbilical blood sampling appears to outweigh the risk of a vaginal delivery of an infant with thrombocytopenia. The neonates may be affected. The antibodies are known to pass through breast milk, but breast milk feeding is not contraindicated. We should notify the pediatric colleagues and manage the neonates in consultation with them. We can initiate treatment if the patient has symptomatic bleeding or the platelet count falls below 30,000 and or prior to invasive procedures. While all these patients improve maternal platelet, the various modalities they improve the maternal platelet counts, none have been shown to be adequately prevent or treat the fetal or neonatal thrombocytopenia. So what are the various modalities? One is steroids, which could be given orally. The next is IVIG. Now, I'm not reading out too many details because these are modalities of treatment which we should know. However, when we are managing these patients, we'll probably be managing them in consultation with the hematologist colleague. So IVIG is effective but very expensive. Anti-D immunoglobulin in Rh positive non-splenectomized women is interesting. The anti-D immunoglobulin binds to maternal red blood cells and results in Fc receptor blockade. The spleen then directs its phagocytotic activity to the coated red cells rather than to the antibody-coated platelets. Now, this is not useful in Rh negative or splenectomized women. Little data are available on use of anti-D immunoglobulin in pregnant women and the risk-benefit ratios need to be considered. However, because this is a conference setting, I thought I must bring out that this is also one of the known modalities of treatment. Splenectomy removes the organ responsible for destruction of IgG-coated platelets. However, in pregnant women, splenectomy is usually avoided. Splenectomy leads to complete remission, occurs in which occurs in two-thirds of cases, and splenectomy does not have an impact on circulating antibodies that may still cross the placenta and cause neonatal thrombocytopenia. If we have done a splenectomy, or we are doing a splenectomy, we should remember that these patients should receive immunizations for meningococcus, pneumococcus, and Haemophilus influenza.
So thank you, Dr. Atul Seth, Colonel Dr. Atul Seth, for this elaborative talk. And now we basically move on to our next talk, and that would be a very interesting talk on what's new in contraception by Dr. Shobha Gudi. Over to you, madam.
Thank you. I'm sharing my screen. So is my screen seen properly?
Yes, yes, visible.
Yeah. Okay. So thank you very much, Sunita. Wonderful conference here. Hearty congratulations to you, to Vaishali, to Parag, to Nilesh, and entire team. Thank you for inviting me here. Contraception indeed is the need of the hour, and it's very aptly included in the very first session because that is the priority for what's new in contraception. What we do know today is that we are going to reach 9 billion by 2050, and India accounts for 17% of world population. What we perhaps do not know that a lot of pregnancies, especially in this pandemic, up to 2/5 to half of pregnancies which are being conceived are unintended and unplanned. And the unmet need for contraception, if it is met, we can avoid 55 million unwanted pregnancies, 22 million fewer abortions, which result due to them, and 90,000 fewer maternal deaths. Now, that is a significant data to contend with, and we need to be introspective every day in our practice, and we need to figure out a way to reduce the number of unintended pregnancies while conforming for our contraception prescription to the WHO medical eligibility criteria 2015 and categorizing our women who fit into 1, 2, 3, and 4 for a particular contraception method where we can prescribe them the safest one possible. And this is something worthwhile keeping under your desktop table, and that is the ready reckoner for the 2015 MEC criteria. And this is the wheel, and it gives you a very good guidance as to which method is aptly prescribed for which particular patient. And this is also an app which women can download and try to avoid unwanted pregnancy in a given cycle, and the woman will always know the exact chance of pregnancy. If she downloads this, she can perhaps consult the doctor in time. This is again a very interesting technology advance, is that the app can be downloaded onto the mobile screen. The WHO MEC criteria, this is one of them, which shows fertility, Friend or Glow or Clue or Kindara. All of them can tell women in their natural cycles what is their risk of pregnancy, approved by FDA as a digital form of contraception. This is what I was talking about. This is a tool which can be downloaded onto the mobile screen. This is for the healthcare providers to make it very simple for them to prescribe contraception based on the MEC criteria. The tool also provides a comprehensive list of medical conditions or characteristics for which all methods of contraception may be safely recommended to women, provided there are no additional health concerns, and it includes emergency contraception as well, and recommendation on the initiation and continuation of use of 9 common types of contraceptive methods are covered in this tool. So it's worthwhile getting used to utilizing this tool from our mobile screen. This is the the emergency contraception initiative, the counseling tool, which was floated by ECEC, the European Consortium for Emergency Contraception. And this includes all the 4 methods today, which are available for EC, and the copper IUCD, the levonorgestrel EC, and the ulipristal acetate are the 3 modern methods which are included onto this disc. What is the incurrent and inconsistent use of contraception, and when should EC be considered, is a knowledge which all practitioners should have. And any of these ongoing methods like the COCs, the combined ring, the vaginal ring, the POP, IUD, and LNG, when they are at risk of failure, the woman is exposed to the risk of unwanted pregnancy through an unprotected sexual intercourse. And if you consider the example of DMPA, then an unprotected sexual intercourse is defined as an act of intercourse which happens 16 weeks after her last injection. So on and so forth. Every method can fail, and EC is there to cover the woman's risk for unintended pregnancy. And the latest one of them is ulipristal acetate. The new pill, 30 milligrams single day, gives protection up to 5 days following the unprotected intercourse as compared to 3 days from what LNG was providing earlier. It works better in obese women. It has got a unique effect on the dominant follicle. It actually delays ovulation and works in the most fertile period when LNG is no more effective. So it is worthwhile including it in your list of prescription. And also be aware that whenever we are prescribing ulipristal acetate and following it up with another contraceptive method of hormone, which is the ongoing method of contraception for the woman, then you need to give an interval of at least 5 days before starting or resuming the following methods. For example, if it is a combined OC pill, then a 9 days gap after the 5 days of ulipristal acetate needs to be given. And in this period, probably a bridging method like a barrier is recommended to completely remove the risk of unintended pregnancy. This is the MEC criteria, very friendly for the currently available EC. And I think even in women who are with HIV and AIDS and on antiretroviral therapy, it's very much possible to prescribe them EC. There's hardly any contraindication. Let us come to the subdermal contraceptive implant, which 11 million women are using around the world, but not so much in India. That is because it has not yet come into the public basket, and it is the top choice for women more than 30 and less than 20 years, especially popular with teenagers in the developed world. So let us remember that this is something which we need to incorporate into our contraceptive practice. The latest one is Implanon NXT. This is how it looks. It contains etonorgestrel, 68 milligram of it, and it gets released in a slow way for 3 years after insertion. It's a preloaded single-use applicator, single rod, biodegradable, and with a thin EVA membrane, and 25 to 30 microgram is released per day. A very simple insertion technique. After adequate training, every healthcare provider, including paramedical staff, can learn how to insert, and especially gynecologists, they may find it very, very simple and easy. And these are the insertion techniques. The advantage is that it is a LARC, very reversible. Immediately the woman conceives after removal. Cost effective if you consider the 3-year duration, about 3,000 rupees, and plus insertion charges might give some benefit in other menstrual symptoms. So this will be the insertion, and these are the removal. For paucity of time, I will not initiate the video here. No routine follow-up is required, but if the woman cannot feel the implant, or there are any skin changes, or it's or pain at the site of insertion, she could come. When is it contraindicated? The WHO MEC 3 will be when there is a history of breast cancer, unexplained bleeding, or women are on certain medication like anti-epileptic, anti-tubercular, antiretroviral, because unlike the emergency contraception and unlike the DMPA injections, there is some drug interaction possible of the etonorgestrel, and we need to be careful in these women. If there are problems of follow-up because of impalpable or deep implant, imaging can very easily identify, and with the help of a surgeon, it can be retrieved out. I do not feel that a misplaced implant is a big problem in today's insertion and removal techniques. In special situations as well, for women living with HIV, it is very much possible to prescribe with the MEC category 1. And let us also stand informed that implants feature among the UN endorsed contraceptive implants as one of its 13 life-saving commodities. So as far as reduction in maternal mortality is concerned, the female condom, the implant, the emergency contraception have the same value as perhaps for maternal health is oxytocin, misoprostol, magnesium sulfate. They have the same value and the same ability to prevent maternal mortality through prevention of unintended pregnancies. Injectable contraceptives, of course, all of us are very familiar with 3 monthly injections of DMPA. It has got benefits beyond contraception as well. It is a woman's best friend, very confidential method, safe, easy, highly effective, and of course it's a long-acting reversible, no effect on lactation. So the currently one, what is available is being used by 14 million women worldwide. It is 150 milligram every 3 months. But how about reducing the dosage and looking at reducing the side effects and the delay of return to fertility of 10 to 18 months? And that should be possible and also the fear about the effect on bone density can be mitigate this effect and can be reduce this concern by floating another injectable, which is 104 milligram. The same mechanism of action, now approved by DCGI. It is subcutaneous, so very, very friendly in the times of pandemic, where one prescription over the teleconsultation platform and the woman can go on injecting herself every 3 months and be protected from unintended pregnancy. So 104 milligram every 12 to 14 weeks, approved by DCGI as well as US FDA, single dose, single passage, very friendly to uniject this injection subcutaneously. Just one session of training may be required. Very friendly MEC criteria for DMPA, even in women with medical disorders and who smoke, who are breastfeeding, etc. And even in younger girls, it is possible to prescribe this. So we shall go ahead. Hardly any contraindication except for currently ongoing breast cancer. So then this is the newer injectable, which will be available very shortly in India with the estradiol cypionate and 25 milligram of medroxyprogesterone. Let us see the oral contraceptive pills, which have evolved so much over the past few years. The few studies that report menstrual symptoms found that the extended cycle group fared better in terms of symptoms of headache, genital irritation, tiredness, bloating, and menstrual pain. So all these hormone withdrawal symptoms are much friendlier when we give a shorter hormone free interval, and that is what happens when we use the 24/4 instead of the 21/7, and we can avoid a lot of suppression of pituitary ovarian axis and unnecessary withdrawal bleeds, which might be heavy. So 24/7 has the advantage of shortening the 7-day cycle and also the number of cycles which happen, and also improve the woman's tolerance of the OC pill. The newer estrogens also deserve mention today because estetrol especially is a native estrogen and is more physiological in action, and it is perhaps going to yield a lesser risk.
Doctor,
yeah.
3 minutes left. Thank you.
Yeah, thank you very much. I will finish in 3 minutes. So this is the extended cycle regime, which is used with seasonal and continuous regime for 365 days, which with no break, with fewer periods, diminished breakthrough bleeding, and very useful in women with endometriosis and chronic pelvic pain, who deserve contraception as well as pain relief. Vaginal rings like Nuva ring and of course Enovera in the US are very friendly for women, very conducive to reproductive autonomy of women because the method is entirely in their hands. They're user friendly, contain very low doses of hormones. Of course, they need to get used to the feeling of the foreign body in place, but that hardly takes a few months, and there is a rapid return of fertility. We are all familiar with LNG IUS. When I said injectable is the woman's best friend. I would say LNG-IUS is the gynecologist best friend as far as contraception is concerned. And today we look at a lot of new types of LNG-IUS, especially for younger girls, unmarried girls. A thinner variety are available, and of course, we need to source them and use them for our women. The patches are still in their nascent stage in India because we are not yet through the phase 3 trial, but we expect that in the near future, patches will come, the transdermal system as they are called. One of them is also the spray, and this is a very thin patch which is in trial right now, the TCDS. We are hoping that it will come, and this is a microchip which soon can come into being, because what is better than a chip which can sense the hormone release and which can also tell the woman which are her days of risk. These are the newer advances in the barrier contraceptives, the galactic cap, the origami, the diaphragm, and of course the female condom. There's been, I think there is not a better innovation than the female condom for a friendly reproductive health method for the woman. The male hormonal contraceptives just deserve a mention in passing, because all these forms of testosterone have not stood the test of time or are not free of side effects.
Time up, ma'am.
Yes, I think I shall end. Yeah. Thank you very much for the time given to me. And I must say that family planning alone can bring more benefits to more people. And pregnancy by choice doubles the joy of parenthood, and choice also celebrates She the Star. Thank you very much.
Thank you, madam,
Thank you.
for this excellent presentation. And we have been enlightened by your presentation regarding contraception. And I think all the delegates and everyone who joined in must have benefited immensely with this. Let us move to our next topic for today. And it is none other than Colonel Dr. Sanjay Singh speaking on complications in monochorionic twin pregnancy.
Nirav, we don't have a voice.
Simplified overview of the challenges. Good afternoon, everybody. I propose to cover my presentation under following heads. The incidence of multiple gestations has risen rapidly over the past several decades due to the widespread use of assisted reproductive technologies as well as increasing maternal age. As we all know, multiple gestations are associated with an increased risk of both fetal and maternal complications. Monochorionic twins especially may develop unique and potentially fatal complications because of the shared placenta. Hence, they require diligent surveillance and care throughout the pregnancy. The problem areas associated with monochorionic twins, which pose a challenge in managing them, that I am going to touch upon in this presentation, are unequal placental sharing, TTTS, TAPS, TRAP, and monoamniotic twins. Unequal placental sharing results when one twin receives a greater share of the placenta relative to the other. This results in selective growth restriction or growth discordance. Filamentous cord insertion is often seen in these cases. Amniotic fluid levels may remain normal or slightly abnormal. Unfortunately, no intervention can reverse the pathology, and hence regular twice-weekly surveillance based on biophysical profile, umbilical artery Doppler, and non-stress test are recommended. This surveillance is required to assess the health of the fetus and to time interventions such as admission, steroid administration, and delivery. Monoamniotic twin is another challenging type of monochorionic pregnancy. Its incidence is 5% of all monochorionic twins. Though it can be diagnosed at a very early period of gestation, still the perinatal mortality rate is very high. This is because of several complications including cord entanglement. There lies the importance of close monitoring of the fetuses with USG and CTG from period of viability. Elective cesarean section is recommended at 32 to 34 weeks period of gestation after injection corticosteroid for fetal lung maturity. Twin reversed arterial perfusion sequence, also called TRAP, whose incidence is 2 to 3% of the monochorionic twins occurs between a well-formed pump twin and a recipient acardiac twin that lacks a heart and other structure. Based on what all structures are absent in recipient twin, it may be acardius acephalus, acardius amorphous, and acardius malacephalus. It is caused mainly by a large artery-to-artery anastomosis where donor twin pumps deoxygenated blood under pressure to its co-twin. Since donor twin pumps blood for self and co-twin, it results in cardiomegaly and high output failure. The management is based on volume of the recipient twin. There is a formula to calculate the volume. Expected management is offered for a case where volume of the acardiac twin is less than 50%. If the volume of the acardiac twin is more than 50%, the treatment of choice is radiofrequency ablation of the communicating vessels. The prognosis remains poor in cases of monochorionic monoamniotic acardiac twins and acardiac twin with a volume of more than 50%. The twin-to-twin transfusion syndrome, also called TTTS, is a dreaded complication that constitutes 10 to 12% of the monochorionic twins. In this, one twin becomes large with polyhydramnios and another remains small with oligohydramnios. It is said to occur because of the normal vascular communication in the placenta. To understand this abnormality, let's first know what is the normal vascular communication in a monochorionic placental tissue. So in pic A, we can appreciate that there is a single monochorionic placenta which has been shared by two fetuses. In pic B, we can see that there are three types of vascular communications, two superficial and one deep. Two superficial communications are located on the surface of the placenta. These are arterioarterial or veno-venal. Both are bidirectional, means blood may flow from one twin to another and vice versa. These two communications, however, are devoid of capillary bed communication, means blood cannot be oxygenated. Third communication, which is located deep inside the placenta, is an arteriovenous communication wherein blood flows unidirectionally from one twin to another. Most importantly, this communication occurs through capillary bed so that the deoxygenated blood inside the artery may go as oxygenated blood to vein. Now let's focus on pic C. Normally, blood from twin A flows to twin B through deep arteriovenous anastomosis. The extra blood that has reached to twin B from twin A is balanced by flow of blood through superficial communication from twin B to twin A, and nothing happens. This is known as balanced vascular anastomosis. Now let's see what happens in abnormal communication. Over here we can see that though the deep arteriovenous communication is there, the superficial arterioarterial or veno-venal communications are missing. As a result, blood can move from twin A to twin B, but extra blood cannot be balanced by blood flow from twin B to twin A, as there is no arterioarterial or veno-venal communication. This unbalanced vascular connections results in overload of blood in twin B and its incident consequences. So what are the consequences? The donor becomes small in size, and hypovolemia causes the release of substances such as vasopressin and renin-angiotensin system that leads to less urine production and consequently oligohydramnios. On the other hand, the recipient becomes large in size, and hypervolemia causes release of substances such as brain natriuretic peptide and atrial natriuretic peptide that increases urine production. This forms polyhydramnios in recipient sac. As the disease advances, the vasopressin and renin-angiotensin system passes to the recipient from the donor through vascular connection. This decreased urine production in the recipient and excess fluid accumulation in recipient body finally leads to overload, causing congestive cardiac failure and fetal hydrops. So how do we diagnose it? There are two diagnostic criteria. One, presence of monochorionic monoamniotic pregnancy, and two, presence of polyhydramnios in one sac and oligohydramnios in another. Because TTTS affects 15% of the monochorionic twin, Green Top Guideline 51, published in 2016, advises the screening of TTTS by regular USG in high-risk cases is starting at 16 weeks and then 2 weekly. We look for the biometry and maximal vertical pocket and visualization of the fetal blood. Once TTTS is diagnosed, it is very important to assess the severity of the disease. Quintero staging system classifies TTTS in 5 stages. In stage 1, there is a Oli-Poly sequence and urinary bladder of the donor is visualized and the Doppler study is normal. In stage 2, donor bladder is not visualized, however Doppler study is normal. In stage 3, there is Doppler abnormality noted. In stage 4, hydrops develops in one fetus or both fetuses. In stage 5, there is death of either of the twins. There are various treatment options for TTTS that include expectant management, which is applicable for Quintero staging 1 and 2, laser ablation of vascular anastomoses, serial amnioreduction, septostomy, and selective feticide. However, as per Green Top Guideline 51, TTTS presenting before 26 weeks should be treated by fetoscopic laser ablation rather than amnioreduction and septostomy. For laser ablation, a fetoscope is inserted inside the recipient amniotic sac to identify all vascular communications between two fetuses, followed by photocoagulation of all of them. This functionally separates the placenta into two separate pieces. This is referred as dichorionization of monochorionic placenta. There are two types of laser ablation, selective and non-selective. In selective type, all vascular communications between two fetuses are coagulated, while in non-selective type, all blood vessels crossing intertwin membranes, whether communicating or not, are coagulated. Non-selective type is associated with higher pregnancy loss rate, and that is why the selective type is preferred. Whereas the survival rate of both the fetuses is 50%, the survival rate of only one fetus is only 30%, and 20% of the cases there is complete pregnancy loss. Another option of treatment is amnioreduction. It involves removal of amniotic fluid from the recipient sac. This will reduce the intra-amniotic pressure and reduces the risk of preterm labor. This is performed when maximum vertical pocket is more than 8 cm. Amnioreduction does not treat the underlying pathology, and this is likely to require repeated procedure. Moreover, this procedure also has complications like preterm PRM, preterm labor, chorioamnionitis, and placental abruption. Another treatment option is septostomy. This involves intentional puncture of the intertwin membrane, theoretically leading to equal pressure into amniotic sac. But generally, septostomy has been abandoned as a treatment of TTTS as it has no significant therapeutic advantage. Moreover, it may cause disruption of intertwin membrane, resulting in a monoamniotic pregnancy. Other treatment options include selective reduction of the fetus. It may be a reasonable option in certain cases like pregnancy less than 24 weeks with severe unequal placental sharing with marked discordant growth, major malformation, and evidence of brain injury before or after laser therapy. Coming to delivery, it should be conducted between 34 to 36 weeks period of gestation and earlier also if there are concerns. One course of steroid should be given before delivery, and mode of delivery is often by cesarean. Twin anemia polycythemia sequence occurs spontaneously in 3 to 5% of the monochorionic twins and iatrogenically in 10 to 13% of the cases after laser ablation of TTTS. TAPS occurs due to a slow transfusion of blood through very small arteriovenous vascular anastomosis. This leads to highly discordant hemoglobin levels between donor and recipient twin. However, there is no substantial difference between the twins in either size or amniotic fluid volume. It is diagnosed by middle cerebral artery peak systolic velocity. If it is more than 1.5 mom, it suggests anemia, and if it is less than 1 mom, it suggests polycythemia. So what is the treatment? In case where immediate intervention is not required or laser surgery is not an option, close monitoring is required to be done. Blood transfusion to the anemic donor twin is option, but it is temporary treatment that can possibly worsen the condition of the recipient twin with polycythemia. Fetal laser surgery of communicating arteriovenous anastomosis is definitive treatment. However, it is highly challenging because these anastomoses are extremely small. So what is the take-home message? Let's remember that monochorionic twins may develop unique and potentially fatal complications. Thus, it is important to know them and diagnose in time. A diligent surveillance and appropriate interventions may save many such affected fetuses. It goes without saying that most of these cases will need expert care of a feto-maternal specialist and a neonatologist. Thank you, ladies and gentlemen. Thanks for your patience hearing.
So yes, once again, great congratulations and thanks to Colonel Sanjay Singh for his wonderful talk. Over to the chairpersons for the expert comment and for any questions which they have, Professor Pradeep Sambre sir and Dr. Sanjay Das.
Any question from the audience, someone so far?
Yes. No questions from the audience.
Okay, but I will congratulate all the three speakers, Dr. Sanjay, Dr. Atul and Dr. Shobha. Only thing I just wanted to know about the use of general anesthesia from in this thrombocytopenia and liberal use of say operative delivery, something like that. Because our residents get worried when a patient of thrombocytopenia is in labor or she requires a section. That's a problem many times. And second thing is for our Shobha, doctor, she has covered, I think, excellently all the current contraceptive available. But I think that awareness among the people, among the women, about the availability of these contraceptives is more important. Yeah. Because working in a little in a government setup and with the poor patients, this availability and the knowledge may be little lacking. So to make more availability and health program and counseling sessions for this, so the use of these contraceptives will be little more on a higher side.
Yes.
Yeah. Do you agree, Dr. Shobha?
Yes, 100%. And we have a program from Family Welfare Committee which is called Jagriti. And through this, we do mass education. And our attempt is to actually make people aware of options available in the public basket first. Because that is what comes at a low cost.
You covered implants, but are you sure they are being used still?
Yes, sir. Yeah. So MSD has floated the product about 2 years back, and we have conducted training sessions. About 800 implants have been inserted so far in the past 2 years. Yes.
Okay, because
it is ongoing.
Gone little out of use for some time.
Yes. It is in a new form and more friendly and more useful. Yeah.
Because your WHO tool was excellent, and Uriprestol and this.
May I come in, sir?
Yeah.
Sir, I'm Dr. Seth. So, adding to the implants, what Dr. Shobha was talking, in fact, we too in FMC have started using these implants since about 1.5 years. In fact, one of the graduate residents has been given that as a dissertation.
Yeah,
That
we
is
had
number
long
one.
ICMR trials long back, but
Yeah.
currently I
Yes.
think in our college also it is not so.
Yes, sir. That was the earlier version that was
Okay.
Implanon R,
Yeah, no.
and that was next earlier version that was about in 2004, and it concluded
right.
and it was published ICMR.
But I'm very happy that you have covered almost all the things available in the world also. Only thing we have to make our women and the couples availability,
Yes.
use of the emergency contraception, etc.
Yeah.
Okay.
I
Yes,
thank
Dr.
Sunita
Yeah.
and team for
Yeah.
keeping this subject. Thank you.
Yeah,
I
of course.
would
We
like to
almost
answer
thank
that
her.
question that you brought out regarding thrombocytopenia and anesthesia, sir.
Yeah.
So, what I tried to say in my talk also that, sir, in the vast majority of cases of thrombocytopenia in pregnancy,
Right.
what we are dealing with is actually gestational thrombocytopenia. And in that, the platelet count usually varies between, somewhere around 70, 80,000 and more.
Yeah.
And we do get concerned when we get a report like that.
Yeah.
But what I tried to emphasize, in fact, so many young people would be there in the audience, is that we should consult the hematologist, we should keep the anesthesiologist and
Right.
pediatrician will do. However, it is not a reason to get worried and does not require platelet transfusion, etc.
Okay. We must be worried about PPH also. Always keep a watch on the postpartum hemorrhage.
We should, sir, but again, those cases will not be too many. That is what.
Okay. Yeah, nice. But I congratulate you also. It's a very emergency topic. It's a serious problem coming with us. And now cases of gestational thrombocytosis. Though you said it's nothing to worry about it much, but still our residents are little worried when they manage such cases. Okay. Thank you, doctor, and thank you, Amol, for nice conduction of the session. And
Thank you,
of
sir.
course,
Thanks a
Sunita and
lot.
our team deserves a lot.
Yeah.
Dr. Sanjay Das, for your comments and for your questions.
All the speakers are fabulous. Really, I thank Sunita and her team for the organizing is such a wonderful conference, e-conference, I would say. And everybody is really impressed with all the speakers. Regarding Dr. Shobha Gudi is a fantastic presentation and covered all what my previous speakers have told. I do also admit this thing. And especially she highlighted only the newer contraceptive. Whatever it means, usually they cover all the topics, so the time is very constant. But she has nicely covered only the newer things. Once again, congratulations, Dr. Shobha.
Thank you.
Yeah.
Thank you.
Regarding the thrombocytopenia, really we hardly see any cases, and though rare, but we should not afraid of it. Rightly, she has pointed out all the management, and our PGs should be tuned up to tackle the situation at the earliest. Regarding the MC twins, really, it's a difficult task. It should be ideally diagnosed earlier so that you can apprehend the complications and do accordingly. So it is the need of the hour to diagnose how early you can diagnose perfectly, and then only you can proceed and you have a chat with the clients and the guardians and all these things. Thanks all. Thank you all, and thank you all chairpersons.
Thank you, Dr. Sanjay.
Thank you, chairpersons, for your excellent expert comments and questions. And we move to the most interesting part of today's, that is the quiz. So I would request you all to stay glued and attempt for the quiz.
Hello, good morning, dear friends. I welcome you all.
Part of the conference that we are having quiz sessions, 5 minutes quiz after every session, and there are excellent prizes to be won in each hall.
To this POGS Star OG Global Virtual Conference, and this is quiz time. I welcome to this Star Hall first quiz. You need power only when you want to do something harmful. Otherwise, love is enough to get everything done. And it is this knowledge and love which we want to spread amidst this COVID times. I welcome you all to Pune, although virtually. Pune is a cultural and educational capital of Maharashtra. It's a city which stands out amongst all. So is the organization Pune Obstetrics and Gynecological Society since its installation in 1953. I welcome you to the first quiz. The rules for the quiz are you have to choose the most correct option. Prizes will be given to the person answering correctly and quickly on the first come first serve basis. You have to WhatsApp me as soon as you see the question on this number 8446206075. One person will be eligible for only one prize in this hourly quizzes, and all can participate in the mega quiz, which is scheduled today evening at 5 p.m. in the Obstetrics and Gynecology halls. So, are you ready for the first question? So, Implanon, a long-acting reversible contraceptive, can be placed effectively for how many years? A. 1 year, B. 3 years, C. 5 years, D. 7 years. So your time starts now. You have to answer it correctly and quickly. You don't have time to refer to the internet because I have already started receiving responses on my WhatsApp number 8446206075. Last 10 seconds to go. So the answer is about question is about Implanon, a LARC, which can be used for how many years? The effectivity remains for how many years? Thank you. We'll see you in the second quiz. Thanks for participating.
After this innovative quiz session, let us move towards the next session of the day, and it is going to be a panel discussion on first trimester losses. And to chair this session, we have chairpersons Dr. Dilip Kamath sir. He is a ex-president of POGS, patron member and the backbone of the POGS society, Dr. Ritu Joshi and Dr. Indu Agarwal, senior gynecologist and obstetrician from Jaipur and Chandrapur respectively. We welcome the chairpersons, and it's a privilege to have you here. I would request Dr. Vaishali Chavan madam and Colonel Tony Jose, moderators for the session, to take over and start with the panel discussions with the panelists Dr. Uma Wankhede madam, Dr. Siddesh Iyer, Dr. Indrani Roy, Dr. Monica Gupta, Dr. Pankaj Mate, Dr. Amrita Tandon, and Dr. Mandakini Pradhan as the panelists. Over to the moderators to start with the panel discussions on first trimester losses.
Thank you, Dr. Amol, for the introduction, and we would like to thank the entire team, President Pune Obstetrics Gynec Society, Dr. Sunita Tandlwarkar, General Secretary Dr. Vaishali Kordenai, Clinical Secretary Dr. Nilesh Balkawde, and the entire team. It's indeed an honor to be present here for the 36th installation STAR OG Global Virtual Conference. It's a huge mega event. And with me, along with all the esteemed, my co-moderator, Colonel Tony Jose, and all the esteemed panelists and chairperson, we thank you for this. So I would like to start my screen sharing. Yeah, can I share? This is a very interesting topic. As we know, early pregnancy losses, it is a huge sorrow and cause of anguish for the patient. And there are many factors to it. Usually the early pregnancy losses, there's not a single factor. It could be multifactorial, it could be environmental, genetic, endocrine, thromboembolic phenomena, so many factors. And you do the entire gamut of all the investigations for RPL, and at the end you find more than 50% cases are unexplained RPLs. And then as a clinician, you are faced with these patients who are in so much of sadness and anger. And then how do you answer them? They say, will it happen again? What can I do to avoid it? Why did it happen? What should I do? And when we face these helpless patients, how to go about it? So as clinicians, we are going to keep this panel discussion very clinical oriented. I request all the panelists to be precise. We have about 50 minutes time to cover the entire topic. And this is going to be a guideline based. We are using ASRM, HRA, RCOG, all guideline based discussion, and we hope to give good take home messages. So coming to the first case is 36-year-old A2 lady. She's had 2 spontaneous first trimester abortions. USG has confirmed it. And she's been married for 3 years. Last miscarriage was 6 months back. Otherwise, she's had regular cycles. There's no medical, surgical morbidity, no addictions, nothing. On examination, she's obese. BMI is 29. She has acanthosis nigricans. She has no calyptoria, thyromegaly. And coming to the husband is 40-year-old, mesomorphic, smoker, and yes, he's alcoholic also. So my first question is to Dr. Amrita. Dr. Amrita, are you there?
Yes, Dr. Vaishnavi.
Yeah. So Dr. Amrita, what do you feel? Are we dealing with a case of RPL, and how would you like to define RPL?
Yes, so we are dealing with a case of RPL in this case, and recurrent pregnancy loss is now defined as the loss of spontaneous loss of clinical pregnancies when there have been 2 spontaneous losses. So evaluation should definitely start after 2 spontaneous losses. Earlier it was considered as 3, but now we start the evaluation after 2 spontaneous losses of clinical pregnancies.
So, do you mean if there is an ectopic pregnancy or molar pregnancy, will it come in the definition?
No, so ectopic molar pregnancies are not included. All clinically confirmed pregnancies by ultrasound should be included in your definition of recurrent pregnancy loss. Yeah. 2 is the number that 2 recurrent pregnancy losses, and they need not be consecutive because they have shown that it doesn't matter whether they were consecutive or they happened over.
Yeah, you're absolutely right. So let us look at what guidelines say and how they define. So ASHRAE 2017 says spontaneous demise of a pregnancy before viability, and here they have taken viability as 24 weeks, loss of 2 or more pregnancy, and this can be non-consecutive also. Like you said, Dr. Amrita, ectopic molar pregnancy do not come in this definition. GTG 17 says spontaneous loss of pregnancy before the fetus reaches viability. And ASRM 2013, here there's a slight change in the definition. Loss of pregnancy should be documented either by USG or by histological diagnosis and clinical evaluation after 2 losses. But if there are 3 or more losses, it could be counted as definition in the definition for epidemiological studies. I request moderator with me, Colonel Tony Jose, to take forward the panel discussion.
Yeah, good morning. Now, taking on from here, when you have a case like this, the first issue is counseling. So, I would like to ask Dr. Nikhil. Dr. Nikhil is there on the panel? Dr. Nikhil, are you there? I think he's not there. Dr. Pankaj? Yeah, so once you have a patient like this, how do you like to counsel this particular patient? Counseling regarding the risk factors, lifestyle changes, what is the prognosis that you envisage for this patient? So how do you like to go about? Dr. Pankaj, I think, is not there on the panel. I would request Dr. Uma to take on the case.
Yes, good morning. Naturally, this couple will be very worried because they've already had 2 abortions, 2 losses. So we will first reassure them, counsel them that the risk of the 3rd one is low. Second, that they'll have to go through a gamut of investigations before we can, help them out for the next pregnancy. The third is that they'll have to undergo lifestyle modifications, like this lady is obese. and she looks as a case of PCO, so she'll have to lose weight. We'll have to readjust them a lot because they'll be obviously very worried.
Yeah, very true, ma'am, because the counseling involves an assessment of the risk factors, and the age of the patient is considered to be one of the most important risk factors, and the risk of recurrent miscarriages, it has been seen that it is directly related to the age of the patient. And as Madam has rightly said, modification of the risk factors, modifiable risk factors are basically lifestyle related, smoking, alcohol, caffeine intake, and the prognosis is based on that. So the initial counseling definitely requires to involve all this, right? So that is where the evaluation of the patient starts. Thereafter, you require detailed investigation of the patient. I request Dr. Vaishali to continue.
Thank you, sir. So now here we have this patient with this particular history. Now we need to move forward with the investigation. Now we know the etiology behind RPL. There's, like I said, then multifactorial. It could be endocrine, be, immunological, it could be infection, could be environmental. So many causative factors could be there. So for this particular patient, how would you like to investigate the patient? Any of the panelists can take this question.
Madam, hello, madam. This is Dr. Siddesh.
Yes.
Madam, before the investigations, I would just like to add one point that when we are counseling the patient, probably it is worthwhile telling them that 1 in 10 pregnancies anyways miscarry. So it is a possibility that there is a 1 in 10 chance that she would have had a miscarriage just because of some factors which are not known. Secondly, I would also like to tell her that even if she's had like 1, 2, 3 miscarriages, still the 4th miscarriage ke baad bhi there is a possibility that 60 to 70% chances that she will go ahead and have a healthy pregnancy in future. So this probably reassures and puts the patient at a better footing just before we start even explaining what all investigations need to be done, because she is a little more relaxed and settled before we give her the gamut of investigation.
Right. So would you like to enumerate the investigations? Anybody on the panel?
Can I come in, please? I'm Mandakini.
Yes.
This is, I fully agree with Dr. Siddesh that we need to look at whether the glass is half full or half empty. So to put that in this patient's perspective, that you have got 80% chance that your subsequent pregnancy will be successful. This becomes a very, very positive note to the patient. Even if we do, before planning any investigation, we must tell them that doing all investigation after 2 or 3 spontaneous abortions, in 50% cases we will find out a cause, in 50% we will not find out a cause. This sentence should be very, very clear to the patient, to the couple. And hence, we assess the economical status of the patient. All patients may not be of equal status, and then we can offer them a set of investigation which is treatable condition like diabetes, thyroid, and next is antiphospholipid antibody syndrome. So these are treatable condition that can be done first. The second line can be, say for example, uterine malformation or a karyotype of both the couple. So this can be put as our second line of treatment. If a patient wants to do everything, then you can do all these investigations together. Coming on to hereditary thrombophilias, investigation for hereditary thrombophilias, yes, we keep it after all these investigations are normal. And looking for tuberculosis, TORCH and bacterial vaginosis, they will not be doing recurrent spontaneous abortion. That may be one abortion that could be because of this infection, and hence this may not be a part of a recurrent spontaneous abortion. So we need to tell them and then get ahead and go do the test. For APLA screening, we probably can discuss what are the tests for APLA screening.
Yeah. So right, Dr. Mandakini, we are going to take each of this topic and each of the investigations in detail as we proceed. And like you said, you know, some tests are absolutely essential, like diabetic, thyroid, imaging, maybe genetic testing, and there is a gray area, controversial, whether infections, especially hereditary thrombophilias, or the male needs to be tested with higher testing, immunological screening. All these are a little bit of gray areas. So we proceed further, and we will be discussing each of it in details. I request Tony sir.
Yes, yeah. Let's start with a controversial topic, because there's a common scenario. A couple like this walks in with a TORCH report saying that TORCH is positive, and nobody knows what is to be done. So, Dr. Siddesh, do we have to screen for infections? If yes, which one? And do touch upon the issue of TORCH.
So I think TORCH infection, frankly, has currently been proven beyond doubt that there is no role for screening of TORCH infection. Because if she is infected, then whatever has happened has already happened in the pregnancy, and it has been done and dusted. She would have been an IgG by now, so that will not cause an effect on the future pregnancies. So TORCH is a strictly no, definitely. Tuberculosis per se may not cause a recurrent pregnancy loss. It may actually cause a difficulty in conceiving in the first place. Hence, tuberculosis screening also is not recommended. There are a couple of studies which actually talk about bacterial vaginosis and chlamydia screening, and frankly, there is no role of going on and testing each of these individually for a recurrent pregnancy loss.
Yeah, very true. So the take-home message is TORCH is out as far as screening for recurrent pregnancy losses are concerned. Tuberculosis, maybe. Bacterial vaginosis definitely has got a role, especially in second trimester losses and in preterm labor. I think that should be the take-home message as far as infections are concerned. So now we go on to the next issue, again with a lot of controversies. That is the issue of thrombophilia testing. So again, Dr. Siddesh, Dr. Vaishali, you would like to continue? We are at thrombophilias.
Yes, sir. So, talking about thrombophilias, again, I would like to address this question to Dr. Siddesh. I think he has special interest in this topic. So, when we talk about thrombophilias, there's inherited thrombophilias and acquired thrombophilias, and basically the acquired thrombophilias are the ones which cause this entire syndrome of and the entire syndrome. What is important about it is knowing in depth the syndrome and how it is preventable. And this is one part of RPL where, when we address this situation, it is entirely treatable, and if left untreated, there's only 10% chances of live birth, but if you treat it, then the live birth goes as high as 80%. So thrombophilias, like we said, are congenital, acquired. The question here, Dr. Siddesh, is how important is thrombophilia screen, and would you like to screen for both acquired and inherited as well?
I think here, after 2 pregnancy losses, we would screen for thrombophilia definitely, because as you put it, it is one of the most treatable causes that we currently have. You have the diagnosis of a thrombophilia and you know what to do with it. So at least you are clear on the path that how we are going to move forward. So since she's had 2 pregnancy losses, as per the current criteria and the guidelines that are available for diagnosis of antiphospholipid antibody syndrome, 2 or 3 or more pregnancy losses of the first trimester, 1 or more loss beyond 10 weeks of a morphologically normal fetus, and if we've had a preterm birth due to placenta-related diseases like severe preeclampsia, eclampsia, HELLP syndrome, then she falls into the criteria of antiphospholipid antibody syndrome. Now, the idea of treating or diagnosing antiphospholipid syndrome is that we need to have a laboratory test also, which is the lupus anticoagulant test and the anticardiolipin antibodies. These are the 2 tests that need to be done. Earlier it was said that according to the Sapporo criteria, that 6 apart, if you have a test which is more than 99 percentile, then she is probably infected. But now, as per the Miyake criteria, it has come down to 12 weeks apart. So we need at least a test which is minimum 3 months, that is 12 weeks apart, to actually fit her into the criteria of an antiphospholipid syndrome. The third one, that is anti-beta-2 glycoprotein 1. is also being done, but then frankly, as per the S3 guidelines, it is in the gray zone whether to do or not, because they say that there may be a role of testing anti-beta 2 glycoprotein 1, but LAC and ACLA are definitely the diagnostic criteria tests. Now,
Dr. Sudesh, I've got a question for you.
Yes, sir.
What do we do with a patient who has got only one report and she is conceived?
Now that she has conceived, frankly, it is a gray zone as to what we will do, whether to treat or not to treat. In my clinical practice, I think every pregnancy is important, and there are two ways of treating it. There are people who start aspirin, there are people who start aspirin and low molecular weight heparin, and there are different strategies for starting as well. People start after the onset of cardiac activity. There are people who also start the moment you have a positive pregnancy test. Now, how aggressively we want to treat it. Now, both schools of thought are widely acceptable, that you wait till the cardiac activity, just start aspirin before, and the moment you see cardiac activity, you go on and put on the LMWH. But then there are also people who say that each pregnancy is precious. There are different schools which say that the moment you get a positive pregnancy test, you please put her on low molecular weight heparin once a day, subcute injection, easy to give, no monitoring required, and you can take it forward from there. Now, if there is one loss, I would probably
what you have said is absolutely right. So now we want to move on to the dose. So what is the correct dose of aspirin or the heparin which you are using, or is there a role for steroids, immunoglobulin, and like you said, periconceptional early pregnancy? So any of the panelists would like to take this question?
Low dose aspirin actually, which is as per ESHRE, they have said 75 to 100 milligrams per day, can in fact be started periconceptionally and then continued throughout pregnancy till about 35 to 36 weeks. Low molecular weight heparin is started as soon as per the new guidelines, again, as soon as there is a positive pregnancy test, like Siddesh said. But of course, there is a lot of gray area. Some people do start it after the cardiac activity.
I think the minute pregnancy test is positive is the right time to start.
The right time to start LMWH.
Exact dose.
Because 40 mg is what I prefer to give in my clinical practice. But anything ranging from 40 to 60 mg is something that is
depending upon the patient's weight,
history, and weight. Yes.
And Dr. Amrita,
yes.
There's a question from my side. Would you like to start this particular management empirically? Suppose
No.
you would not.
In the absence of an APLA or in the absence of any known history of thrombophilia or presence of any inherited thrombophilias, it is not indicated to start low dose aspirin as well as LMWH, because it is not shown to improve the results of a recurrent pregnancy loss vis-a-vis an expectant management. So I would not.
Before we go into the guidelines, we'll be flashing the guidelines also. I would like to know from the other panelists also. Would you wait for 2 reports 12 weeks apart for a definite diagnosis before it is started, or the benefit of doubt goes to the patient? Dr.
On my side,
in case you can.
Yeah. The benefit of doubt goes to the patient.
Dr. Indrani?
Without a definitive report, I would not start low molecular weight heparin.
I want to see that even with one report, I start. Like if there's no time, etc. I do start.
If the report is positive, definitely even I will start. But without a report, empirically, I am not going to start low molecular weight heparin.
So the consensus here is without a positive report, absolutely no role. But if there's one positive report, Dr. Uma says yes, she will go ahead. Dr. Indrani says no, unless there are 2 positive reports.
No. One report I will start, but not without. Empirically, I am talking about empirical. I don't think I want to start low molecular weight heparin.
So
we should see what the guidelines say. Dr. Vaishali, we should see the guidelines.
That women who fulfill the laboratory criteria that we have seen and have a history of 3 or more pregnancy losses, you should give low dose aspirin, 75 to 100 mg per day, or low molecular weight heparin. And with 2 pregnancy losses and a positive report, treatment only in the context of clinical research. Many a time we see that patient, clinicians give either only aspirin or only heparin. Now that again is wrong. You need to give both the things for a successful outcome. Yeah, and absolutely there's no role of corticosteroids or immunoglobulin. Like the revised Sapiro classification, I think Dr. Siddesh has already covered this. Test should be positive on 2 or more occasions, at least 12 weeks apart. And yeah, inherited thrombophilia, should we screen or not to screen? What does the panel say?
Dr. Siddesh, I think Dr. Siddesh.
I think there is no need to directly screen for inherited thrombophilias unless there is a strong family history that there is a thrombophilia in the family, because needless to say, it is an expensive screening. And
Dr. Siddesh, you're not audible. I think there's some problem with your audio.
Now am I okay, sir?
Yeah, sure. Yeah.
I'm saying it is not necessary to screen for inherited thrombophilias unless there is like a family history or there is a history of venous thromboembolism that has happened in the past, because needless to say, it is an expensive test that we may have to do.
Yeah, so you are
also inherited hemophilia generally do not cause such early losses.
True. Can I add on to it, Mandakini? Yes, I fully agree that if there is a family history of thrombophilia, and what family history means is first degree relative. So the patient's sibling or the parents have history of thromboembolism, that constitute the family history. And if the patient herself had a venous thromboembolism, then only we will go for inherited thrombophilia. It is not, these days, these are not very expensive tests. It is available in less than 1,000 rupees. So it can be done, but it's not changing too much, and it is not responsible for causing recurrent spontaneous abortion of such early duration, as has been pointed out.
As you have very clearly told us, routinely not to screen, that is what ASHRAE, GTG, SRM guidelines say.
Yes.
But yes, if there are additional risk factors, you should go ahead and do the testing. Tony sir, I hand over to you again.
So there is no doubt that anatomical abnormalities account for a considerable number of recurrent pregnancy losses. But we are discussing this case where it is a pregnancy loss in the early first trimester. Should we screen for anatomical abnormalities in this particular patient? Dr. Uma, if you can take on this.
Yes, I think so. Septate uterus is a very important cause of first trimester abortion. So I would definitely evaluate for septate uterus by a 3D sonography or a hysteroscopy.
Yeah. Okay. So, what would be the anomalies that you'll look for?
Yeah, the different anomalies could be polyps, could be fibroids. If she has a history of acquired cynic Asherman's, but generally the early losses are generally due to septate uterus, which is quite common, saying 10 to 15%.
Yes, Dr. Uma.
So I will go in for a 3D sonography or a hysteroscopy or a HSG.
What is the investigation that you would prefer in your practice, ma'am? Because 3D sonography is not that freely available in many places.
In my practice, so a normal TBS and a hysteroscopy.
Okay. So hysteroscopy
MRI I don't do so often.
Okay, there is a cost factor involved. There is the issue of availability. So, Dr. Mandakini, ma'am, what would you prefer in your practice to rule out anomalies of the uterus?
Frankly speaking, I go ahead and do a PS examination to see for 2 cervix. Okay, so it starts from there, and then we do a 3D transvaginal sonography and rarely a hysteroscopy. So a good
rarely hysteroscopy.
Yeah. So that is, and never MRI. Most likely, like I don't remember ever I have gone ahead and done an MRI for assessing uterine anomaly. Very rarely, once probably. So,
suppose you have a congenital anomaly of the uterus, would you require any other evaluation? Would you go ahead and do any further evaluation for this patient?
Hysterolaparoscopy is when we are trying to evaluate simultaneously if there is history of infertility. So both the things combined in the same sitting becomes easy for the patient.
And to add in some cases, HSG may also have a role. In certain cases, I think we'd still like to do an HSG, but the patient's affordability is not there. So combined ultrasound and HSG might give us some clue.
Sonography, anybody has done it? It's documented to have a TVS with saline.
Saline infusion sonography or sonosalpingography?
Salpingo.
No.
Personal experience, no.
Personal experience, no.
So it is basically done by gynecology. There are a few radiologists who do this particular investigation. Possibly that is why it is not. So the panel agrees that even in first trimester recurrent pregnancy losses, there is a definite role for ruling out anomalies. And that is what the latest guideline also says. The preferred technique is 3D ultrasound, depending on availability and experience. MRI is not recommended as a first line option. HSG definitely has got a very low priority as far as the diagnosis of uterine anomalies is concerned. Sonohysterography fares better. So the guideline also says that if you detect an anomaly, you have to rule out the renal tract, including the kidneys, because there is a possibility of associated anomalies. So I think the panel is on board as far as evaluation for ruling out the anomalies is concerned. Now we come back to this particular patient. Please go back to the previous slide, please. So this patient incidentally had an HSG with a suspicion of a subseparate uterus. No 3D ultrasound has been done. So the issue is, suppose there is a septum or a subseparate uterus. Would you advise going in for a resection of the septum in this particular patient? The history of one pregnancy loss, a possible septum. Is resection of the septum going to be of any help? Dr. Uma?
She's had 2 losses and I will investigate her thoroughly. If I don't find any other cause, then I may go for resection. Though guidelines don't say.
What is your opinion from the rest of the panelists? Presuming that there is a subseparate uterus, would you go in, Dr. Amrita, would you go in and resect the septum?
Although there is no evidence that suggests that resecting a subseparate uterus may 100% improve the pregnancy outcome, but in clinical practice, I would do a hysteroscopy and I would do a resection of the septum in this patient because she has had 2 recurrent pregnancy losses. Plus, HSG is showing a possible cause, so I would like to correct it.
I differ over here. I differ this. The pregnancy outcome improves if she has a subseparate uterus. As the pregnancy number advances, the outcome will improve. Second is, we tend to forget the morbidly adherent placenta that we come across after doing such surgery. So with all these, and the guideline also suggests that there is insufficient evidence to go ahead and do a surgery in such case. So,
yeah, so the evidence recently is insufficient, so we actually don't know whether it actually helps or not. So as per the present evidence, there is no evidence of benefit. So you are justified in not doing it. The problem is it is often difficult to convince a patient. So the patient,
here the counseling of the patient here is the most important thing, actually.
which should be very, very important. So suppose this patient, you have permitted her to conceive again, you haven't removed the septum. would you consider cervical encephalage in this patient if she conceives? It is a hypothetical question. If she conceives, is there a role for a prophylactic cervical encephalage in this patient? Uma ma'am, would you like to?
No, I will not offer cervical cerclage. I'll do repeated sonographies, and if sonography suggests insufficiency, then I will go in for a cerclage. Otherwise, routinely, no.
Sir, I also agree with Uma. So unless it is a documented ultrasound mid-trimester between the cervical length less than 2.5 centimeter with a past history of 2 losses, then that is the indication of cervical cerclage. So ultrasonographic surveillance is very important, and documentation of cervical length of 25 mm or less is very important. So we'll move on to the next topic of this discussion, metabolic and endocrine evaluation. So coming to Dr. Indrani Roy, Madam, would you like to screen for endocrine disorders for this patient?
Yeah. This patient, like the history and what the examination we have got, she is an obese patient, the BMI is high, and one more important factor, she has acanthosis nigricans, which also goes in favor. So definitely I would like to do a full evaluation of her. I would like to screen her thyroid status. I would like to see her HB1AC to rule out diabetes, then hyperprolactinemia. And of course, she might be a case of PCOS. So that might again cause a luteal phase defect. So all these screening procedures. And one more thing is her obesity. That is one of the things which will have a poor outcome. The obesity has a negative impact on the reproductive health. So all these investigations would definitely like to investigate. And endocrine causes are actually almost like 8 to 12% comprises of RPL, endocrine causes.
Yeah, so the little slight controversy here is what all hormones to test and what all not to test. So prolactin testing is not recommended unless the definite history. Ovarian reserve testing is also not routinely recommended. LPD testing is not routinely recommended, and androgen testing is also not routinely recommended. So what hormone testing is actually?
So thyroid and diabetes, basically we have to rule out the thyroid profile, complete thyroid profile, and the diabetic profile, that we need to rule out. Auto and thyroid autoimmune antibodies might be there. So the full thyroid profile and a diabetic rule out has to be done.
Absolutely. And wherever indicated, if there's oligoaminuria, then you have to do a prolactin. You need to. So this is what ESHRE 2017 and ASRM 2013 means. These guidelines recommend, tell us what to be done routinely. And these endocrine disorders, once treated, can give a very good success rate. So thyroid, when you treat, the success rate, the outcome is very good. The same goes for hyperprolactinemia, the same for uncontrolled diabetes. And now coming to a little controversial zone is progesterone. So luteal phase defect, will you do a investigation of, for the LPD, and what is your opinion about the progesterone?
I think I will not directly put an investigation, but empirically progesterone, though I will definitely give. But one thing I want to be clear, I will not put her in multiple, because we've seen a lot of people giving multiple progesterones in one form, either oral, injectable. I will stick to one form of progesterone. I will not overload her with all 3 types of progesterone.
What does the panel say? What is the opinion of the panel about progesterone?
So actually in unexplained RPL, progesterone also has not been shown to have a definitive role, but empirically, I think all of us would start a progesterone as soon as the pregnancy test comes positive, or from if we are doing an ovulation induction as luteal phase support, and then continue it beyond the pregnancy test. After
and also progesterone has a immunomodulatory
effect. Yes.
So for the immunomodulatory effect also,
it is as per the guidelines, recommendation, and the empirical use. So it is a sort of a gray zone.
I think, madam, here the PROMISE trial confused everyone, saying that progesterone is of no use, or there is doubtful benefit according to the PROMISE trial. But then there were 2 other studies. One was a Kumaraswamy et al. In 2015, and there was one Kumar et al. In 2014. Kumar et al. Definitely said that there is a role of progesterone in unexplained recurrent miscarriages. So I think we are not wrong in starting even empirical, because there is some evidence to even back starting progesterone. So it's not like on a hunch we are starting
No, we
progesterone.
do not have clear-cut guidelines.
Yes, that is true.
But the message should go that one patient should not be put on oral, injectable, vaginal, because we've seen many, like all three types of progesterone are being put on the patients. So that should be kept in mind. Progesterone has a role, but it should be like, it should be justified in giving what type of progesterone.
Absolutely, absolutely. And I would like to remind the panelists, we are really short of time and we have a few more important topics to cover. So moving on to the next topic, Tony sir.
Yeah, Jared. So there is a lot of availability of genetic tests. Industry is driving it like anything. So is genetic testing indicated in recurrent pregnancy losses? If yes, when? And what is the type of genetic test that you would like to do? Dr. Mandakini, if you can answer this issue. Dr. Mandakini, are you there?
Yes, yes, I am there. Yeah. I was muted. Anyway, so recurrent pregnancy loss is an indication of going ahead and doing a parental karyotype, what is called as a chromosomal analysis.
So you would do it in all patients?
Yes, we do in all patients. 5% you will find balanced chromosomal translocation. And it cost 4,000 rupees for the couple. So, so that is to be done, that is to be, is recommendation. For product of conception, we never do it. A patient who insists on doing a genetic test on product of conception to know why this pregnancy was lost is the microarray, that is written RACGH or microarray testing, but that same money can be utilized for doing a chromosomal analysis of the parent. Why I am explaining is, if suppose your report comes as abnormal from the product of conception, your subsequent mode of action is you go ahead and do the parent testing to know if one of them is a carrier. If the product of conception report comes as normal, then also as a part of testing, you go and do the parental karyotyping. So my test on product of conception is not changing my subsequent mode of action, and hence I differ from doing a chromosomal analysis of the product of conception. Second is product of conception collection into a vial where culture media is there, which is specially procured, is not always available. And the culture failure rate in the lab is as high as 50%. So we may not get a report in that. So spending that same amount of money in parents' karyotype is more helpful for a couple. So we differ from doing product of conception. We definitely do for parents' chromosomal analysis in a case of parents.
What would you do? What would you do if you find a balanced translocation in the parental karyotype?
Yeah.
Does it change your management?
There are two types of balanced translocation. One is balanced translocation between the same chromosome. Say, for example, 21-21 translocation or 13-13 translocation. So in that case, the recurrence will be 100%. In that case, we should use donor gamete or donor sperm or ovum, whoever is the carrier. So there is 100% recurrence. That is a very small portion of the people. Then next is that it depends on the type of translocation. If you find a translocation, then you need to go ahead and do the abnormality in the fetus. The fetus can have congenital malformation, can have mental retardation, or the pregnancy can result in spontaneous abortion. So
it is basically, from what I understand, it has got a lot of implications as far as counseling is concerned, possibly not that much as far as treatment is concerned.
Yes.
So that is possibly what the guidelines also say. Because of paucity of time, I think we'll go straight to the guideline. So as far as the latest guideline, genetic analysis is not routinely recommended. It has to be decided on a case-to-case basis. And one of the oldest guidelines, GTG 17, it says that after the third and subsequent miscarriages, possibly the karyotyping has got a role. So I think we'll leave it at that because of paucity of time, and we'll go ahead to the next topic, which is evaluation of male factor. Yeah, Dr. Vaishali.
Yeah. So evaluation of the male factor, is it necessary, and are immunological tests necessary for evaluation of male factor? Anybody from the panel can take it. Dr. Indrani?
So immunological factor plays a role. I think the proper history of the male partner, the habits, whether smoking, alcohol, and regarding test, certain immunological, like sperm DNA fragmentation test has a role. There has been evidence shows that sperm DNA fragmentation has a role in evaluation of the male factor, which might cause RPL. So I think that is one of the recommendations.
That is what guidelines also say, if indicated, required. Though these are slightly expensive investigations.
Yeah. So you have to customize, no? You have to see, like, the benefit risk ratio, see whether the patient's affordability is there or not, how she's taking it. And other than that, you have to advise lifestyle modification for the male partner.
Madam, how do you counsel this particular couple? You have a male who is a smoker, he consumes alcohol. So that is possibly one of the important facets of counseling too.
Yeah. So I think that has to be properly explained to the partner, like that the reduction in her, the chances of her getting a live birth will have a lot of factor depending on his reduction in smoking and alcohol, which will bring a change in his sperm. So that counseling is a very important role in both the male and female partners, so to get a better outcome.
Right. So now we have run through all the investigations, and now finally we have realized that everything is normal. So we have reached something known as unexplained RPLs. Tony sir, can you take it from here?
Yeah. This is the most common scenario. You've done all possible investigations. Nothing has come out, but the patient keeps on losing her pregnancies. So how do we manage this? Possibly one of the most difficult situations. And that is where we use everything in our armamentarium. So the question is open to all panelists. What do we do right now?
I think the tender loving care is one of the important point here, where counseling, that means it all boils down how you are counseling. You give her a positive feeling that yes, after 2 abortions, there's a chance the third one she will not have that, have again the miscarriage. So the emotional support of, as a doctor, we should be giving to the partner, and of course lifestyle modifications and vitamin D. Vitamin D also has a role. Evidence has shown that vitamin D plays a very important role. So lifestyle modifications, some vitamin supplements, and tender loving care from our side can help the patient give a better outcome.
Dr. Siddesh, would you put the patient on ecospirin?
I think I would put the patient on ecospirin, because when patient is coming to you with such high expectations, I think there is something that they are looking for. There is enough evidence to show that it increases the endometrial vascularity and helps in implantation. I would definitely put the patient on ecospirin. Not on low molecular weight heparin, but definitely ecospirin, yes.
Dr. Uma, your opinion? And thereafter, Dr. Amrita. Dr. Amrita?
Yes, I would definitely put the patient on low-dose aspirin, and I would add a progesterone supplement also for this patient. I would not start her on low molecular weight heparin, but definitely...
So you're talking about the patient after she conceives?
After she... aspirin from before, and once she conceives, progesterone support.
Okay, right. So the patient... Yes.
One more question. Has Dr. Pankaj and Dr. Nikhil joined us? If they have, we can address some questions to them.
Yes.
I don't think they've joined. So just to an extension of what Tony sir has said, now this patient has conceived, and then what to go about. So the continuation of this as a rapid fire round. Now this patient has conceived, just say yes or no, each of the panelists. Progesterone, will you give progesterone?
Yes.
Yes.
Yes. Yes.
HCG, is there any role?
Pardon?
HCG.
Yes, probably yes.
HCG,
Yes.
No.
Guidelines say no.
No, I will not give HCG.
Is there a role here for metformin?
Probably in this patient, because she is PCO, she's a little obese.
Guidelines
I
say
would start.
no. That is what this is a rapid fire to cover.
She
some
may already be on metformin, no, ma'am,
Yes,
because of
I
her
would
acanthosis.
continue
So we
it.
will continue
I
it
would
if she's
continue
on.
it. Yes.
Yes. If a GCT is positive, then metformin. If the
But
GCT
if
is
she's
normal,
not, you should not start new. Vitamin
metformin,
D,
no.
like Tony sir has said, yes, it is important. You can give same thing for folic acid. What about IV immunoglobulin?
No.
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 Any role? Anybody? Steroids? Any role for steroids?
No.
No.
And last repetition of the question: aspirin and heparin.
Aspirin, yes. Heparin, no.
Same. Only aspirin.
Only aspirin.
Sorry to interrupt everyone. 5 minutes left.
Yeah, we are already through. Just to summarize this controversial topic, a topic full of controversies, where there is a lot of gap between actual practice and the available guidelines, as we had seen. So just to summarize the discussion that we have had, recurrent pregnancy loss is any loss of 2 or more pregnancies and definitely requires evaluation. Counseling is a very important part of management of recurrent pregnancy losses, especially if it's an unexplained recurrent pregnancy loss. What the guidelines recommend is an RPL clinic where you provide tender, loving care, which is nothing but counseling. Lifestyle modifications for both the partners. We've already discussed what it involves. And evaluation of the baseline, which we have already discussed in this panel. The role of empirical management is as controversial as ever. And as we have seen, in practice, you are forced to start something. And the idea is, if it is not going to harm, possibly it will benefit the patient. But one should be aware what the guidelines say. And the results are not bad. And that is what the counseling should finally drive in as far as the patient is concerned. So this is just the summary of the discussion that we have had.
Sorry to interrupt
Yes,
you.
Dr. Vaishnavi.
We also want valuable inputs from our very esteemed chairperson, Dr. Ritu Joshi, Dr. Dilip Kamath, and Dr. Indu Agarwal, madam. Please, if our chairpersons can kindly say.
Thank you.
Congratulations, first of all, Dr. Sunita, for the excellent program put up, and congratulations, Vaishali and Dr. Tony. It was you covered all the topics thoroughly. Thank you so much.
Thank you.
Yeah, I would also like to comment on something that I'm very happy that this panel was taken up, but I also feel that in case if we do the CGH microarray, we can actually be able to at least give our patient some kind of a moral support that there was something wrong with the baby, that is why the loss was there. You know, at times they need, like we're talking in terms of TLC, this also sort of becomes like a TLC for her. And then then we can evaluate her more thoroughly, looking into any other maternal cause. Thank you.
Thank you for this wonderful panel discussion. I think we are at the end of the time as told by the organizers. Thank you, Sunita ma'am, for this lovely brooch that we all of us are wearing, the faculty. And thank you to all the wonderful panelists. Thank you especially Colonel Tony Jose. He has been wonderful to moderate this session with you. And thank you, everyone. Thank you.
Thank you. Thank you, everyone.
Thank you so much.
Thank you. And Colonel Tony Jose, thank you so much. It was an excellent panel, and I congratulate all the panelists for doing an excellent job. I have an announcement to make. The winner of the last hour's quiz, and Siddesh, it's a good news for you that you are the winner, Siddesh Iyer. And I request, when you participate in the quiz, please mention the hall, which hall you are contesting from. So that is very important. So once again, congratulating every panelist and Siddesh once more for winning the quiz, and thanking chairperson for this session. It was an excellent panel as usual. Vaishali, you did an excellent job, and Colonel Tony Jose too. Amol, please carry forward.
Yes, thank you for this excellent panel discussion. And now let us move to another interesting session on quiz. So after, as I said, POGS has come out with this innovative idea, and after every session we are having a 5 minutes for the quiz. So I would request you all to participate in this quiz, and let us have our quiz session now.
Hello friends, it's quiz time again. I welcome you to this second quiz session of this hall. I welcome you all on behalf of my team POGS 2021, and they have left no stone unturned to make this event a wonderful event for all of you. So I thank all of them. Under the able leadership of Dr. Sunita Tandurkar, we have been giving you this academic feast in the form of POGS OG Star OG Global Conference. Answer to the first question is implant on a lark which can be effectively placed for how many years? The correct answer is 3 years. I congratulate the winners because winning isn't the everything. It's the only thing. Congratulations once again. Before we go on to the second question, here are rules for all of you. You have to choose the most correct option. Prizes will be given to the person answering correctly and quickly on a first come first serve basis. WhatsApp me on my number the correct answer 8446206075. Remember my number because you have to answer it here as soon as you see the question. One person will be eligible for only one prize in this hourly quiz. However, all can participate in the mega quiz, which has the bumper prizes today evening at 5 p.m. in the Obstetrics and Gynecology Hall. With this, we go on to the second question of this hall. According to the ESHRE guidelines 2017 for recurrent pregnancy loss, following is true except RPL is defined as more than or equal to 2 losses. 3D transvaginal ultrasonography is recommended in all women with RPL. Office hysteroscopy plus imaging is inferior to laparoscopy. D. Severe adenomyosis can cause first trimester losses. So all of these are true except which of the statement? Your time has started. You have to answer it within 20 seconds and you have to answer it correctly and very quickly on my WhatsApp number 8446206075. Remember, you don't have time to refer to the internet as I've already started receiving responses from many of you. Last 5 seconds to go.
So I hope many of you must have answered to this exciting quiz session. And I, Dr. Amol Lunkad, on behalf of POGS, once again thank you all for your participation. I thank the moderators and the panelists for the previous and the chairpersons for the previous session for making it so interactive and knowledgeable for our participants and our delegates. We would be moving to the next session, which is a plenary session.
Thank you, Amol. And thank you, chairpersons, once again. And congratulations, Siddesh, once again. Thank you.
Thank you, ma'am.
the smaller things, fetal Dopplers and all. But when I say mega quiz, telescopes and the CTG machines, you never said no to me. Thank you, Sudeep, for your always, whether you were with MCure or now you are with Zydus, you are always with academics. Thank you so much.
Thank you.
We move on. Ameya, take over.
Yes, ma'am.
Thank you, Ameya.
Nilesh sir, over to you. Thank you, sir.
Yeah. Thank you, Ameya, for the plenary session. I request all of you to log in for the Kaun Banega Star quiz. And we have the AMOX dates announced, which will be a physical conference. And this is a plenary session which will be having 4 keynote addresses from all the stalwarts in the field. May I call upon the chairpersons for the plenary session? We have Dr. Atul Munshi. He is the ex-professor of NHL Medical College, Ahmedabad. We all know his role and visionary role in the FOXY as well. Dr. Arun Fadnis, past president of Pune Gynec Society and award-winning work on the Misgav Ladakh technique. And Dr. Hefziba, who is a professor at Savita Medical College, Chennai, and vice president of Chennai Menopausal Society. So I welcome all the chairpersons, and I request Dr. Atul Munshi to kindly introduce our first speaker, Dr. Sanjay Gupte, sir.
Thank you, Nilesh. I congratulate and thank POGS and FOXY for giving me this opportunity. This star-studded conference, as first plenary session is starting now. And we have got 4 total speakers. In the first session, there will be 2, Dr. Sanjay Gupta and and both of them are past presidents. And we are going to have Dr. Sanjay Gupta, my good friend. I'd like to introduce Dr. Sanjay Gupta. He is FIGO International Federation of Obstetrics Gynecology Ethics Committee Chairperson, past president of FOXY, president of Diabetology in Pregnancy, and a lot of things associated with him. Above all, he's a good friend of mine. He's a very caring and compassionate obstetrician and a patient to the patient and to the doctors. Dr. Sanjay Gupta is going to talk about genomics in pregnancy.
Thank you so much, Atulji. It's good to have such a good friend for chairing my session, and I also thank Hepsizavji and the whole POGS team under Dr. Sunita for having me here and inviting me for this talk. Let me share my the slides first, and since the time is short, I'll directly go on to the topic without any ado. So, genomics and obstetrics and overview. In 1988, Human Genome Project was set up in US, and finally in year 2000, full genome sequencing was achieved. This project required $1 billion, 30,000 computers worldwide, and years of hard work by scientists across the world. All the 20,000 plus genes in human genome and its 3 billion base pairs are now mapped and are available on the internet for comparison and research. This science of genomics has progressed so fast that now one may get full genome sequence done at the cost of just $1,000 and in 2 days' time. If the automobile science is to progress at this rate, we would have had S-Class Mercedes manufactured in 1 hour, and it would have actually cost only 5 cents. So in comparison, you can see how fast this science is progressing. And so in 1950s, it was the atom which was the main buzzword which made a difference and changed the world. In the late 1980s, we had BITE, and now in 21st century, we are going to have the basis, the nucleotide basis, and this is going to be the genomics century. So, fortunately or unfortunately, because of Corona, now even the man on the street knows about something about the mutations and why they are important. And we know that genetics can help us find the cause of the disease, mechanism of disease, and sometimes response to therapy. the genetic issues are not really uncommon as we think. 2 to 3% children are born with a congenital birth defect and by age 18, approximately 8% are discovered to have one or more anomalies. 67% of the population will experience a disease with a genetic component in their lifetime, and if cancer is included, this is 91%. So there are types of genetic disorders that we find in obgynae are chromosomal disorders, single gene disorders, multi-gene disorders, multifactorial disorders, that is polygenic and exogenous factor combined, and somatic cell disorders. Let's look at the chromosomal disorders. Actually, we are well versed with them. Chromosomal disorders are numerical and structural, and of it can be associated with severe outcomes like mental retardation, minor or major structural anomalies. Single gene disorders are caused by mutation in the single gene. More than 12,000 monogenic disorders are now identified. And single gene disorders show Mendelian inheritance. That means autosomal dominant, autosomal recessive, co-dominant, or X-linked, and so on. The examples are of autosomal dominant, very many of which we know: achondroplasia, acute intermittent porphyria, polycystic kidney disease, and so on. And autosomal recessive disorders are albinism, cystic fibrosis, etc. X-linked inheritance are interesting, because they are due to presence of the recessive genes on X chromosomes. Here, the females act as carriers, and males are affected almost exclusively. An affected male can pass on the disorder to his grandsons through his unaffected carrier daughter. Then there are multi-gene disorders and also multifactorial disorders, which are basically the NCDs, diabetes mellitus, hypertensive diseases, and obesity that we talk about. So let's come to the genetic tests which are available to us today. And we are going to talk only of these highlighted on the left side, because they are the major ones. All others are there, but we won't have time to go into the details of these other tests. So karyotype, we are well versed with it right from our medical days, medical student days, and it is a systematized arrangement of chromosome pairs in descending order of size. It is used to analyze the number and structure of all the chromosomes, but what we need to know, it provides only a low resolution screen for chromosomal abnormalities. On the other hand, chromosomal microarray, this testing looks for duplicated or deleted chromosomal segments, sometimes called as copy number variants or CNVs. These include microdeletions and microduplications of chromosome segments, which are too small to be seen under the microscope, but may contain multiple genes in those segments. Most abnormalities of chromosome number, including Down syndrome, can be diagnosed, and most unbalanced rearrangements of chromosome structures can also be identified by microarray testing. Microarray testing is ideal for product of concept of testing, as it can be done even with dead tissue. That is, even in misabortions we can actually do it, and it doesn't require culturing of the cells. Next generation sequencing. The whole genome sequencing refers to sequencing the entire genome, both the non-coding region, that is introns, and coding region, that is exons. This method gives us detailed coding of all the genes up to every single base pair. In both clinical and research settings, NGS is used to find a single genetic variant relevant to a specific disease or a trait. Sanger sequencing is used to identify a point mutation and small deletions and insertions in single genes. It is highly accurate and is commonly used for single gene testing and also for validating results obtained through next generation sequencing. In 1975, Frederick Sanger actually discovered this, and this has enabled the unraveling of genetic code and revolutionized the molecular biology, and for which he got the Nobel Prize. It can be cost effective, especially if we are looking for a known gene, for example, BRCA gene. Now let me give you a comparison, by these Google map that will explain a little bit more about these tests. The karyotype is like a low resolution Google map where you can see in our country there are 28 states, and those 28 states can be compared to 23 pairs of chromosomes. If you have a better resolution map, then it will also show us the various 30,000 cities of India, and it is like microarray showing us 3 million CNVs when we look at it through microarray. Then if you go further, then this now better resolution map of Google will show us 300 million households actually in India. It is like the next generation sequencing showing us 300 billion bases. So as the resolution improves, then we get better and better picture of the NGS, and we are able to diagnose in a better way. So after all this essential background, let's come to the practical aspects. Previously, if somebody mentioned genetics, people used to say, why to study it? We cannot change the outcome. Now that things have changed totally and are changing faster. So where can we as obstetricians and gynecologists use these tests effectively? So these are the tests now available to us. We are going to talk only of the obstetrics tests today. So, oncogenomics, pharmacogenomics and nutrigenomics is something I'm not going to discuss today. So let's start with the preconceptional testing. Preconceptional testing basically is the carrier testing. That means a couple planning a natural pregnancy or ART treatments may opt for carrier screening for common genetic diseases. They may want to make sure that they are healthy so that the baby doesn't have any problem. Carrier test screening should actually ideally be done always for sperm donors and egg donors. Then when there is history of congenital pathology in a partner or a relative, carrier testing is important. History of previous abnormal child, history of family disease like polycystic kidney, ADHDs or autism, history of consanguinity, really a bad obstetric history like previous couple of stillbirths and so on. And carrier screening can really always be done by NGS. It requires NGS for doing this study. So let's look at genetic tests for infertility now. So first, if we look at female infertility, there can be causes can be chromosomal aberrations, and which can be looked at from by karyotype, or there can be gene mutations for which, of course, we require either next generation sequencing or Sanger sequencing. So if we look at where the genetics is responsible in female infertility, in premature ovarian failures, polycystic ovarian syndrome, poor and hyper responders, endometriosis, adenomyosis, leiomyomas, everywhere now genetic plays a role. So if we look at genetic defects in premature ovarian failure, again there are chromosomal anomalies and there are various mutations like MFR1 mutation, FSH receptor mutation, and so on. And now we can actually through microarray and next generation sequencing actually look at these and find out whether this is the actual cause in that particular given patient. But if we take the polycystic ovary syndrome, then it is a complex trait and it involves many candidate genes. So genes involved in androgen production may be responsible, genes involved in secretion and action of insulin and insulin resistance may be responsible, or genes involved in functioning of pro-inflammatory cytokines and cytokine receptor genes can be responsible, or gene involved in GT action and regulation can be responsible in actually causing this polycystic ovary syndrome in a particular patient. And recently now, the Kavanaugh and all have studied and they have found that AMH and AMH receptor 2 polymorphisms are very much associated in PCOS morphology and even antral follicular count, and they modulate FSH sensitivity. So now, when the AMH is low, or even if AMH is normal and PCOS is there, we may have to look at these polymorphisms in particular genes. Then in poor responders also, there are chromosomal abnormalities and genetic variations. And we can actually look for these and find out the real cause of these. So practically, what are the tests that we can do presently in female infertility? Of course, we can do the karyotype, we can do CFTR, mutation, then FMR1 gene mutation, Fragile X syndrome, FSH receptor gene, CYP11A gene, aromatase gene, CYP19 gene, and MHR2 gene. And of course, most important, which many of the IVF consultants resort to, is the endometrial receptivity array. And here, actually, especially where there has been a implantation failure in IVF, this is something very important, and this can be readjusted, treated, and success rate can be improved in this situation. We don't have time to go into the importance of every single gene, but this is the overall picture that we have, and we can study and actually sometimes modify these genes to improve the outcome also. So let's look at the male infertility now. Male infertility can be affected genetically at the gonadal development level, or gonadotropin action receptor level, or gametogenesis level, or organ malformations level, and also sexual behavior. So what are the tests available to us? For karyotyping may be done in non-obstructive azoospermia as well as severe oligospermia. But now a step further, we can do Y microdeletion, non-obstructive azoospermia, and especially in many severe oligospermias, we are now finding that the various regions of the Y chromosome, ZA, ZB, are many times are deleted, and the treatment can vary according to if you get FA deletion, or is it B deletion, or is it FC deletion. Accordingly, the treatment actually can vary in these persons. And CFTR gene mutation is important for obstructive azoospermia, because most of the time there is actually the absence of vas deferens, and CFTR also leads later on in life to cystic fibrosis. Androgen receptor mutation is important, and something that is practically and very usefully done is the DNA fragmentation and sperm methylation, especially again when you're doing intrauterine inseminations, and if it's not working out, before going into IVF also you can do DNA fragmentation, sperm methylation, and again important thing is, so we can actually modify if we find these methylations in that particular person. And mind you, smoking many times lead to these problems too. Then now let's go on to the further tests apart from infertility. And what are they? The pre-implantation genetic diagnosis called as PGD, which includes embryo biopsy procedure and is indicated when both parents are carriers of a single gene or autosomal recessive disorder. One parent is a known carrier of single gene. Then one parent is potential carrier based on family history of such inheritance. One parent is a carrier of chromosomal rearrangement, or a previous child has been diagnosed with genetic or familial disease. Then this pre-implantation genetic testing, as you know, is of two types. One called as PGT-A, which is meant for aneuploidy, to detect chromosomal aneuploidy before embryo transfer. Advanced maternal and paternal age, RPL, RIF, and severe male factor infertility would be the indications. PGT-M screens for single gene monogenic disorders, and PGT-SR for structural rearrangements. So now what is important is not only these PGT-A, PGT-M, and PGT-SR tests are actually practically available, but the non-invasive PGT-A is also available to us, and here we only have to use the fluid from the culture medium and extract DNA and work on that. So that is going to be a boon for the success of IVF and choosing proper embryo in IVF in very, very near future. This is already being done even in our city. testing of products of conceptors. This should be done in all cases now. Miscarriage by karyotyping, fish, microarray, preferably CGS, microarray, NGS should be done, and maternal contamination should be ruled out by PCR test, and it helps in confirming genetic etiology in many cases of RPL. So now, after this we can go on to the prenatal genetic and genomic testing. So here NIPT, then test for fetal growth restriction, RPL, syndromic anomalies in fetus, RH sensitized patients, unexplained still, and other research tests are important. So let's look at the prenatal cell-free DNA testing, or NIPT. We know that now that NIPT is a much better test for trisomies 13, 18 and 21, and it can give us a result as much as 99%. So now even the SCOG and SCMG are routinely recommending this test, and I think we can also shift, rather than doing and spending patients' money again and again on the double markers and quadruple markers, with NT directly NIPT can be done and we can get better results. NIPT is also important in RH sensitized patients when the parental RH genotype is determined to be heterozygous or is unknown. And now we are looking even at extended NIPT with NGS so that we can get more and more diagnosis of monogenic disorders, and so that's why NIPT is going to be more important in future. Then if you look at the newborn screening, hundreds of tests can be done in newborn screening. We don't do all these tests in our country, but there are now places like Stanford in USA where all the babies, these tests are done. As soon as the baby is born, and the record is maintained for future reference. So if we come to the genetic causes of recurrent pregnancy loss, in RPL also now testing is available for otherwise unexplained cases. Single or multiple panel testing for evaluation of RPL can contain factor 2 prothrombin gene mutation, factor 5 Leiden mutation, MTHFR mutation, CREB5 gene mutation, sperm methylation, and balanced translocation. It helps us in diagnosing the actual etiology, providing the risk for the offspring in future, and maybe if at all going in for prenatal diagnostic test as an option. Recently, these two genes, THBD gene and FGA and MMP gene mutations have been recognized as specific, more specific genes, of course, in mice for repeated pregnancy loss and are being investigated in human pregnancies. Gene panels are sets of genes that are sequenced as a group. The group is selected because mutations of any of the included genes can produce clinically similar diseases or disorders of the same class. This is also called as the target sequencing. Target sequencing means sequencing of any part of a genome for which alignment back to a reference genome is possible. So as you can see here, the small panel, large panel, depending on that the depth of resolution is decided, and this is useful especially in multigenic or multifactorial disorders. So
kindly summarize in 2 minutes.
Yes, in 2 minutes it will be over. It's exactly 17 minutes right now. I'll finish in 2 minutes. Preterm, now the preterm labor is also, we have the panel of tests now, and recently even timing of the gene, the timing of labor can be accurately seen with this HAND2 gene. In preeclampsia now we have genomic testing. In gene cardiomyopathy there are genes, and if you diagnose this you can help in preventing this, and there are candidates for genes for the FGR and this thing. So as one can see, all aspects of obstetrics is now getting covered by genomics. So these are the practical tests. You can take the photograph of this and find out that these are the practical tests that you can do in practice now, starting from preconception tests, right from NIPT's test for fetal RAS. Obviously everything cannot be covered in such a small talk. So, but genomic science is really at an accelerating state. I truly envy the young researchers and clinicians amongst you, because you are going to have this new tool in your hands, like the present generation had the ultrasonography and scopies, which is going to help you in treating your patients much more efficiently and knowledgeably and with much more satisfaction than we could ever achieve. For those who want to know more about this exciting science, you may avail of free online course by registering on this link on Green Array Lab. I have devised this course especially for the youngsters who are interested in this particular field, and then we can have discussion and go through all the details of what we discussed. Thank you very much for your patient listening.
Thank you, Dr. Sanjay, for an exhaustive and excellent account of our very difficult topic. You made it so simplified that we know about diagnosis part, the management part, and whatever prognosis we can do. I know that lots of questions will be there, but time constraints. So we'll go to our next speaker, Dr. Jaideep. And somebody will
Dr. Munshi, thank you so much. I'm sorry to interfere a little bit. Such a complex topic, such a beautifully simplified, and there is no short of time. We have kept the time after the plenary session both. We are going to have 10 minutes for discussion.
Okay.
Thank you so much, sir.
Thank you.
It's so important topic.
I request to put up the questions to Sanjay Gupta sir before we move on to the next talk. We still have 2 minutes left.
I'd like to ask one question. You talked about NIPT and RH incompatibility. How does it help?
Right.
RH isoimmunization, the role of NIPT. We are using
this is basically in patient who is a sensitized patient.
Yes.
Then in sensitized patient, by looking at the cell-free DNA, we can actually find out, the blood group of the baby and find out whether it is negative or positive also. So, if the baby is negative, we don't have to worry about even if the patient is previously sensitized.
We started this session 5 minutes late, so I request to have more questions, please. Dr. Gupta, can I ask you one more thing? Usually for a recurrent pregnancy losses, especially those were very early pregnancy losses, we suspect from they probably may be the genetic losses. So do we advise a single gene you are suspecting, or you just advise parental karyotyping, or we ask for the microarray? How do we guide them and asking them?
If we are doing the POC testing, then we should be doing the microarray. So we will know whether in that particular POC, whether there was any abnormality. But many times, it's kind of unexplained, so RPL. Then we have to go through that gene panel that I described to you, is because it can be factor 5, factor 2, or now one gene called a CREB5 gene has been really pinpointed towards repeated pregnancy loss. Then we have to look at the sperms, and there many times you find that the sperm methylation is there, and that's why. And this is important for all of you IVF specialists also, because if the sperms are not good, your embryos are repeatedly going to be not so good or not get implanted, and this can be done. And sperm methylation gets affected by lifestyle. Now we have even obese husbands, diabetic husbands, smoking husbands, alcoholic husbands. So there also we have to look at.
I totally agree with you, and I saw your one point of a DNA fragmentation also for a RPL. Nowadays we should be. So when do you like to give a carry-on message that when we talk about the parental karyotyping, instead of just a gross parental karyotyping, we should be advising the whole spectra for really?
Absolutely, because karyotyping is a very gross study, as we as I showed in those Google Maps. It's a gross study, and if you have to go into the details, you have to go for microarray or carrier testing. That means you have to use NGS. So people have to now wake up to this, and so that we get better results. When these things are available, comparatively the cost is reduced. So why not? This.
Absolutely. Yesterday, how we talked about obstetric one step at a time. I think in advising for a RPL, unnecessary advising 14 weeks losses with thrombophilias when we have at 6-7 weeks losses. One should be putting more money into more genetic testing than thrombophilia studies of 14 weeks, and we save the money and cost. Very important carry-home messages, sir. Thank you so much for simplifying and emphasizing.
How about total cost effectiveness?
Yes.
See, for a routine patients.
Right. So, the
recurrent pregnancy loss or karyotyping, whole thing you want to do.
Right. So the karyotyping cost around 2,000 rupees now, or even less many times. Then this microarray, depending on the depth of the microarray, will cost somewhere between 10 and 12,000. And the NGS, again, depending on if you select a panel, that's why I showed in between, you have to select the depth. If you're going to go in for whole genome testing, it will cost from 40 to 45,000. But there can be we can have some shortcuts depending on the clinical situation of the patient also.
Most of the patients are ready. Only thing you have to tell them, these are the things available.
Absolutely. Quite right. Quite right.
Thank you, respected chairpersons and Sanjay Gupta sir, for this wonderful talk. I now request our next chairperson, Dr. Arun Fadnis sir, to kindly invite and introduce our next speaker, Dr. Jaideep Malhotra. Sir, kindly unmute yourself.
Yes. Am I audible now?
Yes, sir.
I have great privilege to introduce Dr. Jaideep Malhotra. She had been past president of FOXI, ISAR and ISPAT. She is director of the Rainbow IVF. She is professor in the International University of Croatia. She has been a recipient of many laureates, and she is initiator of this wonderful program, Adbhut Matrutva. Very fascinating motherhood she will be talking about. And I am sure the most important epigenetic aspect in that she will emphasize on.
Thank you, Arun, and very good morning to all of you. Thanks, Sunita, for this wonderful opportunity, and congratulations for a wonderful conference. Friends, as you have already seen, she is the star, and if you see here, that's our star. We are the custodians of she, who basically her health depends on us. And as obstetricians, as I said, we are not only considering just the medical part of pregnancy, but our commitment is towards future healthy generations. And so this talk is going to be dedicated to the future healthy generations. And I'm really looking forward to each one understanding this concept and then maybe modifying your practices so that the time which we are spending today, the impact is going to be basically not on this generation, but on the future, at least minimum of 2 to 3 generations. And that is the kind of impact our practice can make on. Let us face the facts now. We have almost close to about 130 million births globally. And if you see here, almost 56 million of them have maternal anemia, 42 million have maternal obesity, 26 million have maternal malnutrition, and about 21 million have maternal hyperglycemia, and 8 million have hypertension. And we were discussing all this in this conference and many conferences for decades. And basically, we have understood that, yes, we need to have control on these. But we have to also understand that not only these conditions increase the risk of an adverse outcome in a pregnancy, they also increase the perinatal and morbidity and mortality, but it gives us an opportunity to identify both the mother and the offspring at high risk of future diabetes, obesity, hypertension, cardiovascular disease, and stroke. And that is something which is very, very important for me to make all of you understand that that's something which we have to impact. Now, we have all understood that there is an early origin of non-communicable diseases. We've all understood that even this figure is rising. Almost about 41 million people each year succumb to NCDs. And if we look at our own country, now the normal average figure of anyone in the world succumbing to NCDs or non-communicable diseases is about 55 years. But in our own country, this is about 45 years, which is a decade earlier. So you can imagine the impact. Secondly, if you look at the figure of diabetes, just diabetes, 77 million out of 88 million in the Southeast Asia come from our country. We are the obesity capital of the world. We are the preterm birth capital of the world. Maximum number of preterm births happen in our country. And along with this, if we look at the under 5 deaths in India, 68% of the under 5 deaths in India are due to child and maternal malnutrition. Now, why am I saying all these things? We have understood the scope of, let's say, the perinatal and the prenatal care as much, because long time back with the thalidomide, we understood, yes, certain drugs have to be restricted in pregnancy, especially in early pregnancy. We understood with folate and iron deficiency that yes, micronutrients also have a role to play in the outcome of a pregnancy. But I'll take you a little further today. Now, this is a story from a small country of Gambia, where the study was done in 3 Gambian villages. And what did we find out here was that people who are born in the wet or the hungry season were 10 times more likely to die prematurely than the people who were born during the dry or the harvest season. Now, what was important for us to understand that the immunological regulation of these children and the adults actually was totally different in the 2 seasons. And what also we understood was that the children who were born at that time during these seasons had different weight, they had different head circumference, they had different methylation patterns, and even the epigenetic changes in their lymphocytes and their hair follicles basically indicated that this is the lineage which they're going to carry on into the future generations too. So this is what we understand now today, that there is definitely a fetal origin of adult diseases. Barker's theory has been discussed, dissected. But what we have to understand is today our understanding between the genetics and the environmental determinism is basically now changing because of our increasing knowledge of epigenetics. And we have to understand that epigenetics today plays a huge role in this determinism. And look at these mice. Now, if I just ask you which one is the healthiest, all of us will say, oh, this one's the healthiest. But if I tell you this one is the healthiest, because this one is carrying a gene called agouti, where is basically this mouse is born to a mother who actually ate more DNA methylating foods. Now, this is something which has to be understood, because these epigenetic changes actually not only regulate this life, they are actually passed on apart from the DNA, and they will affect the future generations. And that is something which is very, very important understanding today. We learned again a lot from Dutch hunger winter in the 1940s, where, you know, Audrey Hepburn was born during that period. And we know her as a beautiful actress, but we don't know that she suffered from anemia, respiratory illnesses, and edema. All her life she had clinical depression. And further studies on people who were born during that period confirmed that those people were at least 2-fold more rise was there in the coronary artery disease in the people who were there born during that period. And also there was an increased history of breast cancer. On further dissection, it was seen if the exposure was in the preconception period, infertility resulted in those people. And first, second, and third trimester led to a lot of NCDs later on in life. So we do understand today that undernutrition, overweight, obesity, hypertension, hyperglycemia, they're all very commonly associated problems in pregnancy, and they do affect the outcome of the pregnancy and also the fetal programming. Now, how does undernutrition actually affect? We have understood that whether it's undernutrition, ultimate result will be that the child may succumb to type 2 diabetes or coronary heart disease. Similarly, if it is overnutrition, we know that in the fetus there may be macrosomia, but in childhood, obesity, impaired glucose tolerance test, and NCDs later on in life. And a dual teratogenicity will again have both of these affecting the outcome of a pregnancy and the future generations. Now, this is not new. In 2007, BBC had this wonderful documentary film which said there is a ghost in your genes. Now, what was that ghost? That ghost was the epigenomic changes which were happening side by side in our DNA. Along with the DNA were passed on to the future generations, and they basically explained that this exposure not only affects the first generation, but also the second generation, and may have effects on the third generation also. Now, when we were studying, this important quote from Ian Donald, first 38 weeks spent in are allegedly, the most protected environment of amniotic sac, and will have a much larger impact on our life than the next 38 years. But today, if I tell you that antenatal care is also too late, it is too late to prevent any kind of birth defects during the critical period of teratogenicity. It is too late to prevent implantation errors. It is too late to restore any allostasis. Now, and that's where the concept of prenatal care or preconception care is very, very important. And again, this is confounded by when we inverted this pyramid of care. Now, today we understand that it's not only the early first trimester, but it's the preconception period which is much more important. And along with the preconception period, we have in this pyramid a basement of postnatal care, which is also equally important. So if you see on the time invested and the outcomes, you'll understand that if we invest time in the preconception care, the best outcome and best value is something which will be generated. And also what is important is that in this period when gametogenesis is taking place, if you see here, the environmental, lifestyle, genes, and reproductive disorders can have an impact on our future generations as disease and disability. So what is important today? That 3 months or 12 weeks prior to conception to about 8 weeks post-conception is the most important period where we can bring about a lot of changes which will influence the organization of a lot of diseases in our later life. So periconceptional influence can actually affect the DNA, epigenome, mitochondria, metabolism, placentation, organ development, every possible thing. And with two things, one is DNA methylation and the second is histone modification. And these are very, very important because they actually leave a lasting legacy in our future generations. So we need to really understand that it's not only the medical aspect which we are considering, we have to consider many other things, because there is a strong association of not only the mother's BMI, but also the father's BMI on the pregnancy outcome, on the infant's neurocognitive development, on the, if you just look here, on the effects of obesity and diet on the eggs. This is a normal egg, and this is what high-fat diet does to the egg. There's lipid deposition here. Similarly, lipids and sugars, they alter the mitochondrial activity. Once the mitochondrial activity is altered, the whole aspect of fertilization and outcome will be altered. And similarly, micronutrients will impact the DNA modification. And that's again something which we have to understand. So just look at this picture here. That's a normal mitochondria in a normal egg in a woman with normal diet. But look at this with a high-fat diet. Now the outcome of these two is not going to be the same, and that is something we have to understand. Similarly, lot of times we're not able to explain why pregnancy losses are happening. This woman is absolutely all right. Men's weight also has a lot of impact on the pregnancy losses. There's increased pregnancy loss if the partner's BMI is higher. And we have to also understand that the paternal obesity is also a contributor to an impaired glucose tolerance test in the babies or in the offsprings. So both the partners have to be healthy and in an optimum health for a good outcome, not only in themselves, but also in their future generations. So here we have the impact of prenatal, perinatal, and childhood factors. But if you see here, maximum impact comes from the pre and the early natal factors. Let us now look at another aspect. Now, we have understood that if a woman suffers from gestational hypertension or hypertensive disorder of pregnancy and preeclampsia, definitely adverse effects are there in the offsprings. But we have also understood that between hypertensive disorders of pregnancy, the offspring health outcomes, there's also an increased risk of cardiovascular disease in the babies which are going to come. So it's not only the mother, but also the future generations who will suffer. Similarly, we have understood if gestational diabetes happens during a pregnancy in a woman, she has twofold higher risk of developing type 2 diabetes later on in life, and also metabolic syndrome and cardiovascular disease. But what we have to further understand is that children of these patients are also at high risk of developing type 2 diabetes and obesity, and that too in early life. So we need to prevent this from the beginning itself, and that cannot be done once gestational diabetes happens. It has to be in the preconception period that optimization has to happen. Similarly, preterm birth. Now, babies who are born preterm have a higher risk of cardiovascular disease later on in life. So we need to prevent. We can't only just save them, we have to save plus prevent the quality of life later on. And similarly, hyperhomocysteemia and so much. Now, apart from this, we have not focused on the perinatal mental health. And we need to understand that perinatal mental health actually leads to, especially women who have, a lot of depression and anxiety, and they can have it for various reasons during pregnancy. There is an increased methylation of certain genes, and those can actually come up in a very different way in the future generations. And here I have, brought down a lot of very recent studies today, which tell us that perinatal and parental mental health actually before and during pregnancy has a huge impact on the child's behavioral and cognitive outcome. Now, these are very small things which will not need much time from our side, but will have a huge impact on our future generations. Now, maternal stress is something which can actually lead to a lot of problems in the child. And here, this is one of the latest studies which has come up this year only. It increases child sleep problems after birth. So a lot of children who are very cranky just after birth, you can understand what they've gone through during that in the pregnancy period as far as their maternal mental health was concerned. Now, domestic violence, again, now this comes in the perinatal and mental health, but can tell you leads to a lot of behavioral problems in the future generations. So we must address them. And pregnancy is one opportunity which actually gives us, and we are so lucky as obstetricians that we get an opportunity to meet a patient at least 4 to 10 times during pregnancy. And we get a lot of time and our staff gets a lot of time to interact with her at various levels. And if we could reduce during that period her stressors, we will be actually reducing a lot of intergenerational chronic diseases along with mental and other health problems. So we have to understand that this is one very high quality intervention which is related to maternal and child health services, which will actually help us achieve several objectives with far-reaching health and economic benefits, especially for our future generations. So we need to understand this. But as I understand we are very challenged on time. We are not able to give the time of our consultation as required. Time may be 15 minutes, but we are able to only give about 2 or 3 minutes for consultation, and we are unable to actually even assess the patient during that consultation period. So that's why sometimes we become robotic and we just do what is minimally required to take this pregnancy to a successful delivery. And that is not the aim. I think all of us who are really committed obstetricians who understand this. Now, how can we really go ahead and modify this? So we need to just modify the way we practice, because this is a very small opportunity which can actually be a beginning of great achievements for our future generations. And we as obstetricians cannot lose this opportunity, because we are good doctors. And what are good doctors? Good doctors are a gap or a bridge between science and society. So we need to actually, whatever we observe, record and tabulate, we need to identify and modify our practices so that the outcome in our patients is much, much better. And I'm sure all of us know this, but I can also assure you that knowing is not enough. We must apply it. Willing is not enough. We must do it. And that's where our doing is very important. But how should we do it? Our goals are very simple. We must have a focused antenatal care program, which has to be holistic and dignified. We need to understand that there needs to be birth preparedness, there should be complication readiness, and this can all be done with a small amount of lifestyle modification. And along with medical part, we need to have a very integrated maternal and child health care program, which will actually, without our realizing, prevent a lot of NCDs and have a very positive health promotion. Now, as practitioners, I think this integration is something which we are really looking at, and it is very easily done. Now, what probably cannot be done is that we cannot sit down with every patient and answer whole load of questions: what to eat, what exercise to do, when to come for the ultrasound examination, when to do all the genetic testing and all. And those are the kind of helps which we require. And this is a beautiful app which has been developed by me, which takes care of all these problems which we may have. So I really encourage all of you to encourage all your patients to use this app, because this app is a complete guide into making the journey of pregnancy as blissful and incredible. It is an amalgamation of fetal origin of adult diseases and Garb Sanskar, and it looks after a lot of things, because as we have understood fetal origin, we also have to understand that Garb Sanskar is a huge science from our own country, which actually tells us that child's mental and behavioral development starts as soon as the child is conceived. And I think we are also responsible to take care of that aspect. And it has also been scientifically proved that pregnant women who are actually exposed to Garb Sanskar have significantly reduced stress, and they have very much improved coping strategies. And that actually improves the outcome of these pregnancies later on. So what are the components of Adbhut Matratva, I may put it, because this was my basic theme for my FOXY presidential year, and we have continued it further. First is pre-conception counseling, then antenatal care, diet and nutrition, cosmetic care, yoga, exercise, music, meditation, birth preparedness, very, very important to reduce the increasing cesarean section rates and the complication rates, immunization, bonding of your baby with the parents and also with the doctor, very important again, and postpartum care. So these are the 9 components of Adbhut Matratva, and if we just focus on these, we will definitely improve the outcome in our future generations. And for this, as I've already told you, this is a beautiful app which actually guides the mother through diet charts, yoga, meditations, Garb Samvad, which are baby bonding exercises, music, stories, and expert advices, which will actually ease out our work. and the time spent with the patient, but the knowledge and guidance to the patient every day on a daily basis is immense. And I would really invite all of you on 16th of May, because we are now launching our next program, which is a responsible parenting program for the 0 to 4 years children, especially their parents, because the first 1,000 days are very important in building up the personality and the health of the baby. So we are further going ahead and launching our parenting program now. So maybe your pediatrician friends can basically prescribe this to all the young mothers who don't know what to do and how to bring up their babies. So I'd really like to end here and say that, yes, we are all the custodians of women's health, and I think the onus lies on us to shape up and build up the future generations in a most holistic and integrated way. Now, what are we going to achieve? Definitely, we are going to make motherhood a blissful experience. We are going to increase the bonding of the parents with the baby, which is very important, and especially with baby bonding exercises. And this is something which is lacking in these millennials and the other generations which are there today. Bonding of the couple with the doctor and the hospital will reduce a lot of litigations and dissatisfaction amongst the people who come to the hospital and the litigations later on. Plus, will encourage normal deliveries, which is also very important, and reduce the cesarean section rates, because that fear of vaginal delivery has to be allayed. Sensitizing the most important aspects of pregnancy and postpartum period, because we don't end up only by delivery. We need to also have the spacing and the postpartum contraception and the breastfeeding and all those things also put into place, because all these will then lead to building up the future healthy generations. And without even our realizing, we have shaped up the future of our future generations. So I'd really like to thank all of you for giving me this opportunity. And I would end up saying that let us keep on igniting and lighting as many lives as we can, because we also have only one life to give to the service of mankind. Thank you very much.
Thank you, Dr. Jaideep. As usual, an excellent presentation. I think that this plenary session is as good as oration from two stalwarts, Dr. Sanjay Gupte and Dr. Jaideep Malhotra. We are very fortunate to have you, both of you, at this particular junction. I know there are few comments from my other colleagues. Let them have it, and then I'll say that. Dr. Arun, Dr. Habziba.
Yeah. Dr. Arun, you are muted.
Arun, please unmute.
Good afternoon.
Am I audible now?
Yeah.
Yeah. Both lectures were excellent. Yes.
Not audible, sir.
Sir, please unmute, sir.
Not audible.
Now is it audible?
Yes.
Yeah. Both the lectures were very excellent lectures. I just wanted to any one of them, how much time the epigenetic changes take place to get it reverted. For example, as Dr. Gupte said, paternal weight, paternal vices, alcohol and all, if they stop it, if the obesity is reduced, how much time the epigenetic changes would take to revert? Roughly, so that we can.
But first of all, let me congratulate my co-speaker Jaideep for a wonderful talk. And the way she's coming up with these apps, they're very useful apps, and many of my people are also using her apps, and they're very good. And I'm looking forward to the next step, and I'm certainly will be there for your launch, Jaideep. Having said that, yes. And Arun, it has been seen now, for example, if bariatric surgery is done, then actually 500 different genes are improved and start showing changes in a particular person. And this has been improved now. Of course, it will take time. Diet, exercise is not going to be instantaneous. But for every person, it will be different. But one would say at least 3 months' time is a minimum that is required to make a real change, start making real change in the genes. And what Dr. Jaideep very rightly pointed out, and I also insist nowadays, is we are just letting the husband scot-free. They are the culprits in most of the cases, and poor girls suffer. So look at them, call the husband, look at him, see what he is doing, and then make him go on diet also, and at least smoking and alcohol should be stopped.
Thank you.
And sir, it's not only that. So many times, when recurrent pregnancy losses are happening, or even as in IVF, when we don't have a pregnancy, we are unable to explain, and you bear the brunt that you have done something wrong, or this lady has done something wrong, where the actual problem may have been with the male. So we need to basically, now put this picture together and treat both of them.
Absolutely. And as we have started doing sperm methylation studies now, sperms have problems, and fortunately they can be improved. Even diet is terrible. If you look at it, they are deficient many times in simple vitamins like folic acid and D3. And that causes the methylation in the sperms, and the quality of the sperm, motility may be there, but still the quality of the sperm genetically is not good.
Yeah.
Silver lining is both husband and wife are now coming for consultation with one after for antenatal visits also they come, and about weight and other thing when we talk them, they always try to understand. Dr. Absita.
Yes, sir. Good afternoon, everybody. At the outset, I thank the organizers for the wonderful opportunity, and I congratulate both the speakers. It was excellent. Dr. Sanjay was talking so much about the need of the genetic testing right from embryo to the childhood. And Dr. Jaideep, the passion with which you talk and insist on a commitment about future generation. It's wonderful, wonderful. And how the epigenetic plays in our day-to-day life, that diet, the exercise, the gene, the environment, it was wonderful. And your commitment towards your this thing is really is going to help the future generation. Thank you for the wonderful deliberation. I really congratulate both the speakers. Wonderful.
Thank you. Thank you so much.
Thank you.
An excellent session from genetics or genetics to epigenetics, and from normal things to advanced technology. And this is always will remember for a long time, and we wish that every time to improve upon this, and more information will come for research, for management part, and for the prognostic part. Thank you very much.
Thank you, Atulji. Nice to see your pleasant face always, and my very close friend and FC madam, all so thank you so much for sharing our session together.
Thank you so much.
Thank you, Jaideep. Thank you, Jaideep. It was an excellent presentation as usual.
Thank you, sir.
And thank you, Jaideep. Yesterday whole day you were with us, and today again. Thank you so much, dear. Always there with POGS. Dr. Gupte, he is a star of POGS. Star.
And with you always there.
He's our star also.
Yeah, he is a Foxy star as well.
Yeah.
Ever shining star.
16th May we will be with you.
Sunita, congratulations for such a wonderful thing.
Thank you, sir. You are always there. Thank you.
Keep it up. Keep it up for future also.
Thank you, FC madam.
Thank you.
Chaitanya sir, please take over.
Yeah, thank you. On behalf of Team POGS, I would like to thank the speakers, Dr. Sanjay Gupte sir and Dr. Jaideep Malhotra. I would also like to thank the chairpersons, Dr. Atul Munshi sir, Dr. Arun Fadnis, and Dr. Hebziba for accepting our invitation and being there as chairpersons for this plenary session. Moving on, let's move on to the next plenary session, and for this I would like to call upon the chairpersons, Dr. Rajendra Singh Pardesi, Dr. Meenakshi Patel, and Dr. Hemant Deshpande. Dr. Rajendra Singh Pardesi is the Vice President of AMOX and is the Vice President of Foxy. Dr. Meenakshi Patel, she is the Director at Sunshine Hospital and Global and Baroda Hospital, and past President of Baroda OBGY Society. Dr. Hemant Deshpande, he is a professor and head of the department at Dr. D.Y. Patil Medical College and Hospital, Pune, and he is being the chairperson of Medical Education Committee Foxy during 2016 and 2018. I would now request Dr. Rajendra Singh Pardesi to introduce our first speaker for this plenary session, Dr. Krishnendu Gupta, and he's going to speak upon galactoria and evidence-based approach. Over to you, Rajendra sir.
Rajendra, Hemant sir is going to introduce Krishnendu sir. Rajendra sir will introduce the next speaker.
Okay,
Nilesh. Good morning, everybody, and congratulations to Dr. Sunita and entire STAR team for such a wonderful show since morning and yesterday too. Excellent show, absolutely. And it's really my privilege to introduce Dr. Krishnendu Gupta, a good friend of mine, who is speaking on galactoria and evidence-based approach. Dr. Krishnendu Gupta is a professor and unit head of OBGY in Vivekananda Institute of Medical Sciences, Kolkata. He is adjunct professor in OBGY in Kasturba Medical College, Mahe, that's a Manipal University. He is a FOXI representative to Asia Oceanica Federation of OBGY. He is a chair of Sexual and Reproductive Health Committee of AFOGS. He was chairperson of Indian College of Obstetrics Gynecology for 2016. He was president of Bengal OBGY Society in 2013 and vice president of FOXI in 2011. A multifaceted personality, excellent orator, a good friend of every one of us. Dr. Krishnendu, the stage is yours now.
Respected chairpersons, at the outset, let me thank Dr. Sunita Tandulwarkar and the entire team of the Pune Society for organizing this fantastic STAR conference, and also for inviting me to speak on a very intriguing topic entitled Galactoria and Evidence-Based Approach. An often question which comes to one's mind is, does galactoria loosely refer to hyperprolactinemia? This takes me to a case report which was published in 2010 in an index journal with the heading Hyperprolactinemia with Normal Serum Prolactin, Its Clinical Significance. This was a case report of a 31-year-old lady, para 1 living 1, last childbirth of 8 years, complained of amenorrhea for 2 years, prior history of normal menstrual cycles. While on examination of the breast, secretions were present from both breasts, which was not noticed by her earlier, which obviously was the galactoria, and the pelvic examination was normal. In view of the amenorrhea and the existing galactoria, she was advised serum prolactin, thyroid profile estimations, and an ultrasound of the pelvis, all of which were normal. She was advised cabergoline 0.5 milligrams once a week. She took this treatment for 4 months, but remained amenorrheic, then discontinued this therapy. And after 1 month, she bled for about a day, which could be her menstrual cycle, and thereafter presented with amenorrhea once again to the doctor for 2 months. Lo and behold, during pregnancy, test was advised and was found to be positive, and the ultrasound was advised, which confirmed a 7-week gestation. She had an uneventful antenatal period and delivered a healthy baby vaginally. So what does this case report teach us? That isolated galactoria with normal menstrual cycles and normal prolactin levels have been estimated to occur in up to 20% of women at some point in their lives. So this is basically the mistake of this paper. It should have been galactoria with normal serum prolactin instead of hyperprolactinemia with normal serum prolactin. So we are all aware that such cases actually are challenging and taxing to the clinician, which also adds because of the problem of the heterogeneity of the prolactin molecule, which now takes me to prolactin, and which we all know is a polypeptide synthesized in a pulsatile fashion from the anterior-pituitary, the lactotropes. There are 3 types of prolactin: little, big, and big, of which the little is the most important because it has the great biological activity of 80 to 85%. The units of measurement is 1 nanograms per mils, which corresponds to 20 milli-international units per ml. The normal adult serum levels in females is between 5 to 27 nanograms per mils, and it is also seen that the high secretory peak of prolactin occurs during the rapid eye movement sleep and between 4 to 6/5 to 7 a.m. in the morning. So therefore, we always try to advise the ladies to get the prolactin levels done sometime around 8:30, 9 o'clock, because we can get very high levels, high normal levels of up to 30 nanograms per mils during that time. And the circulating half-life is 50 minutes. So we are aware from where prolactin is synthesized. We know that dopamine inhibits prolactin secretion, and there are also certain hypothalamic releasing factors for prolactin, like the vasoactive intestinal polypeptide, thyrotropin releasing hormone, and of course, estrogen. We are all aware also that what the regulation of prolactin is like. These are standard textbook diagrams, and I think it's beyond the scope of the presentation to really deal with the details of the regulation of prolactin. So my presentation objectives, after mentioning a confusing published case report, are give you some facts about galactoria, tell you something about nipple discharge, give you the causes, evaluation, and evidence-based management of galactoria, a few words about the hyperprolactinemia guidelines of treatment, and of course end with key points and summary. So what is galactoria? It's basically non-lactational milk production, which is milk production 1 year after pregnancy and cessation of breastfeeding. Can occur also in nulliparous women, postmenopausal women, and also in men. The incidence is variable, although 90% of women with hyperprolactinemia will have galactoria. 3 out of 10 women, that is 30%, who present to their doctor for a breast examination have some sort of nipple discharge. Nipple discharge is present in 7 to 10% of all breast symptoms. It's classified as normal or abnormal, depending on features such as laterality, unilateral or bilateral, cycle variation, quantity, color, or presentation, whether it is spontaneous or induced. The spontaneous or induced nipple discharge may be identified either by the patient accidentally, on her own, or during clinical examination. Less commonly, it may present during mammography secondary to pressure, because suddenly the film and the plate comes in between and there's a pressure and there's a little bit of discharge, which the lady suddenly sees. So it can be categorized as normal, abnormal, or attributed to galactoria according to the history and physical examination. So what is normal nipple discharge? A normal discharge is non-spontaneous and is usually bilateral, serous, and originates in many ducts. Multiple duct discharges are rarely caused by cancer. I repeat, multiple duct discharges are rarely caused by cancer. In cases not related to breast pathology, mechanical stimulation, thoracic trauma, and medications are also and should be included in the differential diagnosis of nipple discharge. The patient who's curious to check for discharge may continuously cause mechanical stimulation, and in such cases, discontinuation of the stimulation will discontinue the process. Women should be advised to avoid checking themselves for discharge, since benign discharge may resolve while the nipple is left alone. Abnormal nipple discharge is defined as non-lactational, persistent, spontaneous, and unilateral, usually located in one duct. And as it is spontaneous, it may well disappear on its own. It may be green or gray in color, serous or bloody in appearance. Even if bloody, it is usually benign. So just because someone comes with a bloody discharge, you should not only think of malignancy, because the underlying malignancy in a bloody discharge is as low as 1.2% to as high as 15%. So this shows us the nature of the discharge, whether it's milky, serosanguinous, bloody, and green, depending, as you can see, this is white galactoria, and so many types of serosanguinous, bloody, and greenish kind of discharge, which tells us, which can actually help us to diagnose what could be the etiology of this nipple discharge. And it's very important for us to have this as a ready reckoner to know what we are think. Although we have to think of malignancy in case of a bloody discharge, we have to keep that in mind, no doubt upon that. But even trauma can cause that. So coming to galactoria, it is typically bilateral. It originates in many ducts, and the discharge is milky. This is typical in pharmacological galactoria, and discontinuation of the medication is all that is required, which will eliminate the finding. When galactoria is accompanied by amenorrhea, it is usually caused by hyperprolactinemia. Very, very important point. When galactorrhea is accompanied by amenorrhea, it is usually caused by hyperprolactinemia. However, when a patient has normal ovulatory menses and galactorrhea, the prolactin levels are usually normal. So we can classify galactorrhea as hyperprolactinemic galactorrhea or normoprolactinemic galactorrhea, where there is an excessive nipple stimulation, including during sex or suckling. This can cause a physiologic galactorrhea because of the hyperprolactinemia. In the neonatal period, the high level of estrogen from the mother can cause transient galactorrhea in the newborn, which is called as witch's milk. I think all of us are well aware of that. During pregnancy, especially during the third trimester, women can have galactorrhea with prolactin levels up to 200 micrograms per liter, which is extremely, extremely high levels of almost nearing 9,000 picomoles per liter. Other causes of transient hyperprolactinemia are vigorous exercise and physical stress. So some of the causes of hyperprolactinemic galactorrhea could be physiological or pathological. We already discussed some causes of the physiologic ones, while the pathological causes could be hypothalamic or infundibular lesions like the Stork effect, and of course pituitary lesions, which we are very well aware of, lesions involving the chest wall, and of course systemic disease. We have to think of thyroid, hypothyroidism, which is extremely important, and renal disease. And of course, medicines. Medication-induced hyperprolactinemia is a big problem because a lot of our patients are buying things off the net and taking it, and we really don't know where that could be caused. And this, what is most important, you have a huge plethora of medicines which can actually cause galactorrhea, including herbs like anise, blessed thistle, fennel, fenugreek seeds, marshmallow, nettle, red clover, red raspberry, etc. These are actually beyond the scope of this presentation, but we must remember that we must ask the patient whether they are actually buying things off the net and taking. So illicit drugs and herbal supplements can also cause galactorrhea, but what is very important for us to remember are antipsychotics and the gastrointestinal promotility agents block the dopamine receptor on the pituitary lactotropes, decreasing the normal inhibition of prolactin release, thereby causing hyperprolactinemia and galactorrhea. So a few words for postgraduates here about Chiari-Frommel syndrome, which is a rare endocrine disorder that affects postpartum women and is characterized by galactorrhea, anovulation, and amenorrhea. The symptoms persist long for more than 6 months or so postpartum. This amenorrhea may result in uterine atrophy, but the good part is some of them resolve spontaneously and the hormone levels and reproductive function return to normal. So coming to hyperprolactinemic galactorrhea, it could be idiopathic. Occasionally, no cause is actually found. We just cannot find the cause of the hyperprolactinemia. With long-term follow-up, some women with idiopathic hyperprolactinemia are found to have microprolactinemias that were too small to detect originally. And this is something which I've learned through practical experience and in my private practice, that if a lady with hyperprolactinemia gets an MRI done, let's say in the villages where an old machine from the city, from a metro is kind of furbished there and all that, they may miss it. So we must be very specific that when a lady is sent for a MRI of the pituitary, we must ensure that it is done by a high-end MRI machine, preferably a 3 Tesla and with 1 millimeter cellular cuts. And that's very important for us to write it down so that the radiologist can actually go ahead and do that, or a dynamic MRI as we call it. So how do we evaluate galactorrhea? Well, galactorrhea should be distinguished from pathological nipple discharge, which can involve breast tumors. It's very important. We all know that galactorrhea is usually bilateral, multiductal, and milky, but can be yellow, green, greenish, or even brown. I mean, that's nipple discharge. So you've got to make out whether there's some, kind of associated problem. And the clinical practice point is, if the diagnosis of milk production is in doubt, a Sudan 4 staining for fat droplets in the nipple discharge can readily confirm the diagnosis. Well, again, from the history, there's a beautiful chart. There are 2 charts from the American family physician way back in 2004, where based on the historical data, we can actually find out the possible, or think of the possible etiology, like galactorrhea in the neonatal period, neonatal galactorrhea. If the galactorrhea is along with headache, visual disturbance, temperature issues, we know that we are dealing with a pituitary adenoma, and of course decreased libido. We can think of so many kind of clinical kind of symptoms and signs which can actually help us to diagnose the etiology. And similarly, based on the physical findings, we can also think of the possible etiology of the problem. If there's poor growth, hypopituitarism, gigantism or acromegaly pituitary tumor, etc., etc., hirsutism or acne, clinical hyperandrogenism. So we have to kind of think about all the clinical findings, both from the history as well as the physical findings, and then we can definitely come to a diagnosis. Of course, we have to think of thyroid tumors as well. So if you have to look at how do we evaluate, if there's a nipple discharge, we rule out breast pathology. If it's galactoria, we of course have a look at the prolactin levels. If there's no elevation, we treat with a dopamine agonist only if the galactoria is bothersome. Only if the galactoria is bothersome. Please remember that. Otherwise, it requires no treatment. But of course, if there is, then we check for thyroid, creatinine, and of course the renal functions. And of course, we have to rule out pregnancy, no doubt about that. And of course, elevated TSH, HCG, and creatinine levels, the renal levels. And as far as we have to rule out the medicine, if the medicines are the cause. And of course, if there's no other cause, we definitely, depending on the levels of prolactin, if it's more than 50 or 60, or even earlier we used to do it at even 100, but now we have got such sensitive MRI machines that we can even detect a microadenoma when even the prolactin levels are anywhere between 50 to 80. So it's very important for us to remember that. So to manage, of course, after breast pathology, it's excluded. Treatment is usually indicated for patients with bothersome galactoria, hypogonadotropic hypogonadism, or a concerning causative lesion. Otherwise, it is reasonable to reassure the patient and monitor a condition. It's extremely important that counseling is done adequately to the patient. Otherwise, they are extremely anxious and keep fiddling with the nipple, and which can cause more nipple discharge and more galactoria. Because most galactoria is associated with hyperprolactinemia, the treatment can be classified based on the underlying causes or effects of hyperprolactinemia. And of course, we have to think of medicines to treat them as well. We are well aware that we have two of them in our armamentarium, bromocriptine and cabergoline. We all know the dose of bromocriptine, and of course, the new kid on the block, cabergoline. We have to discuss the common adverse effects with the patients. And of course, there are various studies now which are showing the superiority of cabergoline over bromocriptine. Coming to normal prolactinemic galactoria, something which is very, very important for us to remember, that if it is not associated with breast tenderness and swelling, it is not bothersome, please counsel and reassure the lady. But she should also be advised not to check for persistence of galactoria, as I've repeated that, because repeated milking of the breast will stimulate prolactin secretion and delay the resolution of the galactoria. And if it is bothersome, then we come into some sort of treatment, and the treatment usually given is the low-dose dopamine agonist, such as 0.5 milligrams of cabergoline once weekly. This generally kind of resolves the galactoria within a couple of months, and then you can slowly taper off the medication by giving 0.25 once a week, and then making it 0.125, half a tablet of that, and then really tapering it off. So this is a wonderful guideline published by the Endocrine Society, and we must, all postgraduates can take are most welcome to take a picture of this slide, because this will give you beautifully how to diagnose and treat hyperprolactinemia. I've learned a lot going through this guideline. It's impossible in this time to discuss the guideline, and this is the one which the endocrinologists actually follow. And another wonderful systemic review about the treatment of hyperprolactinemia by Wong et al. And it was published in 2012, where they had 8 randomized and 178 non-randomized studies over 3,000 patients. It was found that cabergoline was more effective than bromocriptine in reducing persistent hyperprolactinemia, amenorrhea, oligomenorrhea, and galactoria. And the authors' conclusions were that their results proved, there were enough evidence to show that cabergoline was more efficacious than bromocriptine in treating persistently high levels of prolactin. Well, the key points: galactoria is commonly caused by hyperprolactinemia, especially when it is associated with amenorrhea. Hyperprolactinemia is most often induced by medication or associated with pituitary adenomas or other cellular and or supracellular lesions. Less common causes of galactoria include hypothyroidism, renal insufficiency, pregnancy, and nipple stimulation. After pathological nipple stimulation is ruled out, patients with galactoria should be evaluated by measurement of their serum prolactin level. MRI of the pituitary or brain MRI should be performed if no other cause of hyperprolactinemia is found and we find the levels to be very high. Please remember about the MRI machines, because I've learned it by my own clinical practice. Patients with prolactinomas are usually treated with dopamine agonists, bromocriptine or cabergoline. Surgery or radiation therapy is rarely required nowadays, and that's a great boon for most of the patients. Medications causing hyperprolactinemia should be discontinued or replaced with a medication from a similar class with lower potential for causing hyperprolactinemia. So a clinician also has to be well versed with what are the medicines the patient is getting, what we can substitute it, whether we can still treat her symptom, but reduce her galactoria and other symptoms. Normoprolactinemic patients with idiopathic, non-bothersome galactoria can be reassured and do not need treatment. I repeat, do not need treatment. However, those with bothersome galactoria usually respond to a short course of low-dose dopamine agonist like 0.5 milligrams of cabergoline once a week. You can give it for a couple of weeks or 3 weeks and then move it down 0.25 milligrams once a week and then taper it off, as I mentioned earlier. So the key recommendations for practice, again, most of the recommendations here are consensus, disease-oriented evidence, usual practice, expert opinion. But it's very important that if a cause for hyperprolactinemia cannot be found out by history examination and routine lab testing, an intracranial lesion might be the cause, and brain MRI should be thought out. In patients with normoprolactinemic galactoria, no further evaluation is usually required. Treatment of galactoria should be targeted primarily to correct the cause, that is treatment of the hypothyroidism, as I mentioned, renal disease, etc. And of course, most importantly, the offending medication. Patients with symptomatic prolactinomas should be treated with dopamine agonists with cabergoline preferred over bromocriptine. Treatment is not recommended, I repeat, not recommended for patients with asymptomatic microprolactinoma. Diagnose the etiology of galactoria before initiating any treatment. So this is one of the most important summarizing points. We have to diagnose the etiology of galactoria before we initiate any treatment. Control the symptoms and ascertain the desire of the patient regarding what she wants, fertility or not. So many other wants and wishes are there. The first line therapy is no doubt now cabergoline. Second line therapy, unfortunately, now bromocriptine has taken second place, and it is a team therapy. We have to include an endocrinologist because they are of great help. Their guidelines are extremely important for us obstetrician gynecologists to follow. And please do remember these 2 points. Patients with isolated galactoria and normal prolactin levels do not require treatment if they are not bothered by galactoria, do not wish to conceive, and do not show evidence of hypogonadism or reduced bone density. And prolactin levels are usually normal when a patient has galactoria and normal ovulatory menses. So I hope that I've, in the last 15 to 20 minutes or so, I've been able to take you through my presentation objectives, which I had right in the beginning. It's an intriguing subject, as I said right in the beginning, and the galactoria is an often, patients come with galactoria quite often to us, and then we only think of hyperprolactinemia and nothing else, when actually there are some other causes as well of galactoria. Thank you very much from the city of Kolkata, and I hope all of you stay safe and are healthy in this terrible second wave of COVID, and God bless. Thank you very much. Thank you, Sunita, and the entire team again for this opportunity for me to present before you. Thank you, chairpersons. God bless you. Thank you.
Thank you, sir. Thank you for that wonderful talk. I would like the chairpersons to say a couple of words before we move on.
Excellent talk, Dr. Krishnendu. A good insight on etiology investigations and management of galactorrhea. Really a big problem, both in infertile as well as in fertile patients. And really thank you for excellent talk.
Thank you.
Thank you, Dr. Krishnendu. It was a really next. So.
Hello.
Chaitanya.
Yeah.
Yes,
Thank
Chaitanya.
Thank you, sir. Moving on, there's a slight change. Dr. Meera Agnihotri has been held up with some family emergency, and therefore, Madam, so Dr. Sunita Tandurwadkar will be taking over in place of Dr. Meera Agnihotri. Dr. Sunita is going to speak on how to do a good myomectomy. I would request Dr. Rajendra Singh Pardesi to introduce Madam in short. Over to you, sir.
Hello, good afternoon, everybody. Dr. Sunita Tandurwadkar, I think she doesn't need any introduction. She is the star of this STAR conference, and she is a great star from our AMOX family. She is ever active, ever smiling personality with great academic biodata. She is active in FOXI, AMOX, POGS, ISAR, IIG, and many organizations. We wish her every success in future endeavors in FOXI also. Over to Dr. Sunita.
Thank you, Dr. Pardesi. We are like a AMOGS family together. Thank you. And I thank Dr. Vaishali and Nilesh for roping in me. Very important session. And we pray for the health of Dr. Meeraji's brother. COVID pandemic has given us a really difficult time. I apologize for not using the template because there was no time. In the morning, I came to know about this, but I tried to put the logo in. And of course, my topic always the most favorite is how to do good lap myomectomy. I will remain as much in time as possible. Friends, does myomectomy means only incision, enucleation, closure, and tissue extraction? No. Myomectomy needs much more thinking than all of this. It is an art to perform. We all know that every surgeon, from selection of cases to delivery to end it, single port, multiple ports, laparoscopy to robotic, there are huge differences. And surgery of the myomectomy, though basic principle remains the same, thinking of the same surgeon differ from time to time, and especially if the case is infertility or is it a menorrhagia. And as the time passes, the experience of the surgeon also increases and the surgeon evolves over the period. So the techniques also keep on changing by the same surgeon every time. But what doesn't change is your preoperative excellent preparation. If you want to excel your intraoperative performance, whatever may be the patient, may be morbid obese or a large myomas, if you do very good your preoperative preparation, then nothing like it. In Pune, we know Dr. Manoj Chinchwadkar. I always tell him, you are the reason why we are successful. He gives amazing mapping of the myomas, and then it helps you to do the case. When to post the patient. If it is too complicated giant myomas, I may post in the morning with no overcrowding of the surgeries, which energy sources I need to be booked, which team I will need, youngsters or the senior, the expert one, how will my incision go, how will I need nucleate. I do mental preparation of everything. I always say simulating and visualizing a surgery a night prior to your actual surgery help you to improve your intraoperative performance. You cannot just say, oh, I'm doing it for more than 2 decades and I can take out any myoma. Every patient needs your close observation. Large myomas, yes, very simple. Your ports go in an upper abdomen so that you have a good good panoramic view, maybe a 30-degree telescope, good assistant, good anesthetist. Most importantly is your own level of confidence, and probably the first half of the day I choose to. Your confidence level, of course, will keep on increasing as the time passes. You will have less of an exclusion criteria and more of inclusion criteria. So how do we plan the incision? I feel the most important thing we see, especially in infertile patient, how to prevent the corneal damage so she can conceive post-myomectomy naturally, remove as many myomas as from one incision, and the last preference for the expert endoscopist is whether you are ipsilateral or contralateral, it doesn't make a difference. Look at these multiple myomas, but I'm happy because I take a 2 incision, one anteriorly. I can take out 1, 2, 3, 4, 5 all, and then I will go for the posterior and I can take out. The most difficult one is this one, not any of these. They are simple, they are away from the cavity. Here I need to be very careful that I don't open the cavity as much as possible in infertile patient. Same way here, take 1 incision and take out as many as possible from that incision. Now look at this. Prima facie, it looks the same, both those cases. But if you see more carefully, on this side there is more bulge because there are 3 myomas, one after the other inside, causing deep compression, while here there are only 2 myomas. So how should my incision? Here I am taking vertical incision. So it doesn't make any difference to you whether you are going vertically or horizontally. What is important is you are not damaging the cornea on opposite side. So go intracapsular. This is what I always say. Remain within the capsule. All the cautery always should be on the fibroid and never on the bed. And I always love to close 1 myoma before I land up to the second myoma, because it's very important your vasopressin act only for 20 minutes. And please, you just need to take as fast as possible. What is important is barb suture. Tomorrow Manish is giving a beautiful lecture on it, but the barb suture has simplified our life. It gives beautiful compression, and then now I'm going for the second myoma here and I will be taking out. While here I'm taking first this myoma. Here I cannot even see where the bulge is, but preoperatively I was knowing it's a deep intramural but anterior to the cavity. You can see the wall, thickness of the wall, and again cautery there. While here I'm taking out myomas. So 1 incision vertical, 1 incision horizontal, both parallel, makes no difference. Instead of taking 1 horizontal incision, I might take 2 parallel vertical incision. While here, when I'm taking out the first myoma, in this case again, I'm not closing, because the deeper myoma, whether I will be able to take through this incision or through this incision, I was not aware. So after taking out the first myoma, I jump for the next myoma, and then what I'm trying to see is remain intracapsular. Monopolar helps you to do this fiber by fiber dissection. I just love monopolar in such deep intramural. They are medium size, they are small size, but these remain to be intracapsular, helps us, and only to the base you may use harmonic, or you can go for the bipolar cautery. So once I remove this myoma, I realize that there is no myoma deep inside. Just suck out, don't cauterize any bed. And then I go to the first site and I saw beautifully this myoma I can take from here. I close down that and I come here. I'm taking out the second myoma. You just see the bulge was hardly, and this is also like 3 to 4 centimeter, good size myoma. I'm taking out and I'm searching another 3 centimeter, which was deep. Just put the suction in and then you can take a claw forceps, and then remember one thing, don't allow the assistant to pull too much. They can avulge the cavity, and the third deep intramural myoma came. So there may not be a bulge seen, but you can do large myomas. This was an unmarried girl having 20 centimeter. Usually you will find there is a rotation of the entire fibroid, detour, and then you decide how you will go with the incision. In this case, I'm going oblique incision, very old. We used to use those bipolar in those era, but makes no difference. Now here, my sonologist told me it is going oblong, and then once I go in, as I said, there may be a rotation. What I decide is what should be the direction, taking care of the ureters, taking care of the fallopian tube, taking care of the ovarian ligament. Very important, sometimes it may get extended. Then after the vasopressin incision injection, I decide probably I'm going down here, but I don't. I just do mental preparation, and again I'm watching the cornal end. And once I do that, I tell my assistant, release the, any Ellis forceps pressure, and I realize, oh my God, I was taking completely in a different direction. Probably this is the proper direction. So it goes 180 degree, complete 90 degree rotation. So it doesn't mean evaluate. First you thought I will go over in this. So monopolar, bipolar, whatever energy source you are using, reconfirm your ovarian ligaments are not going to come if you extend the incision and then only you go. You are not going to compromise the ovarian blood supply, especially with the large myomas. Very important. So be thankful for each new challenge, because it will build up your character and the strength. Remain intracapsular. I believe in. I know many great endoscopic surgeons always tells, open it, no problem. I feel no. Try and do as much precautions as possible, but do remain intracapsular. What is important is when you remain intracapsular, there may be you see that there is fibroid was completely from the fundus to the isthmus. This is the capsule. I put lot of fluid also there and ask my vaginal person who has given a traction on the cervix, have you, because traction and a counter traction is the most important step in any laparoscopic surgery. And if he says no fluid is coming, it means even there is no small hole. Now you saw the active bleeder. Don't bother. You just start suturing and you can achieve maybe 50 cc loss, that's okay, but don't do necrosis. Now this fibroid, again, it's very important. I'm showing different energy sources, the gyrus. Over the period you have all, and this is the end result, completely anterior wall, and there is no. While here it was more, lower cavity was absolutely okay, while the upper cavity was compressed. So you know that this is how you will be going, and you have conserved the fallopian tubes. So vertical incision is the one I will take, not the horizontal incision. Now here, it was a previous cesarean. My sonologist told me there will be adhesion band here, and this is the way beautifully they draw. I allow that adhesion band because it helps to antivert the uterus and go beyond it. Now look at this. This is a cornal complete compression it is causing. This patient is simple infertility. It doesn't need IVF. I was knowing I'm going to take an incision as low as possible, lifting with the myoma screw, and you can see the end result. My incision was here, the cornal openings are here, end result beautifully clean pelvis, and she should conceive 3 months after you give her go ahead. While this myoma is small but occupying nearly 1/3 of the upper cavity, if it has caused bulge on the serosal surface, I will approach this always laparoscopically and not hysteroscopically, because I may need more sitting. Now this is a 30 centimeter myoma, but the sonologist said it is a true broad ligament and it has a beautiful blood supply. The uterus is completely compressed. You first do the inspection of every myoma. That was my trocar, which has gone from upper. Still I use a disposable to be on safer side always, but when it is a new piece, it may give it no problem. Now, broad ligament as such are very simple. You have to create. But when it had a blood supply coming, I will see first ureter completely compressed. You saw the beautiful, I think it was a very well vigilant. It was a compressed ureter here, and you do the dissection and try to obliterate temporarily. I'm again saying only temporarily the uterine. You can see the beautiful pulsation, the full course going in. Just obliterate this. I think Sanket has given a nice shoelace knot in his publication. We use it many times, but even if you can do it simple knotting, or you have a disposable clips, use it. It definitely reduces, and then whatever cautery you do on the medial side, on the specimen side, so there is no retrograde flow going. I mean, no damage going to the uterine wall because it was attached. Now, this is a posterior leap of a peritoneum, which we did not dissect out, which we did not separate out. You are seeing it now. Don't excise it. You need to cover that peritoneum back so that bowel will not go and cause an adhesion to that surface. So always be very careful. These bipolar scissors which has come, it made our life very simple. I use it left and right. So here you can see that it is very important. You had a temporary ligation. The moment you release, there may be a nice spurter coming out. So you cauterize that, suture that, and then open up the uterine. Ensure that there is no active bleeding, and then only you close. I believe in closing the peritoneal flap because there is a lot of raw area. We ask the patient to mobilize immediately. It is important that you will see nice pulsation back, no active bleeding, and then you see the whole tortuous uterine over the period with this increasing size of myoma. And just I do allow small hole to remain. This is not because the suture ended. I allow this so that any collection happening, I keep a drain. Don't be overconfident. Keep a drain for 12 hours and take out. Now, this is another 25 centimeter myoma. Again, he's told me it is a true broad ligament, but this time it was from the anterior uterine wall. Now, I want you to know that when it is from the anterior wall, over the period, do expect the bladder coming and covering this area, and be careful because you may lost, and I'll show you here beautifully. Now, this is the myoma. I go ahead, I'm doing a vasopressin injection, I'm taking out the posterior lip. Time doesn't allow me to show so many videos, but I'm telling you the clips. This is the posterior wall, and look at this anterior. If you would have cut here, this is all the bladder. And this we were knowing because obviously if anterior cervical fibroid and entering completely into the broad ligament laterally, you may get a picture like a broad ligament, but preoperatively I was knowing it's the anterior cervical, and I was expecting the bladder compression or the adhesions, and this is completely the bladder. You need to go in this beautiful plane, and then you take out this myoma. So very important to keep the end result as a clean pelvis because this patient can conceive naturally. So friends, what is important is art of endoscopy lies in the imagination of the surgeon. We become creative, we become imaginative, and we should. Closure of the myoma bed, there is no controversy, single layer, multiple layer, whichever suture material you use it. Look at this. This is a deep intramural myomas, oblong, completely arising from the anterior surface. It is going to be a little bit tricky situations, such many more myomas. Here I'm telling you, this is a nice use of the monopolar coming into the intracapsular, make the myoma naked. I was knowing it's a vertical myoma. So naturally with the vertical myoma, I'm expecting, but don't open the cavity. And then naturally, I will go for a multiple closure over single layer. Now, what is important is obliteration of the dead space. If you can take simple, even simple vicryl and through stitches, probably the patient was only of a menorrhagia, you can do that. Infertility patient, scar is often tested. I would prefer to go in with the multiple layer closure. Bob has helped hugely. Friends, it's not very expensive. Use it, because obliteration of the dead space is important. Now look at this. This was again 25-30 centimeter myoma, but I was told this is a peduncle. It has nearly 1 centimeter. So it is a very simple myoma to take out. But if the same myoma, let me go back, and if it would have been the same myoma where there is no pedicle, then I will take an incision more on the myoma than on the pedicle, because you will land up in a huge vessels and you will cauterize the corner of the uterus more. So here what I'm doing is very simple surgery. I was aware, huge vasculature. So I'm just putting 2 loops over there, one after the other. I just run the video, and this is, try to put the second, because one may not do the capillary obliteration, and second, try to put it at least 3 to 4 millimeters away in front than over. You can see the large vessels here. I was aware of these vessels, and that's why I'm taking this step. Now what is this? Myomectomy is very simple. You expect that there will be a retrograde flow coming in from your myoma. Don't bother. Go 5 millimeter to 1 centimeter away from your tied loops. You don't have to take out. I have not done anything on the specimen side, so they will keep on having the flow. Bipolar works fantastically in presence of blood or the fluid. So just keep on cauterizing. This is a bipolar Caesar, most economical. I use it left and right now over the gyrus or an NSIL, and look at this. There is no bleeder at all, and the cornu is very well saved. This is another fibroid. Just take it out. Though it is small, not coming in your way, it will need a surgery. Obstetric quality of the myomectomy scar is a debate, and see to it that there is no hematoma, so obliteration of the dead space. There is no necrosis, so don't cauterize. Start suturing. We don't cauterize after the cesarean, and when you don't cauterize, there is no question about necrosis. When you don't have a hematoma, there won't be infection. So friends, prepare yourself well before each surgery to excel your intraoperative performance. Believe in having excellence every day. Tissue retrieval, I don't think I can cope up with this now in this, but whatever the best economical and in your hand good for the patient, use it. Morcellation, in-back morcellation, vaginal morcellation, all is your choice, or the mini laparotomy. Don't limit your challenges. Challenge your limits. Each day, one should strive for constant, never-ending improvement. There are many hills to climb. Sometimes difficult and tricky situation. Endometriosis, the last 2 videos. We all know that recurrent endometriosis or the endometriosis and myomas goes hand by hand. Patient had a previous surgery. She was for IVF. She had a left-sided hydrosalpinx. I can see only femoral end. And she had a deep intramural myoma. You can't even see the uterus. What is important is a nice adhesiolysis. Caesar is the best energy source you have in your hand, and no third hand is the another best thing you should do, because you should be giving traction and counter traction. Endoscopic surgeon should be always bi-handed surgeon. More depression on the uterine side and never on the bowel side. You got the flimsy things, open up. You can't even jump for the myomas here. Adhesiolysis, you spend entire time in. What is important is doing a safe surgery. When you do the peg leg solution, bowel get compressed, sometimes difficult even. In comparison, colon is better. It is a thick wall, but don't do blind dissection. Always dissection with the good scissors. I always prefer blunt scissor. I never throw off. These are the cases where I use them. Fiber fiber dissection, your Caesar direction. Now, I don't advise complete uterine blockage or anything, but before I will go for the hydrosalpinx, I need to be very sure whether the ureter is pulled here or ureter is in a lateral place. So just see where the ureters are. Once you confirm that the ureters are completely laterally, you don't have to bother. You just go and proceed with your hydrosalpinx dissection. And once you have taken out that hydrosalpinx, then you can see that small tiny uterus and then many fibroid. Now, this patient had not only this deep intramural, but on right side another. My colleagues were exhausted. My team, they said, ma'am, no more fibroid. But Dr. Chinchwadkar said, yes, there is on a right side, right lateral wall, there is a beautiful fibroid. It is compressing, though it is 4 centimeter. Don't leave your surgery halfway. You need to do that. While sometimes you have a tricky situation, myoma on the anterior wall and adenomyoma on the posterior wall, both sandwiching the cavity. I will always go for the myoma removal, and fortunately in this case it was anterior. The second reason to go for it, so that I can make the uterus anteverted very well to tackle the adenomyoma. I will take all precaution not to open this cavity, because with adenomyoma sometimes I'm in a difficult situation. So once you remove that fibroid, then you land up in going for an adenomyoma dissection. Whatever said and done, friends, adenomyoma, try to work with the medical line of treatment before the transfer if you want to do it. And only when medical line of treatment doesn't work, you need to go for adenomyectomy. You can remove maximum 60 to 70%. Don't open the cavity. We all know that there is a defect in the wall and you cannot suture this wall beautifully. So usually I take out pieces by pieces, then one large chunk, and you can very well differentiate the adenomyomatic tissue from the healthy myometrium. We don't grow when the things are easy, friends. We grow when we face the challenges, and experience makes you better. I always feel I'm better than what I was 2 years ago. And this thought is in my mind for last 25 years. More and more, no more simple 5 centimeter myoma reaches to me. More and more complex decision-making cases reaches to you. And then you decide which case, the need surgery, what surgery, because surgery at any age group is uncomfortable. As a surgeon, our job is first to make her life comfortable. Don't say by laparoscopy you make it comfortable. Look at this, so many if it is a difficult case, you land up sometimes with so many trocars. So is it worth doing it? Some women need to be treated, others don't. Find out which one and ask yourself this very important question. But don't stop when you are tired, stop when you are done. And we are only done if we are celebrating our every day, saying, I have done the best surgery possible for my patient. Thank you so much. You can't be anything without having a beautiful team with you. Thank you for this opportunity again. Thank you, POGS team, Vaishali and Nilesh, for giving me an opportunity, because we as a POGS team opted out to be a faculty because they were star-studded faculty in the country, and we thought we should be the listener and be a good host. Thank you.
Thank you, Dr. Sunita. It was really an excellent talk. Every time listening to Sunita is really an academic feast to us. She has explained nicely the procedure of lap myomectomy and small things, means taking care of ligaments, bowel, ureteric injuries also, and use of cauteries, bipolar scissors. She has explained very nicely. Even she told nicely meticulous hemostasis and avoidance of hematoma formation in the myomectomy scar is mandatory. Judicious use of electrocautery, and she has explained all the cases, which not only simple myoma, but myomas in unmarried girl, big myomas, myomas in previous LSCS, myoma with endometriosis, myoma with a bulky uterus. Really different cases and really a nice experience. Thank you so much. Thank you.
I
Dr.
can
Hemant.
Dr. Chandravati, madam. Thank you so much for being with us.
I like to say one thing. First of all, congratulations for this wonderful conference. And you have taken us from a journey from small myoma to multiple as well as very, very huge myomas. And excellent presentation of your videos. So but I will like to ask you one question. While doing all these things, if you damage the cavity, then what is the next step?
I don't close the endometrium, but I will do multi-layer closure, which otherwise also I do. And then you just remain above the endometrium and close it in multiple. Don't try to suture the endometrial layer, number one. Second thing is, you may land up there with a few bleeders. Don't cauterize. Fortunately, VLOC has given us a very good obliteration. So my request will be never. Never suture, never cauterize. Third important thing is, ensure you request the patient to conceive after 3 months of surgery.
And many a times this type of patients usually comes to you with a heavy periods in the next cycle. So is there any relation that some collection in the cavity or like that?
I have not faced really after myomectomy patient coming with PV bleeding, you mean? Or a collection?
Next period is very heavy.
I have not noticed this, but I'll notice this probably. I have never noticed. See, in a fibroid, we are not doing anything with the hypothalamo-pituitary ovarian axis. We are not doing anything. So there is no reason. Secondly, I don't put these patients on any GnRH or anything because I don't want vasculature to get compromised. That's another important tip. Don't put these patients on a GnRH because we all know it will cause a hypovascularity and the scar healing or a tissue healing will be either delayed or defective.
Thank you, madam. Again, congratulations to you and your team. Wonderful show.
I see Mario, I see Dr. Chandravati, I see Dr. Usha Sharma, madam. Thank you so much for giving your valuable time to POGS and for this Star Global Conference.
सुनीता, आपने बुलाया और हम ना आए, ऐसा हो नहीं सकता. मेरी तबीयत भी नहीं ठीक थी, but I thought I'll come and see you at least once and be there with your program. I really congratulate Pune Society to have such a wonderful president and the whole team of Vaishali and other people along with there, and congratulate you all on organizing such a wonderful program.
I see Adi also. Thank you so much.
Hi Sunita, thank you for a lovely, lovely conference. What a lovely lecture, what a lovely dress you're wearing.
Mark aayega Adi.
Beautiful dress you're wearing also. And I loved your lecture. It was so beautifully measured and done. Very nicely done. I sent you a song of A.R. Rahman just now released for COVID. It's a very nice song which is released by him. So you can hear it today. If you want, you can play it in the conference in the interval or something.
Sure.
I'll send it to you.
So we move on. Thank you.
All the best to you for the remaining part of the conference. God bless you. And your whole team also.
Thank you, Adi.
God bless. Bye.
We have Mario now for you all to chair.
Thank you. Chaitanya sir, can we move on to the next session?
Yes. On behalf of Team POGS, I would like to thank Dr. Krishnendu Gupta and Dr. Sunita Madam for wonderful talks, and also the chairpersons for this plenary session, Dr. Rajendra Singh Parvesi, Dr. Meenakshi Patel, and Dr. Hemant Deshpande. Thank you so much for accepting our invitation and being there today. Moving on, Nilesh, let's move on to the oration.
Can we have the chairperson CV, please? Yeah, so we welcome Padma Shri Dr. Usha Sharma, Madam. She is the ex-Director General Medical Education Committee of Uttar Pradesh, the Principal cum Professor of Obs Gynae at Medical College, Meerut. Welcome, ma'am. We have Senior Professor Emeritus Dr. Chandravati, Madam, here, who has accepted our invite in spite of being little bit ill health. Thank you, ma'am, for coming. She is the Professor Emeritus of Department of Obs and Gynae at KGMC Medical College, Lucknow. She is Director of Krishna Medical Center, Lucknow. We also have Dr. Bharti Dhure Patil, past President of Pune Gynec Society and Vice President of FOXI, HOD Shri Hospital, Pune, and National Vice President of the IFS to chair this session. Welcome, ma'am. And we have our very own General Secretary, dynamic, dashing and beautiful General Secretary, Dr. Vaishali Kordenayak, to chair this session. She is the head of the Department of OBGYN, Maimar Medical College. I welcome the chairpersons and I request you to take this session further. I request Chandravati madam to kindly introduce our speaker for today, which is Professor Mario Franchini.
Thank you, Nilesh. Letting me introduce such a wonderful person. Mario Franchini is one of the leading Italian surgeon and outpatient office protocol hysteroscopic tissue removers, and is famous for that. He is the member of the editorial board for practical guidance of hysteroscopy produced on behalf of Italian gynecological endoscopy. He is actively involved with the training of medical junior doctors with an interest in hysteroscopic surgery. His actual appointment includes position in social Limetta IVF Center, Villa Cherubini, Florence, Italy. Dr. Mario, the stage is for yours. We are all anxious to listen to your wonderful talk on this hysteroscopic seal repair.
Thank you, madam. Thank you to all my great Indian friends. The problem is so far, but last night I decided to have an Indian meal, a vegetarian Indian meal, just to be close to you. And now the feeling is to start with my presentation, and I ask to the organizer to use my already recorded presentation and have much time at the end to discuss and making questions. So please, if you can use my pre-recorded registration presentation, the stage is for that. Thank you.
Thank you, Mario. Thank you for being there, and thank you for putting She the Star as your backside. Thank you.
Good day to all, dear friends. I am Mario Franchini, and I am speaking from Florence, the cradle of Renaissance, and famous for its rare steak, and for special salad with beans and turnip greens. And I think this is good for vegetarians, like many of you in India are. And before beginning my presentation, this is my disclosure, I would like to thank Sunita and the organizing committee for the kind invitation. And I would like to start reminding you that if in the early of 1900s, Pharmacy had not invented his famous incision, and Care had not popularized the incision in English-speaking countries, and 100 years later, Stark had not simplified cesarean scar approach with his method, certainly we would not have had this high number of cesarean sections worldwide. And I agree with you that the responsibility of this high rate is not only linked to this easy to perform technique, and other and more important factors are involved. But this is not the topic of today's discussion between us. However, because Isthmoseal has considered a long-term cesarean section scar complication, the prevalence has increased in recent years as the cesarean scar has increased. And this wide range depends on population studied and evaluation methodology used. And as you can see, there are several ways worldwide to call isthmoseal. And the last one definition, indentation, has been recently achieved by the consensus of European ultrasound experts. And moreover, during the same consensus, all diagnostic criteria to evaluate and measure isthmoseal were standardized. And the committee drew attention to the need to measure residual myometer thickness that plays an important role in the subsequent surgical choice. So don't forget residual myometer thickness. Depending on the stage of labor, isthmoseal can be located just at the cervical uterine junction when an elective surgery has been performed, or in the medium or lower part of cervical canal when the cervix has become part of uterine wall during the active phase of labor. The development of isthmoseal is still unclear, but the data of systematic review and meta-analysis have recently indicated that the prevalence decreases when a double-layer unlocked suture, including the decidua, has used. Generally, cesarean scar defect is an incidental finding during a clinical evaluation. I want to stress that it's important to emphasize that isthmoseal is usually asymptomatic. Women with cesarean scar defect conceive spontaneously and can have a normal vaginal delivery. Only between around 30% of women with niche experience specific symptoms and suprapubic pain induced during our bimanual vaginal examination. And it is being postulated that isthmoseal function like a reservoir collecting blood during menstruation and intermittently expelling after. Furthermore, the accumulation of blood may impair infertility with a negative effect on sperm penetration, embryo implantation, and with a local and inflammation and endometritis. To improve the symptomatology, the first line of treatment is the choice of contraceptives or intrauterine devices, medicated devices. When they fail, the treatment has been proposed to eliminate or reduce the symptoms and reinforce the myometer endurance. You have the opportunity to choose two different ways. The first is transabdominal one, laparoscopic or robotic, vaginal, and which one I prefer is China-like resettoscopic treatment. And this approach was proposed at the beginning of this century in Chile by Cecilia Fabres, in Italy by my friend Gianpietro Gubini. And I can think that you too, we can consider these two guys the pioneers of the technique, using at the beginning 26-27 resettoscope. Only recently, with the introduction of on the market of Gubini system, we can use a 16-15 French resettoscope for performing with a classic approach isthmoseal repair. But the more important thing that we have to take into account is that using small size resettoscope, we can approach with vaginoscopic approach. And we can, in that way, have the possibility to move along the cervical canal in the really anatomy without any modification induced by agar dilatation. So with this approach, we can remove the fibrotic tissue of isthmoseal moving all around the cervical canal. This approach we call a 360-degree treatment. And I want to analyze with you all the steps to better show how we can perform this kind of treatment. And the first step is to visualize the proximal edge, that means is very close to the surgeon, and we have to measure the depth and the width of the niche, and we start to resect the fibrotic tissue moving all around. That means we remove either the fibrotic tissue, inflammatory one, present in the opposite of isthmoseal. The second step is to move to the distal part of isthmoseal, and we start to resect in the same way that fibrotic tissue that in that part, I mean superior distal, is less than in the proximal part. And we move again all around. 306 resection. After that, using a roller ball, we start to eliminate small vessels and inflammatory tissue present in the ceiling, the surface of isthmoseal. We don't care to use monopolar or bipolar energy, but we have it only to take into account that we are in the more dangerous part of the procedure, and we have be careful when we are approaching in that part. Reminded to fill the bladder before starting the procedure with methylene blue, so you have a good opportunity to see if you are performing a perforation during that part of the procedure. Finally, reducing the pressure of inflow, we can check if there is any bleeding along the canal, and we can electrocoagulate any small vessel if it's bleeding. So again, the procedures start, the first step is to treat the proximal edge. After, we move back to the distal part of the niche, and finally we approach to the selling of the isthmosphere. We found no difference in time using 26 or 16, 15 French receptoscope. The time is longer with 26 for the dilatation part, and there were no main inconvenience during the procedure, but we have it only to take into account that the only complications that we had were during the dilatation of the cervical canal with perforation and bleeding later after the surgery. But the main result of hysteroscopic isthmosphere repair are that we can restore the continuity of the cervical canal. And doing this, we can reduce blood accumulation and improve menstrual drainage, and at the end, we can reduce the symptomatology linked to the blood accumulation. So that is the main result that we can obtain with this approach. And finally, some data from Japanese colleagues show that with hysteroscopic approach, the residual millimeter thickness can reinforce. And the data moving from MRI induced to consider hysteroscopic isthmosphere repair the first choice in the treatment. But there is still a great debate on which way we have to choose when residual millimeter thickness is less than 2-3 millimeter, because some studies have suggested an association between a small residual millimeter thickness and the risk of uterine perforation during surgery and the rupture of uterine rupture in the subsequent pregnancy. And for this reason, vaginal or laparoscopic repair could be the first choice because they can reinforce uterine wall. But until now, however, no single case of uterine wall perforation and bladder injuries has been reported independently from the size of residual millimeter thickness. And we can consider that if the procedure has been performed by skilled surgeon and moreover using small size resectoscope, the risk to the surgical risks are very, very low. And therefore, I want to close by saying that as there is an increasing interest in cesarean scar management, we, with my friend Cubini and Paolo Casadio, we believe that that kind of enthusiasm should be directed to prevent isthmus formation, reducing the cesarean scar number, and if we have to treat isthmus we have to choose the least sensational approach. Probably in that way we can do the best to our patient. Thank you so much for your kind attention.
Thank you, Dr. Maria.
Thank you. Okay.
So, and any comments, any suggestions, any debate about that? I am here, so please fight against me.
Thank you very much, Dr. Mario, for a very, very illustrative and informative talk on hysteroscopic repair of the isthmocele. And you have really explained so well the use of mini resectoscope, first step, second step, and third step, how to remove the fibrotic tissue, and then how to maintain the continuation of the cervical canal. These things are really very, very important. The only thing we were thinking that laparoscopic approach can be used if that scar, that uterine niche is big. What do you think?
This depends. If you are really a skilled surgeon, you can perform any one of niche. But I want to stress that if you approach by laparoscopy, okay, you can reinforce only one side of cervical canal, and you cannot eliminate the inflammatory tissue that there is all around. This is the reason why we prefer hysteroscopic approach, because the results either in pregnancy rate, the data are not so huge, but anyway underline that by with the hysteroscopic approach we have a better pregnancy rate after the surgery.
But even if it is big?
Madam, big, if it's too big means that there is the exchange of the suture is not more an isthmocele. This is a different kind of situation. So if it's all the suture, I think it could be better really to approach by laparoscopic or vaginal one. Sure.
No, that's true. It was really wonderful. I can tell you that we have become much wiser what we were till now, because few things we really never knew about this, how we can approach this, how we can do it. And I am sure that all the delegates must have been greatly benefited by your experience. Thank you very much. And I would like to congratulate and thank Dr. Sunita, Dr. Vaishali, Dr. Nilesh for making me a part of such a prestigious keynote address by Dr. Mario. Thank you very much, Dr. Mario. It was really wonderful. I appreciate.
Thank you, Ad. Thank you very much. Thank you. Sunita,
Yes, Mario, I'm absolutely fabulously. I had heard you about this. Only I was thinking, do we suggest infertility patient the laparoscopic approach may be little better? Or you feel it is equally okay? Because I feel when we do, it's okay for a postmenstrual spotting or a menometrorrhagia. But for infertility, first, I have a defect there. Second important thing is I'm cauterizing and going to cause more thinning, and I'm worried equally for the rupture in a subsequent pregnancy. Yes. So if the patient wishes to go for a pregnancy further, I will prefer to do laparoscopically over hysteroscopically. That's what I feel. Of course, you are the expert to guide us.
Yes.
Listen, we had performed a lot of more 800 procedure, and women that desire to become pregnant later had never had a rupture during pregnancy. And the majority, 80%, had cesarean scar around 39 weeks. So we prevent eventually the rupture that can occur only during the active phase of labor. So this is the reason why we have no fear to reinforce a lot the surface of the cervical canal. And furthermore, you have not to forget that removing fibrotic and inflammatory tissue we reduce the chronic endometritis that is always present with isthmus-seal. So now we start to use antibiotic treatment immediately after treatment of isthmus-seal, waiting for CD138 plasma cell test for confirming or not the chronic endometritis. And in this way, we can obtain better results because, again, only with laparoscopic or vaginal, we work only in one part of isthmus-seal and not all around. This is the reason of that kind of approach that with my father Gubini and Paolo Casadio have been taking in the last years.
I think 800 is a huge amount, huge number. You evaluated, you performed, you studied, and you mastered.
Yes, yes.
Thank you.
It's creditable, really.
Huge number.
Huge number.
The data are published on JMIG journal, so you can find that. But anyway, my advice is now to use small diameter resectoscope.
Yes.
There are two in the market at the moment, and more are coming. So, but the best use of this resectoscope is perfect for cervical canal. The anatomy is the real anatomy, so you can go into looking, and there is no distortion induced by dilator. So it's a great opportunity to understand how deep and large.
Yes.
Can I request Dr. Bharti and Vaishali for giving the plaque?
Yes, ma'am. Thank you so much. Can we have the slide of the plaque? Yeah. Thank you so much for your time, your efforts. We really appreciate it. And the token of our appreciation is this plaque. We are very sorry due to COVID, it couldn't reach you today, but very soon you would get it. And the words through which we want to convey our emotions. Thank you for your steadfast commitment and thoughtful guidance. Let our unforgettable gratitude greet you for your unwavering support and unrelenting guidance. In appreciation for your efforts and guidance from POGS President Dr. Sunita Tandurkar, Secretary Dr. Vaishali Kordenayak, and General Clinical Secretary Dr. Nilesh Badkaude, and the whole Pune team. We are very grateful to you. Thank you so much.
Thank you to you, Turki, madam. Thank you.
Bharti madam? Bharti madam, you would like to say something? Okay. Thank you. Thank you so much.
Thank you.
Thank you, Mario. Thank
Ciao,
you for
ciao.
your time.
Thank you so much, Sunita, Vaishali. Thank you so much.
Thank you. Thank you,
It was
Sunita,
a great
Vaishali,
session.
Nilesh, everyone. Usha, Baba.
Bye-bye.
मुलाकात होगी यहाँ मिल गए कम से कम
Great occasion webinar. So we are close, even if we are far.
It's a wonderful,
We have to use a lot that opportunity in the coming years because
Thank you.
we have more opportunity to have a good relationship to keep how the world is going on.
Very nicely explained, Dr. Maria. Really, it was very nice. Thank you so much.
Thank you, Usha ma'am. Thank you, Bharti ma'am. Thank you, Chandravati ma'am. You could make it. We are very grateful. Thank you so much.
Thank you.
I thank all the chairpersons and Professor Mario, the speaker, for this session. Wonderful session on hysteroscopic istomosil repair.
We have just finished with our star oration by Dr. Rishikesh Pai, and now we are going to start with the individual halls, and we all welcome on behalf of Team POGS to the star hall along with my co-MOC, Dr. Pankaj Sarode. We are going to have our first session, which is rapid fire learning, and it's on newer drugs in obstetrics and gynecology. Can I have the slide for the chairpersons, please? Yes. So let me start by introducing today's chairpersons for the first session, Dr. Sudesh Doshi. He is a senior obstetrician with experience of delivering more than 12,000 babies at his Agraj hospital in rural setup at Pandharpur. And he has got special interest in helping everybody with medical legal problems. Welcome, Dr. Sudesh. Dr. Ashwini Bhaleram, she's a consultant gynecologist, senior at Hinduja Hospital, Mumbai, and she's the president of Indian Menopause Society. Welcome, madam. And our own Dr. Pankaj Sarode, who is Vice President, POGS 2021 and 22, and a very dear friend of mine. So without wasting time, let me call upon our first speaker for today, Dr. Sujata Sharma, and she is going to speak on drug safety in pregnancy. We are going to have talks of 10 minutes each. Over to you, Dr. Sujata.
Good afternoon, everyone. For the next 10 minutes, I'll be talking on the topic of drug safety in pregnancy. We know use of drugs in pregnancy requires special attention, and any drug or chemical administered to the mother may cross the placenta unless it is dissolved or altered during the process. The transplacental transport is established at about 8th week of gestation and is dependent on the molecular weight and lipid solubility of the substance. As a general rule, number of drugs prescribed during the pregnancy should be restricted to a minimum. Lowest effective dose should be used, should be given for the shortest time, should be given after inquiring about the LNP and avoided especially during the critical period of organogenesis. The most crucial time period is between day 35 to 55 from LNP because prior to day 35, all cells are totipotent cells. So any insult before day 35 will result in either a missed abortion or will have no effect on the growing embryo. But the irony is that most of our women do not report or consult a doctor until 6 weeks of gestation. And by this time, the organogenesis is well underway. And this is the most critical period for organogenesis. And also remember that drugs may harm the fetus even before pregnancy has been diagnosed. Another important factor to remember is that drugs taken by sexually active men are also secreted in the semen and they may cause fetal problems. And L5 alpha reductase inhibitors like finasteride and glycopyrrolate, they are such examples. And if a man is on glycopyrrolate, he should not father a child within 6 months of treatment. Now, we know there are massive physiological changes in almost all the systems of the mother, and these physiological in pregnancy lead to changes in drug absorption. Absorption because there is delayed gastric emptying, there is a slowing of the gut motility, thereby altering the bioavailability of the drugs. Distribution because of the massive hemodilution, massive increase in plasma volume, there is dilutional effect, thereby affecting the efficacy of the drugs. Metabolism because metabolism is slowed, and also excretion because excretion is accelerated because of a massive increase in renal blood flow and GFR. Now, this increase in the extracellular space and total body water will affect drug efficacy. Another important physiological factor is that there is a decrease in albumin levels during pregnancy, and these decreased albumin levels will result in increased free drug concentration of drugs which are normally bound to albumin, and thereby shortening their elimination half-life. Pharmacokinetics in pregnancy are very important to remember because all the three important steps, that is drug absorption, drug metabolism, and drug excretion, are affected. To address to the problem and to know about various drugs, their safety profiles, the teratogenic effects that they can cause, pregnancy registries and case control surveillance studies have been available, and there are various sites where these are registered. Drug teratogenicity is registered. FDA has its own website. Reprotox is another site. Terrace and Otis are other sites where patients can have information about the toxicity or the teratogenicity of a particular drug. Teratogens, as we know, are the agents which act during embryonic and fetal development and result in permanent alteration of form or function, and they have the potential to develop congenital anomalies in the fetus. So there are various mechanisms of teratogenicity. For example, these drugs can cause disruption of folic acid metabolism. They can result in formation of oxidative intermediates. They can alter fetal genetic composition or genetic mutation, or they can cause chaotic gene expression due to homeobox regulatory genes. Now, these homeobox regulatory genes are very important genes. They are present in all the vertebrates, and these are the genes which are essential to establish positional identity of various body structures from stage to stage. Teratogenicity is the capacity of a drug to cause fetal abnormalities when administered to a pregnant patient, and the extent of embryonic and fetal exposure depends on so many factors. So based on the gestation at exposure, a teratogen can induce either an embryopathy or a fetopathy. So several critical periods are pre-implantation, embryonic from 2nd to 9th week, and fetal from 9th week to term. Now, this pre-implantation period is generally characterized as all or nothing, which means that injury to a large number of cells will predictably cause an embryonic loss, but if only a small number of cells are involved, the embryo is protected through a phenomenon called compensation that facilitates the survival without birth defects. Embryonic stage 3 to 8 weeks is the most important stage because this is the time when most of the embryogenesis Organogenesis is happening and is being completed except for CNS, eyes, teeth, external genitalia, which are completed by 10th week of pregnancy. So exposure to drugs during this critical period can cause greatest risk of major birth defects. But after 8 weeks, most teratogenic effects are related to fetal growth restriction or functional deficits such as mental retardation. To know about the drug toxicity and its effect on the fetus, so various classification systems have been designed. The most commonly and most widely used is the US FDA classification. However, Sweden and Australia also have their own classification systems. The US FDA category A is adequate, well-controlled studies in humans demonstrate no risk to the fetus in first 3 months, and there is no evidence of later risk either. Less than 1% drugs are available in this category. Category B is animal studies indicate no risk, but there are no adequate well-controlled studies in humans, or animal studies show adverse effects, but adequate studies in humans have not demonstrated a risk. Category C is no adequate well-controlled studies in women are available, but there is a potential risk when animal studies have been performed, and these drugs can be used when potential benefits outweigh the potential risks. Category D is there is clear evidence of human fetal risk, but the potential benefit to the mother may be acceptable in a serious condition that cannot be treated effectively with a safer drug. And category X is when both animal and human studies have shown a gross adverse effects, but the risk of use in a pregnant woman will clearly outweigh any possible benefits. Some common drugs with proven teratogenic potentials are ACE inhibitors, carbamazepine, cocaine, anti-cancer drugs, diethylstilbestrol, ethanol, atrinate, and isotretinoin. Now, isotretinoin is very, very notorious because it is used in various skin conditions, is stored below the skin, and is released slowly. So, if the woman is planning pregnancy, she should stop taking this medication at least 4 to 6 weeks before pregnancy. Iodide, lithium, phenidone, tetracycline, valproic acid, warfarin, all are associated with adverse fetal effects. Out of the hormonal agents, corticosteroids, diethylstilbestrol is well known for its adverse effects on the male and the female fetus. Antithyroid, clomiphene, and synthetic progestin. These are the drugs which we very commonly use, but these are the drugs when used in therapeutic doses will not affect the fetus, but when used beyond therapeutic doses and for a longer period of time, they can definitely cause adverse effects. Out of the psychiatric drugs and substance abuse, lithium is one which can cause problems. LSD, alcohol, heroin, and cocaine all are known with adverse effects throughout pregnancy. Anticoagulants have their own side effects. Warfarin and aspirin are the ones which we use very commonly during pregnancy, but warfarin is definitely associated with very well-known warfarin ampliopathy. Some of the drugs used in perinatal period, although we use them on daily basis, oxytocin, misoprostol, prolonged cortisone, NSAIDs, dexamethasone, we are using them as a routine in therapeutic doses, which have been described and found to be very, very safe during pregnancy. But when we go beyond these limits, obviously adverse effects are there with these drugs also. Now, the irony is that despite a plethora of antihypertensive drugs available in the market, there are very few which have been tried and found to be safe in pregnancy. So, methyldopa, labetalol, nifedipine, propranolol, and hydrolysine all are found to be safe during pregnancy. However, propranolol should not be used for a longer time because it can cause IUGR and oligohydramnios. But ACE inhibitors are big no during pregnancy because they do have gross effect on the fetus. Diuretics as a general rule should not be used during pregnancy, but if required, then for a shorter period, short course can be given during pregnancy. We have again a variety of prophylactics available for use during pregnancy. Beta blockers are almost out of use because of their adverse maternal as well as fetal side effects. But magnesium sulfate, which is being commonly used for neoprotection, also can cause lethargy, hypotension, and respiratory depression in the newborn. Calcium channel blockers are found to be very, very safe. Atoxaban, indomethacin, and glyceryl trinitrate again are drugs which need to be used with care and
Hello.
Hello.
Chaitanya sir, please start.
Yeah. Thank you, Dr. Sujata madam. And sorry, we had to introduce the next speaker because of lack of time. I would now request Dr. Vaishali Deshmukh to start her talk. She is going to speak on newer OHA in treatment of diabetes in pregnancy. I would request to stick to the timings. Over to you, Dr. Vaishali.
Thank you, Dr. Ganpule, for the start. And you cannot share the screen is what I'm getting.
Madam, you have pre-recorded your talk and
I'm giving a live talk.
You are giving a live talk.
Yeah.
Ma'am, you can share the screen.
Dominic, can you make her host?
No, we are given the rights. She can share the screen.
Am I visible and audible both?
Yes, you are. Please start.
Yeah.
Absolutely.
Yeah.
Go ahead, ma'am.
So I'll be speaking on newer OHAs in diabetes and pregnancy, and it's my pleasure to share the forum with my friends Dr. Pankaj and Dr. Sudesh, and eminent gynecologists from the country. And thanks POGS for the opportunity. See, I will start with describing what anti-diabetics we have currently in our basket and what has been tried in overall in the anti-diabetic agents in pregnancy. So glibenclamide, glipizide, metformin and voglibose are the ones which have been tested, and at least some data is available. So they form the category B of the drugs that have been used in the pregnancy. All the others fall into the category C. So I'm not going to elaborate more on the category C because we are mainly talking about category D drugs. We all know that before I begin that all these drugs have been tried after the 11th week of pregnancy. So we are overcoming this period of embryogenesis when we are talking on this kind of a forum. So what about the newer agents? Just a slide that DPP-4 inhibitors are also category B drugs, but there is lack of data in pregnancy. So we will not cover this in this talk today, but it is mentioned as it can be used, use is not recommended unless the benefits outweigh the risk to the fetus. So if you have any patients who has conceived on DPP-4, it's not a risk factor, but definitely we don't have more data in pregnancy. What about SGLT2 inhibitors? These are category C drugs. Bromocriptine is a category B drug, but it is not studied for diabetes in pregnancy, so it is not recommended. And glitazones definitely are not advisable in pregnancy considering the teratogenic effects. One thing before I start is that oral drugs are absolutely contraindicated in pregnancy in situations where you have high HbA1c, ketonuria, associated renal or hepatic dysfunction, macrosomia, IUGR, hydramnios, or any antenatal corticosteroid therapy or deterioration of glycemia. So don't try using OHS for this category of patients. We also need to remember that these are the common side effects, whether the patient is pregnant or not. So hypoglycemia, weight gain, lactic acidosis, diarrhea, flatulence are the known side effects of these drugs. So you need to weigh the risk versus the benefit when you're giving it to the patients. So coming to sulfonylurea, the whole story began in the late 19th century, where the history of oral hypoglycemic had development of congenital anomalies with the first generation sulfonylureas, and that's why all the story began. But then came Langer's landmark article where glyburide or which we call as glibenclamide in India, the commonly available Dionel brand. It is known to be an insulin analog, and it's a sulfonylurea. It has an elimination half-life of 5 to 16 hours, so it is truly once a day. Adverse effects are significant. You can see hypoglycemia is 1 to 5%. The dose began with 2.5 and 5 milligram initially once a day, and then up titrating to 20 milligram per day after the 11th week of gestation. It is negligible crossing across placenta, so that's an advantage because it is highly protein bound. So you can use it safely in pregnancy because there is less transfer across placenta. Now, this is the Kramer study, which has actually shown that nearly 81% patients had satisfactory control only with use of glyburide, and most of them required a dose of 7.5 milligram per day or less. 19% still developed macrosomic infants, and their side effects were seen in nearly 11%. I will not read the whole slide, but these are certain safety concerns from maternal and fetal point. The maternal hypoglycemia in women who received insulin was higher as compared to that with glyburide. So insulin gives more hypos, but outcomes are nearly the similar. The transfer is negligible. There is no association between congenital anomalies. Neonatal hypoglycemia is high because, as I said, that it is not very it's highly protein bound, so it is released into the cord blood, and neither glyburide nor glipizide is detected in the breast milk, and there is lack of information on long-term outcomes. So it is not the first-line therapy in patients, though you want to use a OHA. Coming to metformin, it is known to be an insulin sensitizer. Effect may take 2 weeks. Dose is beginning from 500 to 2500. It is mainly acting through the liver. It's excreted in the urine, has a half-life of 6 hours. Efficacy in pregnancy has been proven in various RCTs, and you can see that there is a high failure rate also. So nearly 30 to 40% do report failure with metformin alone, and they require insulin on top of it. A serious side effect is lactic acidosis, and vitamin B12 deficiency nearly develops in 30% of cases after 3 months of therapy duration. It crosses the placenta freely, and it is negligibly bound to the protein. Again, coming to the maternal and fetal safety concerns, the weight gain and pregnancy induced hypertension rates were lower in patients who are on metformin. The average gestational age at delivery also was lower in the metformin group. It is known to be freely crossing the placenta but not teratogenic. The pregnancy MITI trial, the landmark trial which was released in Lancet of 2018, showed that the primary outcome was not really different between the groups, but there were improvements in the maternal glycemic profile and adiposity in the neonate. Lactation wise, it is a safe drug, but long-term wise, there is no data available beyond 2 years of age. So it has a healthier fat distribution, though, in the neonates who are born eventually. So if you see this comparative chart, to understand, insulin doesn't cross significantly, glyburide doesn't cross significantly, but metformin does cross. Weight gain is not likely to occur with metformin. Hypoglycemia is rare with metformin. Gastrointestinal side effects are more with metformin. And of course, the benefit of oral usage with the OHAs are there. So I'm not here to tell about insulin, but definitely it needs to be compared accordingly. So one advantage of glyburide when compared to insulin is that glyburide was not detected in the serum of the cord blood. So this was an important finding in the Langer study, though the Langer study had a lot of limitation in terms of not able to use in the first trimester. We had not studied type 2 diabetes who are conceiving. And
Sorry to interrupt, doctor. 3 minutes left. Thank you.
Yeah, thank you. So it did not evaluate other hypoglycemic agents also. So what about metformin versus glyburide? So they found significantly lower weight gain in the metformin as compared to glyburide group. The difference was significant as neonatal weight, and if you see that nearly 34% did not achieve good control with metformin vis-a-vis 16%, and they required insulin eventually. Cesarean deliveries were higher with metformin group in various meta-analysis. Alpha glucoside inhibitor. So it is the postprandial glucose. It is known to have less than 2% absorption in the maternal circulation, and labor is likely to be induced because it is known to enhance prostaglandin secretions in the gut. So it is better to avoid until a lot of safety data is available. There is only one Mexican study which shows 6 pregnancies which delivered normally, but intestinal discomfort was there throughout. Now, choice of OHA currently lies between the 3, and I have explained the benefits and drawbacks of the 3. So, pros and cons need to be understood. That pros are it's cost effective, patient friendly, potential compliance enhancing therapy. Outcomes are nearly the same as compared to insulin. There may be a greater risk to fetus in withholding certain medications than the risk of keeping them hyperglycemic, and the current evidence shows that it is good as insulin. Cons is that potential adverse effect of the fetus and paucity of data is there, and drug regulations and legalities are not yet properly mentioned in guidelines. So what are the current recommendations? The first line therapy by all guidelines says it's insulin. Second line is metformin or metformin and glyburide. And there is no third choice as of now in guidelines. To summarize, oral agents are not routinely recommended. It's insulin is the first line. Reserve all oral agents only for those select who refuse insulin and mild degree of hyperglycemia, or those who have not been able to take insulin specifically. No specific preference between the 2 drugs. but you need to remember that they may need add-on insulin when it is being used. The thorough counseling and documentation as a part of legality is needed, and RCTs are needed for further data in the long run. Thank you so much for the patient listening.
Thank you, Dr. Vaishali. Moving on, I would like to call upon Dr. Komal Chavan, who is going to speak on COVID-19, which drugs can we offer in pregnancy. I would request all the speakers to stay back because we are going to have a question answer session at the end of the session. Over to you, Dr. Komal.
Yeah, thank you so much. Hello, everybody. I would like to thank Dr. Sunita Tandulwarkar and Pune Obstetrics and Gynec Society for this kind invitation for making me a part of STAR conference. The topic which I'm going to speak is on COVID-19, which drugs can be offered in pregnancy. As we all know, the second wave of COVID-19 is ongoing, and so many of our pregnant patients are getting tested COVID positive. And there is always a dilemma regarding which drug therapy we can give to these patients. Pregnant patients with a lot of comorbidities like obesity, diabetes, heart disease are also getting tested positive, and they are at risk more than the one which are not having any comorbidities. And the risk as in increased ICU admission, mechanical ventilation, also increased chance of anxiety and depression, many studies have shown. So we need to offer the right treatment to them, and what drug therapy we can give in pregnancy. We definitely have limitations because of the FDA classification. Most of the drugs are contraindicated during pregnancy, or so many drugs are under experimental use and they have unknown adverse effects. So what we will discuss is some drugs which have been enrolled in various trials and have been discussed by clinical studies, and one which are actually recommended and safe in pregnancy. So how do we get the evidence for management? And this was an overview based on the CDC, ACOG, and Society of Maternal and Fetal Medicines. And they said that we definitely need to have a shared decision making between the patient, the clinical team regarding the safety of the medication, safety for the woman as well as the fetus. And many antivirals and immune-based therapies were selected to form the guidelines. But what was the main drawback was the most of the clinical trials, they excluded or included a very few pregnant women and lactating women. So we definitely have less reports from all these clinical trials, and we need to have more and more trials with pregnant women as they are in their study. So drugs for COVID, when the COVID virus came, and so many drugs were tried in different parts of the world, and the list is endless, ranging from antipyretic, anti-inflammatory, multivitamins, steroids, anticoagulants, antivirals, even anti-malarial, antibiotics, convalescent plasma, immunomodulatory agents, and interferons. But when we talk for its role in pregnancy, we have limited safe drugs which are actually safe in pregnancy. So we need to use in caution the high dose of antipyretic, anti-inflammatory, and steroids. Whereas antiviral, convalescent plasma, immunomodulatory agent, and interferons are contraindicated by most of the guidelines, even our guidelines by Government of India. The new and emerging respiratory virus threat advisory group actually have listed, that is the NERV tag, they have listed an investigational medicinal products which are recommended by various clinical trials. And they also say that additional treatment options are likely to emerge as more and more scientific and clinical understanding of COVID-19 is going to improve. The recommendation for use of pregnant and postpartum patients with COVID-19 of the medications administered routinely in pregnancy. These include the antenatal corticosteroid, which we are giving to our pregnant patient for fetal lung maturation. Magnesium sulfate, which is given for neuroprotection or in cases of respiratory distress. Then NCIs, which are used, that is low-dose aspirin, for prevention of placental-mediated complications. Indomethacin is used as a tocolytic agent, and NCH also for analgesia. So all these recommended drugs which we give in pregnancy are used for COVID-19 and have to be given as per various studies. What about the steroid rule? The recovery trial, which is the trial which has revolutionized the role of steroid for COVID management, has changed the entire outlook. Thus shows a significant reduction in 28 days mortality for individuals with COVID-19 requiring oxygen therapy. And recovery trial protocol for pregnant women also recommends prednisolone 40 mg orally once daily. And in women unable to take the oral medication, hydrocortisone 80 mg intravenously was used. So, definitely, pregnant women requiring oxygen ventilatory support, we give dexamethasone as it is given in general population, that is 6 mg daily for 10 days. And even when there is a risk of preterm labor, we can give dexamethasone, betamethasone for lung maturity in the same doses as we give for the steroid prophylaxis for lung maturity. Then coming to the NSAIDs, the only preferred and the safer is paracetamol, which is an antipyretic agent. Thromboprophylaxis in pregnant women is definitely recommended as COVID-19 shows high rate of thrombotic complication, and pregnancy also is a prothrombotic state. So there is an increased risk of thrombosis, and there are two manifest mechanisms, that is pulmonary microvascular thrombosis and hospital-associated venous thromboembolism. So low molecular weight heparin is something which is recommended for all admitted patients with COVID-19 related complication or any obstetric complication. And heparin is relatively safe for use in pregnancy as well as lactation. So unfractionated heparin can be used in a dose of 5,000 units subcutaneously every 12 hourly for patients who are near term or about to deliver. Also, enoxaparin 40 mg daily can be given for patients who are likely to deliver, or for the postpartum patient, it can actually be continued till COVID titer is positive. Then antiviral, remdesivir, lopinavir, ritonavir combination, flavipavir are all tried for treatment of COVID, and so many studies from different countries have come regarding roles of this antiviral. Remdesivir is something which is even any layman or everybody knows remdesivir because of the drug being the drug for treatment of COVID, and the shortage of this drug is a point of worry for everybody. And remdesivir is an adenosine analog, earlier tried for Ebola. It is given as an IV infusion, though nephrotoxic. It can be given for life-threatening complications of COVID-19 as a single dose of 200 mg loading dose followed by 100 mg daily IV infusion for 10 days. The Solidarity trial, which has a series of 86 women who were given remdesivir on compassionate basis, said there were rates of preterm delivery, but a high rate of clinical recovery was found in this patient. So they said that remdesivir can be given in pregnancy if the benefit outweighs the potential risk. Lopinavir ritonavir combination. Actually, these drugs were used for treatment of HIV, but China used it for COVID-19. Lopinavir is FDA non-categorized, so the safety is questionable. But ritonavir is a category B drug, so can be used in pregnancy. Flavipavir is something which we are giving in and out for treatment of non-pregnant COVID patients. It is a pyrazine carboxamide derivative and acts on viral RNA-dependent RNA polymerase, causing chain termination and preventing RNA elongation. The dose is 1800 mg BD on the day 1, followed by 800 mg BD for a total of 7 to 14 days. But this drug also is contraindicated in pregnancy and breastfeeding and not recommended by our GI guidelines in pregnancy. Empiric treatment for bacterial pneumonia in selected patients is actually given for all patients who are diagnosed with COVID-19. Even if there are any CT changes or a chest imaging changes, low procalcitonin level may be helpful in suggestion against bacterial pneumonia or patients who are in seriously ill. A choice of antibiotic can be given as per the hospital policy, but in pregnancy, the safer alternatives are the azithromycin, amoxicillin, and ceftriaxone. Chloroquine and its
Thank you, Dr. Komal, for that talk on which drugs can be offered in pregnancy and COVID-19. Moving on, I would like to invite our next speaker, Dr. Arun Borua. He's going to speak on selective progesterone receptor modulators in endometriosis. Over to you, Dr. Arun. Thank you.
You deserve to be in a higher positions in Foxy as well.
Thank you, ma'am. Thank you so much.
Yeah, I think. Thank you so much for asking me to make this presentation, which is so relevant in today's setting. Selective progesterone receptor modulators in endometriosis is an upcoming medical management which has a wider scope in comparison to the existing medical therapy that we have in endometriosis. We are all aware that endometriosis has kept every one of us in a puzzling state, and we are more than sure that this is going to keep us in the same affair maybe for a few more decades, because nothing has really improved beyond a certain point other than the medical management. So it is time for us to know what are the options that are upcoming in the medical management of endometriosis. Yes, surgery has an important role in management of endometriosis, but today we need to know that we have to optimize surgical interference and minimize it to at least the best possible outlook time, and this could be in any part of her reproductive life. Now, coming to the topic, what exactly do you mean by selective progesterone receptor modulator? What exactly is the molecule? It is an agent which is acting on the progesterone receptors that exist in the reproductive system of the woman. This could be either agonist or an antagonist, and we also have to appreciate that a full agonist like progesterone and a full antagonist like mifepristone, they exert their action through progesterone receptors that are set up wide across the reproductive organs in the female, including breast and the uterus. So we have a role of these SPRMs which modulate the conformational chains that determines the activation of co-activators or co-repressors. And depending upon the relative proportion of co-activator and co-repressor, which are modulated totally by SPRMs, and the cellular environment they are acting upon, we get the final result of either gene transcription or gene downregulation. If you look into the history, this molecule of progesterone receptor modulators has been a recent inclusion, and mifepristone has been widely used, extensively practiced for different other indications, and today we are looking into this molecule as an important parameter of treating endometriosis in different age groups, and more so in adolescent age group, because they have a wider margins of treatment duration in comparison to the late adults, which may be having a minimized time frame for interference, or even they can opt for surgical interference as well. So we have mifepristone, we have esopristol, telapristone, and ulipristal has been in the kitty for quite some time, and many of us have used it for different indications. However, a new molecule, vilapristin, has also come in, and we take up this all one by one to see which fits in today's contest. So the progesterone receptor antagonism has been set into this pyramid, and where the progesterone has been a progesterone receptor agonist at the top, and a mifepristone is the progesterone receptor antagonist looking at the bottom of the prism. We have to understand that there are different other molecules in between, and we'll just discuss one by one the mechanism of action of these selective progesterone receptor modulators. So mifepristone has a higher binding affinity to the human progesterone receptor to the tune of 100% in comparison to the progesterone, which is only around 43%. It has anti-proliferative and anti-progesterone effect of mifepristone on the primary endometrial and also the endometriosis cells that do have lost in different parts of the pelvis or even beyond. Mifepristone to progesterone receptor were 5-fold higher than the mifepristone metabolite metapristone. The weak binding affinity for the androgen receptor and a no affinity for the estrogen receptor or mineralocorticoid receptors makes it ideal. The studies have demonstrated that anti-proliferative effect of mifepristone in endometrial cells by decreasing expression of progesterone receptors, increasing expression of androgen receptors, and no change in the estrogen receptor expression levels. Phase 1 and Phase 2 trials are on, and the results that have been summed up: after 3 months of treatment, the prevalence of dysmenorrhea decreased in 10% when you use 2.5 milligram doses compared to the placebo group. Amenorrhea was reported in 78.7% with 2.5 milligram, 97.8% with 5 milligram, and 98.9% with the 10 milligram doses in patients where it is being used in comparison with the placebo. Adverse events such as hot flashes, nausea, vomiting, and fatigue were reported in a significant number of patients compared to the placebo group. Next molecule is esopristnil. It has demonstrated 3-fold greater binding affinity to progesterone receptor than progesterone in the human, or not basically in a rabbit uterus. Primary metabolite, the demethylated esopristnil, which is also known as J912, showed high binding affinity to progesterone receptor compared to progesterone. Again, the phase 2 clinical trials have been evaluated.
Thank you, Dr. Arun, for your talk on selective progesterone receptor modulators in endometriosis. Moving on, we will ask Dr. Meeta Gupta to start her presentation on medical management of cholestasis in pregnancy. Over to you, Dr. Meeta.
Thank you, sir. Am I audible? Sir, I'm saying that you cannot share your screen.
Please share it now, ma'am.
Okay.
Please put it in the slideshow. Yes.
Is it okay?
Yes.
Okay. Thank you, sir. At the onset, I would like to thank and congratulate the new POGS team and Parag sir for giving me this opportunity. I have been given the task of talking about medical management of obstetric cholestasis. Just a brief introduction, that it is the most common but reversible type of hormonally influenced cholestasis, develops in later half of pregnancy and in females who have a genetic predisposition. The incidence in India is reported to be 0.02% to 2.4%. The pathophysiology, though unknown, is multifactorial. It involves genetic, environmental, and hormonal factors. Genetic, because family clustering of cases are seen. Environmental, because most severe cases are seen in winter seasons and is also associated with selenium deficiency. Hormonal, the sex hormones, especially estrogen, is the culprit because it exerts cholestatic effect via inhibition of the hepatocellular bile salt export pump, thus leading to increase of two bile salts, the taurocholic and taurodeoxycholic acids. The risk factors would be personal family history, multiple pregnancy, gallstones, or a carrier state of hepatitis C. The symptoms are varied. It starts with sudden onset of pruritus, especially in palms and soles, with no skin manifestation and abnormal liver function test. Sometimes the pruritus is so severe that it may lead to insomnia. It may be associated with other features like pale stool, dark urine, and jaundice. Jaundice occurs 2 weeks later and is seen in usually only 50% of the cases. Why we are discussing this is because of the associated maternal and fetal complications. The maternal complications may be presenting with intense pruritus, leading to sleep deprivation, increased chances of cesarean section, increased risk of postpartum hemorrhage, and in long-standing cases, leads to liver dysfunction, leading to prolongation of prothrombin time. The fetal complications may vary from preterm delivery, either spontaneous or iatrogenic, meconium staining of the amniotic fluid, sudden fetal death, and increased chances of perinatal mortality. It is to be noted that no specific method of antenatal fetal monitoring can predict fetal death. Ultrasound and cardiotopography are also not reliable methods in preventing fetal death. Coming to the medical management, it involves local therapy and systemic therapy. In local therapy, tropical emollients are safe, but their efficacy is unknown. Steroid cream, calamine lotion, aqueous cream with menthol may be used. They provide slight but temporary relief in pruritus. The systemic therapy is given with the aim to relieve pruritus. Cholestyramine is poorly tolerated bile acid chelating agent, but improves pruritus in many women. It also exacerbates or increases the chances of vitamin K deficiency. Antihistaminics like chlorpheniramine may give some sedation at night, but has no significant effect of pruritus. The activated charcoal or guar gum, though used, do not give any relief in pruritus. Coming to the drug therapy, ursodeoxycholic acid, the mechanism of action is by the hydrophobic bile acid, which replaces the more cytotoxic bile acids. It is used in the dose of about 10 to 15 milligram per kg body weight in divided doses, decreases pruritus and the bile acid levels, and also improves fetal outcome. Cholestyramine is an anion exchange resin binding bile acids in the intestine for fetal excretion. The dose is maximum about 16 gram per day in divided doses before meals, decreases pruritus, but also decreases the vitamin K absorption and has no effect on fetal prognosis. Dexamethasone, the mechanism of action is by surpassing the fetoplacental estrogen production that decreases the bile acid levels. The dose is about 10 milligram orally for 7 days and then is tapered and finally stopped for over 3 days. It decreases the pruritus and has no effect on fetal prognosis. Phenobarbital, it acts by hepatic microsomal enzyme action to decrease the bile acids. Dose is 2 to 5 milligram per kg body weight and it decreases pruritus in about 50% of the cases. Has no improvement in the abnormal lab test or fetal outcome. Vitamin K is required for synthesis of the clotting factors 2, 7, 9 and 10. Use in the dose of 5 to 10 milligram intramuscular before delivery, and it decreases the risk of abruption and postpartum hemorrhage. S-adenosylmethionine, it decreases the negative effect of estradiol on the bile flow and increases the availability of sulfates to detox the bile acids. Used in the dose of 800 milligram intravenously over 3 hours, decreases the bile acids, pruritus and amniotransferases. But similar improvement is not seen in very advanced or severe cases of obstetric cholestasis. It should be noted that there is insignificant evidence to suggest the effectiveness of S-adenosylmethionine for either control of maternal symptoms or improving the fetal outcome. Dexamethasone should not be used as the first line of treatment. Just to go a little bit more on ursodeoxycholic acid, it is the drug of choice and is used in the doses of 600 milligram to 2 gram, and it has been shown to be effective in reducing the pruritus, the total bile acid levels, ALT levels, and the bilirubin levels, thus leading to delivery closer to term. It also improves the ratio of cholic acid and chenodeoxycholic acid. It is not associated with any significant maternal adverse effects, and a very small infant follow-up study of 26 children over a period of 12 years did not show any long-term sequelae in these children. The mechanism of action is by displacing the more hydrophobic endogenous bile salts from the bile acid pool. It protects the hepatocyte membrane from the damaging toxicity of the bile salts, enhances the bile acid clearance across the placenta from the fetus, has colorectic effect, cytoprotection of the injured bile duct epithelial cells, that is the cholangiocytes, against the
Sorry to interrupt, doctor. Last 3 minutes left. Thank you.
Okay. It is effective in a meta-analysis. It has been shown to be effective in reducing the pruritus and improves the liver function tests. What's new is that a combination of ursodeoxycholic acid and rifampicin is the new second line of treatment. They enhance the bile acid detoxification as well as the bilirubin concentration. They increase the excretion of bilirubin gluconides by increasing the gene expression of MRP2 expression. Heparin, rifampicin, and newer nor-ursodeoxycholic acid are all currently under investigation for use of obstetric cholestasis. Just a word on when to deliver. The women should be counseled regarding induction of labor after 37 completed weeks, and steroid should be considered for lung maturity. They have to be warned about the risk of recurrence in their later pregnancies, which is about 45 to 70%. These females should not be given oral contraceptive pills containing estrogen, and if they want to have it, they should be given the lowest possible dose. If any patient develops cholestasis with use of oral contraceptive pills, they should be warned about the occurrence of obstetric cholestasis in their respective pregnancy. A little bit about postnatal care, that breastfeeding should be encouraged. Liver function tests should be monitored 10 days postnatally, and postnatal resolution of symptoms and biochemical abnormalities is required to secure the diagnosis. Thank you.
Thank you, Dr. Mitra.
Thank you, sir.
I would now request the chairpersons to ask all the speakers if they have any questions. There are no questions from the delegates as such. Over to you. Ashwini madam, Dr. Sudesh and Dr. Pankaj.
Dr. Sunita, can I say something?
Of course, Sarita.
I'm Ashwini.
Ashwini, sorry.
So thank you for organizing this conference. Only one comment I would like to put, that the topics are so vast, but they are so good that this time is not enough for them. And I
understand. I understand.
In between, and not to allow to present the whole thing. I think it is not we are giving justice to the speakers.
I have put
whose presentation couldn't be completed.
Ashwini,
organize a separate workshop with all those speakers, and they can talk properly and have a good discussion.
Ashwini, can I talk to you and can I interrupt, please?
But increase the time.
Yes, Ashwini, can I talk to you?
Yeah.
I do understand. And we all, if you go through our entire sessions, you will see that there was 15 minutes after every talk. But India is studded with fabulous speakers, and we wanted everyone to be there. So what we have done is we got their recorded video, and just now I put on a faculty group that all those videos videos, we are putting it and we are sending the link of these lectures to all registered candidate within a week. We have already prepared those letters and all, because fabulous. Even I wrote there, I'm enjoying obstetrics. Anyway, let's not take the academic.
And also the pre-recorded slides are not visible properly.
I think
if it is a slide share live done, the material is read properly. But if it is pre-recorded slides, they are not at all clear. So I
do understand.
You have just started your year, so you can improve on these points.
Ashwini, I highly take your suggestions better. And if the videos were asked for 10 minutes and if they have received for 15 minutes, then unfortunately, the conference team is taking a call, or the chairperson and the organizers have to take a call. So we request everyone to give a recorded videos of the allotted time only. You decide which are the important points you want to convey it. That is also art. I do understand. It's difficult. But I requested everyone to send only those time allotted videos. I can request chairperson to move on.
If there are anything, the chairpersons, I would like you to conclude this session. Ashwini madam.
No, I have already said my whatever comments.
Sudesh, Dr. Sudesh and Dr. Pankaj, I would like you also to have a word.
Hello.
Yes, Pankaj. Hello.
Hello.
Yeah, Pankaj. You can. Yes.
Yes, Pankaj.
Your voice is breaking in between. No.
Sir, please take the mic closer to your mouth. Hello.
Pankaj, we are not able to hear you. I think Pankaj wants to say he must have enjoyed this session, because in obstetrics, I'm also enjoying this. Dr. Meeta ji, superb. Komal, your, everyone from Latika, we started and it's all tremendous. I think 3 days we are revisiting the MD OBGYN residency. And I see Dr. Mahesh Gupta waiting, so we can start with our session, Chaitanya.
Meeta ma'am for the kind words.
Thank you so much. Your selective progesterone receptors, fabulously you covered your topic. Thank you so much. Komal, it's always nice to see you.
Thank you. On behalf of Team POJs, I would like to thank Thank you, the chairpersons and all the speakers for this session. I would like to thank on behalf of Team POJs for being there. Before moving on to the next session, we have our quiz number 3.
Yes,
going to be taken by Dr. Nilesh. And before that, I would like to announce the winner of quiz 2 in Star Hall, and she's our own from Pune, Dr. Anuja Fadke. So a big hand of applause for her. A small request: when you're sending the answers on the WhatsApp, please write the hall name, Star Hall, and then your option A, B, C, D, E, because sending just an option is not going to work, because we don't know from which hall you are sending it. So please write the name of the hall and then the option number, option alphabet, A, B, C, or D. Over to you, Nilesh.
Hello friends, it's wonderful to receive such huge number of responses from all of you. I again welcome you to this third quiz of this hall. We all been witnessing this star event, and the logo of our year POGS 2021 is She the Star. Star stands for sassy, talented, ageless, and resilient. So as is this star conference, where star is safety, technology, advances, and research, on which we have our mega quiz. So welcome you all for the mega quiz Kaun Banega Star, which is scheduled in the Obstetric and Gynecology halls. You can win CTG machine in the Obstetric hall and telescope in Gynecology hall. So be prepared for that. There are always new grander challenges to confront, and a true winner will embrace each one of them. So the correct answer to the second question, which was asked in this previous session, according to ESHRE guidelines 2017 for RPL, which of the following, all of the following are true, except the correct answer is office hysteroscopy plus imaging is inferior to laparoscopy, whereas it is mentioned in ESHRE guidelines that it is superior to laparoscopy. So congratulations all winners. Champions don't show up to get everything they want. They show up to give everything they have. Congratulations once again. Here are the rules for you before we go on to the third question. You have to choose the most correct option. Prize will be given to the person answering correctly and quickly on a first come first serve basis. You have to WhatsApp me the correct answer on this number 8446206075. Remember this number because you have to WhatsApp me here. One person will be eligible for only one prize in this hourly quiz. All can participate in the mega quiz, which is scheduled in the Obstetrics and Gynecology halls at 5 p.m. today. Are you ready for the third question? Yeah. So following is true regarding elagolix. Which of the following statements is true? It is a peptide small molecule gonadotropin releasing hormone receptor antagonist. It is the first new oral therapy to be approved for treatment of endometriosis associated pain in the United States. Modulation of estradiol with elagolix is partial. Elagolix approved doses are 1000 milligram per day. So which amongst these is the most correct statement you have to give? The time has started. You have to answer me on my WhatsApp number 8446206075. And you have to answer it immediately. Concentrate on the question because there are some minute things which you should not miss. Last 5 seconds. Thank you for actively participating in this quiz.
Thank you, Nilesh, and we would be waiting for the answer for that question. I would now like Dr. Pankaj Sarode, my co-MOC, to take over for the further sessions of the day. Over to you, Pankaj.
So could you please continue because there is some issue, audio issue.
I think I will continue with the session. Now, the next session is on the solution room. Ask me anything, AMA, and for this I would like to invite the chairpersons, Dr. Sanjeev Khut, Dr. Vivekanand, and Dr. Neeraj Jadhav. Can we have the slide, please? Dr. Sanjeev Khut is past president of POGS. He is a senior IVF consultant from Pune, and he is coordinator West Zone for the Endometriosis Committee. Dr. Vivekananda is professor and head of the department at the OBGYN department, Prathima Institute of Medical Sciences, Nagar. He is a founding member of Justosis India, and he is co-chair of PPTCT Guidelines NACO 2010. Dr. Neeraj Jadhav is the chairperson for Sexual Medicine Committee, FOXY. He is a vice president of Rajkot Menopause Society and past president of Rajkot OBGYN Society. I would now like to have our first speakers, managing antepartum hemorrhage at Periphery, Dr. Mahesh Gupta, and the moderator is going to be Dr. Shantanu.
Dr. Mahesh, please start. Please start sharing your screen. So, yeah, please put it in the slideshow mode. Thank you.
Hello, good afternoon, everyone. Am I audible there?
Yes,
yes,
you are audible.
Yes, yeah, thank you. At the outset, I am thankful. At the outset, I am thankful to Dr. Sunita for providing me an opportunity to speak about the APH. But at the same time, she made my talk difficult by adding a management at the periphery level. And because I know Sunita, she is very particular, because I work with her at the IAG Ahmedabad conference as a chairperson with the American Endoscopy Society. She is very particular about everything. And again, congratulations to Dr. Sunita and her team. So it is a management of periphery level at the APH. So there is no point in discussing some Google images or textbook images or slide share. So I'll discuss the APH with the case-based scenario. At the periphery or at your nursing home level, if there is a primary para with 28 weeks of pregnancy and mild bleeding per vagina, where the vitals are normal, uterus is relaxed, and the fetal heart sound is regular. So here our aim is to prolong this pregnancy till the age of gestation. So we have to rule out our small causes or unclassified causes of the APH here. So that is a marginal sinus rupture, that is a SHO, that is cervicitis, that is trauma, that is varicosity, that is tumor, cervical tumor, that may be the hematuria, or that may be the oozing from the os tightening stitch. So these are the unclassified causes of the antepartum hemorrhage, where what we have to rule out, and then we can prolong this pregnancy very well. After doing all these normal investigations and normal blood reports, we can pull on this pregnancy. If we go for a second case scenario where it is a primary para, full term almost 38 weeks pregnancy, uterus is mildly irritable, the fetal heart sound is normal, and mild to moderate bleeding. So these are the cases where we encounter generally in our practice. Here, the routine vitals are normal. If the previous ultrasound scan is present, then it made our diagnosis and our management very simple. Then if not, then we have to confirm the diagnosis. In this case, we find a two case scenario. When the placenta is normally situated at the fundus, or placenta is situated at the low lying, that is the placenta previa. So if placenta is low lying and if it is a placenta previa, then the management is different. If there is a placenta situated at the fundal region and there is a separation or abruption, that will be a concealed bleeding or a revealed bleeding, then the situation is different. Now if we take up first condition, or the placenta, it is a placenta previa bleed. Now in placenta previa bleed, we don't have other option. If it is a complete or major degree placenta previa, then the surgical delivery is the only option. And when the placenta is marginal and not covering the os, then watchful trial with augmentation and induction can be given. So in this both the scenario, if we are going for a surgery in the case of placenta previa in primary para, because it is unscarred uterus, so we are little relieved. Because it is unscarred uterus, the chances of placenta accreta or chances of placental adhesion syndrome is less. So here, before going for a cesarean section, we generally send blood for baseline investigations. We send a cross match for blood sample. We take a large bore IV cannula. Expert help or SOS call or professional colleague to assist is helpful. Presence of neonatologist is required. Then we prefer a spinal anesthesia with prior fluid replacement. Suture material should be there for a uterine closure, or if there is an injury to the bladder, then we may require a thinner suture material. It should be there. We should use a hair antibiotic. A person should also be well accustomed with the devascularization technique if there is a lower segment ooze or lower segment bleeding, or a lower separate techniques to control the lower segment bleeding. This person should be well versed to avoid the obstetric hysterectomy that I'll show in my next videos. And of course, the high risk consent for obstetric hysterectomy is to be taken. So these are the cases where we are going for a cesarean section. Now, if we take a case of abruptio placenta and it is not a cesarean, placenta previa, then the things might be difficult, or things may go unwarranted, or things may take unwarranted twist. So here baseline investigation is to be done along with a coagulation factors like PT, APTT and INR. Sample for cross-match is to be sent, and accordingly report of the blood, these baseline investigations and PTA, PTT, INR, we have to arrange the blood and blood products. And if we consider the obstetric management in case of abruptio placenta, then the standard technique is amniotomy with induction and augmentation of the labor with heart rate monitoring. In all these cases, when they deliver, the prophylactic ergotonics is also to be always to be given, preferably to have a ready Bakary balloon or some devices which can give intrauterine pressure to control the PPH, because the chances of PPH is more in such cases. So our gynecologist should be prepared with all these kind of the facilities when they are tackling with this type of the cases. And the postpartum period is also very, very crucial in such a case, because when there is a history of APH, there are chances of history of PPH. Now cesarean section is required. The coagulation profile is must preoperatively. In case the fetal heart, for fetal reason, we are going for cesarean section. In abruptio placenta, the coagulation profile should be done preoperatively, and accordingly we have to order the blood and blood products. In cases of massive hemorrhage, generally it is to be given in the proportion of 1:1:1. That is, 1 is a packed cell volume, 1 is a platelet-rich concentrate, and 1 is a FFP. Here, usually the general anesthesia is preferred for want of the coagulation disorder. Otherwise, we may puncture the spinal vessels. The cavity drain, peritoneal drain, and suture side drain may be required. And according to the clinical estimation of the blood loss and blood reports, the blood and blood products should be used. If there is altered coagulation factor, then patient is to be managed in critical care unit. Now, in generally, these patients are to be followed in critical care unit by the prognostic value of this prothrombin time, then APTT and INR and platelet. Here, our aim is to maintain the HB more than 8. Our aim is to maintain platelet count more than 50,000. Our aim to maintain the fibrinogen level more than 100, and our aim to maintain the INR more than 1.5. So accordingly, we have to give the blood and blood products. Now we are coming on the cases of where there are severe APH, severe antepartum hemorrhage, and these are the cases which requires a tremendous courage, which requires tremendous the facilities. Where there is a severe APH, if suppose it is a full-term pregnancy, severe blood clots are passing per vagina, uterus is tense, and cervix is non-dilated. Now there are usually a problem what to do. Just I'll share you one video of such case with you, that where you can you can anticipate the amount of the amount of blood. Here you can appreciate the amount of blood loss in cases of accidental hemorrhage, where the 2 suction drains are also insufficient to suck out the blood. And here you will see that how large the retroplacental clot along with a reveal bleeding was present. So if you are taking, see, this was a retroplacental clot. So if you are tackling such kind of the cases, it requires a little multi-speciality kind of approach. And here you need to go for some kind of devascularization technique to prevent the PPH also. The one more case of accidental hemorrhage, severe accidental hemorrhage, where the cesarean section was done, where I am showing the video. Generally in our operation theater, we generally don't push the fetus or we don't allow anesthetist or assistant to push the fetus. Generally the fetus is coming out by itself. It's like a swimming, the fetus is coming out, and after coming out the fetus by this technique, generally the uterus.
We are not able to see your video.
Chances of the PPH is also less if we are following this protocol. Now here you can see, you will witness how the large placental retroplacental hematoma was present.
Hello, sorry to interrupt you, sir.
It is more. The blood clot was even 2 times bigger than the placenta. So these are the cases where you require courage and the facility. So here, when we are going for a cesarean section, in this kind of the cases, we have a thorough preoperative investigations. In preoperative investigations, generally I include one investigation from each system. See, from hepatobiliary system, we generally include liver enzymes and bilirubin. When we are going for a urinary system, we are going for creatinine. When we are going for a coagulation, then we are going for PT, APTT, and INR, and we are going for fibrinogen at the same time. And accordingly, we give a blood and blood products. And for anesthesia perspective, also here the general anesthesia is must, and all the high risk consent and all the consent for obstetric hysterectomy is also to be taken. And these cases, there should be a little modification in the operative steps. Before completing your cesarean section, you should go for some kind of devascularization surgery, or you should go for some kind of compression suture to prevent the bleeding. Now, if we take another case scenario, it is a third para with 35 weeks of pregnancy. It is again painless vaginal bleeding, but here the word of caution is previous to cesarean section with live birth. And in only positive finding was a central placenta previa during anomaly scan. So when you are dealing with any case of APH, you should be certain of the history part, whether it is previously scarred uterus with lower insertion of the placenta, because it is said that unless otherwise proved, all central placenta previa in previous CS or in previous myomectomy cases or in previous 2 or 3 CS cases, placenta accreta or other placental adhesion spectrums should be suspected. And if there is on sonography, if you find there is bulging on the bladder side, there is a convexity on the bladder side with multiple lacuna, with this kind of vasculature, you should think of placenta accreta. And this kind of the cases now, because of it, now it is increasing day by day because of the number of the cesarean section is increasing. Because of the ART techniques are more popular, and every gynecologist is coming or confronting this kind of the cases. So it is the first question is when to operate. So at 34, 35 weeks, this case is to be operated. It needs multidisciplinary approach with the presence of urologists, presence of neonatologists, presence of good assistants. It should be done. Preferably the central venous line or arterial line is to be taken. Blood and blood products should be available beforehand. The general anesthesia is given. There is a debate in skin incision that it is whether it is a vertical incision or transverse incision or fenestrial incision is to be given. It is depending upon the surgeon's choice, one can give it. But the one practical point is you should be mentally prepared before you are taking this kind of the cases. You are mentally prepared for either obstetric hysterectomy or mentally prepare for any untoward or unwarranted twist. So that's why if you are mentally prepared, then you can tackle any situations. And it requires a high risk setup with multi-speciality approach. So if you have proper time, then you have to refer these cases from your periphery to the central some multi-speciality unit. Because here post-operative care is equally important. And if at all you are stuck up at your place with this kind of the case, when you open this case and if you see this kind of the placenta, where the lower segment is almost has been eaten up by the placenta, and you see the placenta only, then I usually put a transverse phalangeal incision always, but it little above, and uterus also I put a transverse incision that is above the edge of the placenta. And because this placenta is low, that placenta will push the fetal head little above. So if you put an incision on little upper side, then you can easily take out the fetus. So one can take the placenta easily. Now, just this 2 minutes video, I will show you that if you find this kind of the cases, then how you can prevent the obstetric hysterectomy, or how can you can prevent the bleeding. So in this case, if you evidence that there is absolute no bleeding after the delivery of the fetus, still placenta is inside, but there is no bleeding because the placenta is attached to the myometrium. So here I am taking both the uterine very low, and after taking both the uterine, I am removing this placenta. This placenta is attached to the myometrium. It is
Mahesh,
not
we can't
percreta.
see your video. We can't see your video, Mahesh.
Pardon?
Your video is not seen.
It's not seen?
No.
Hello?
Hello?
Chaitanya, can you see the video?
No, madam. We tried to tell him in between as well that your videos are not visible. None of the videos were visible throughout.
Mahesh, videos
sir,
are so important and they are not seen.
Sorry to interrupt, sir. Please share the video screen. Please share the video screen. Click on the video and you will see while sharing the screen. Please stop sharing.
He was so engrossed in his talk that we tried to tell him a couple of times, but
You know, Chaitanya, what I suggest is this is a novel session where 15 minutes is the talk.
Yeah.
And as of now, there are no questions which has come.
No.
So we give him a 30 minutes or 25 minutes.
Sure.
No, but how I can share my video, because these are in
You know, every time you have to stop share and you have to share your videos. So on a background, you should make your videos all on.
Oh.
Make the videos on background. Every time you have to stop share and you have to, otherwise you should play. This session is 15 minutes of your talk and 15 minutes is active question.
Yeah.
So we give you two minutes because it is very important. One message has come. We would love to see the video. So
That's
give
true.
time for the video. So we
So this video is now visible?
No. Now you share the screen. Now we can't see anyone. We are seeing only we all. Now again make a share screen on. Dominic, you can guide please.
Now?
We'll see. It's going sharing. Yes.
Can you see this video now?
Yes.
Yes, sir, we can see it
Every
now.
time,
So
Mahesh,
this is the
you have
case.
to stop the screen. You have to reshare. Okay? Go ahead.
But it will be very difficult then.
So you have to speak.
So this was a case of placenta accreta anyway.
You can speak.
So here I used to put an incision more on the upper side of the uterus and then take out the fetus. I will not disturb the placenta and uterine wall. So there won't be much bleeding. So now every time I have to go.
Yes, sir.
Unfortunately, yes.
Hello.
Yeah.
Open all videos on background and one after the other. We could see your this just video where you showed us go on a higher incision so that you don't disturb placenta and you can directly reach out to the head. We got this message and we got that video.
Now this one more video where after taking out the placenta, if there is bleeding, then just to insert the cervical dilator in the cervix and just you pass a needle from front to back from a lower edge of the uterus from anterior to posteriorly and then posterior to anterior. If you take this 2 stitch, then this is a cervical dilator which is going in the cervix. So that's how the cervical canal will remain patent and all the bleeding will stop within 5 minutes. So these are all newly developed technique by me. At the posteriorly on the either side of the cervical canal, I am tying this stitch at low as possible. And I'll show you how it works.
Sir, have you started sharing again?
No. Just a minute. See, this was a case of placenta accreta where the placenta was removed. There was a bleeding from lower edge. On both the side, I put a cervico-ischemic stitch, and you see the effect. This is the effect. Now it is totally dry out. So that's how we can prevent unnecessary obstetric hysterectomy. We can prevent unnecessary morbidity to the uterus, and all bleeding will stop. So so meantime, now if there is 5-6 minutes left, we can go for a discussion.
Yeah, Pankaj.
Hello, am I audible?
Yes.
So that was a nice presentation, although we missed few of your videos. We would like to highlight more here, taking into consideration a situation where we are operating on a patient at a periphery.
Yeah.
Few points wherein a doctor is operating, the blood bank is not easily accessible, the tertiary care is also far off. So what precautions one should take, and which are the cases which one should not operate at such places?
Yeah, there are 2-3 points I want to emphasize. That for a patient and patient relatives, you are not at periphery and you are not in CT and you are not in multispeciality.
Right.
For a patient and patient relative, that is a patient. And the life of the patient is same in periphery and at the center.
Yes.
So every qualified gynecologist must learn something to save the life of the patient. That is the first thing.
Correct.
Because at periphery also we can't give ourselves excuse that this facility is not available. Because now in days of this, India is now 135 crore people. And now all the cities are within reach to the periphery. So that is the one thing. But certain cases, definitely if you have a time to sift that patient at a proper time. If suppose a case of placenta increta or percreta or accreta, if you have sufficient time, then you can definitely sift her, because these cases can behave like a bomb. And same with accidental hemorrhage, a massive accidental hemorrhage, that also can behave like the right thing. So if you have time, you can sift, no issue. But suppose if you have taken that case without diagnosing, and if you end up with such kind of the surgery, then what you have to do, that you have to learn. And that is a message and aim of this kind of the conferences.
Right.
Otherwise, excuse is always given that facility was not available but for patient and patient relative, that is not an excuse. They will go for definitely in the way what they want to go.
Sir, in case of APH, when you have delivered the fetus and the uterus is nicely contracted, and you're not having active bleeding from the site as well, placental site as well. Even then, should we go for an elective devascularization in every case?
I prefer to go for my Comoc MG technique. See, because now there are enough data which suggest that if you are going for a prophylactic bleeding or if you are going for a prophylactic devascularization, the fertility is not hampered. There are enough data now. So this patient can bleed at any time. So once the abdomen is open, that I prefer to go for a devascularization technique in such cases.
What kind of devascularization you prefer? You train ligation with
I prefer
internal ilia.
Yeah, if it is an upper segment bleed, in case of accidental hemorrhage, if it is an upper segment bleed, for me it is a uterine bleed is either upper segment or lower segment. That is very simple. Because in accidental hemorrhage it is an upper segment bleed, and in placenta previa bleed it is a lower segment.
Yes.
Yeah. So upper segment bleed, it is a different spectrum of surgery, and lower segment bleed, it is a different spectrum of surgery. So in upper segment bleed, usually
Sorry to interrupt. Last 2 minutes left. Thank you.
Yeah, thank you. So if you are going for upper segment bleed, then I go for my technique, that is compression and occlusion technique. And if you are going for a lower segment ooze, then what the technique I had shown, that is putting a cervical dilator, take a straight needle and pass, take a 2 stitch on either side of the cervix, as low as possible after dissecting bladder down. So whatever the blood vessels are coming from below up, that will be taken care of, and the bleeding will 100% stop.
So we have to go inside out, outside in, and inside out.
No. It is from exterior. Once the bladder is separated, bladder is separated from exterior, interiorly, from exterior we are going through and through posterior.
Even the posterior wall?
Yes.
Oh,
yes.
Okay. Oh,
yes.
Okay.
So put a cervical dilator. So cervix will not accidentally close. Go straight from anterior to posterior with a straight needle as low as possible, maybe isthmus or maybe at the cervix, and you go laterally also and tie at the posteriorly just below or just at the level of uterosacral, your stitch will come. So all the lower segment bleed will stop by this 2 stitch. That is for sure.
Okay.
So unnecessary obstetric hysterectomy can be avoided.
Okay. Pankaj, you want to ask?
I think we are short of time. Otherwise, I would have loved to see the video.
I know.
I'm very sorry.
If you can share the video with us, that would be good, because it's something
We will post it on our YouTube
seen
when we are uploading.
Otherwise, also Mahesh, everything is going on the group. So on a YouTube, we would love to have your presentation redone. Insert the videos beforehand. And we move on with another expert of PPH, Sheila Mane, known in the country for it.
And thank you, Sunita, for this opportunity. Thank you very much.
Love to see you and love to have you. PPH, when we talk about, you and Sheila always come in front, you know, always. And you're,
Thank you, Mahesh sir, for that wonderful presentation. Pankaj, would you like to take over?
Sir, may I call upon Dr. Sheila Mane Madam to talk on conservative management of PPROM, whether it's a fact or a hype?
Yeah.
Over to you, Madam.
Can you see my screen?
Yes, ma'am.
Yeah, thank you.
But the content is getting cut, ma'am. Can you please go to the first slide?
Yeah, I don't know what is happening with my, you are not able to see?
Please stop sharing once.
Stop share, huh?
Yeah, stop the entire slideshow.
Okay.
Yeah, please go to the slideshow now, PPT.
Again, I share screen.
So just go to the PPT first. Yeah, share screen and go to the PowerPoint presentation.
I don't know, this problem is happening with me. Since,
yeah, can you enable editing on the top?
yeah. Thank you. So thank you, Dr. Sunita. Hearty congratulations to POGS team as well as...
Sorry to interrupt, ma'am. I hope you are on the first slide. Is that the first slide?
Yeah.
Yeah, perfect. Thank you. Please go ahead.
Thank you. Yeah, thank you. So thank you very much for this opportunity and hearty congratulations. A great workshops. Yesterday you had excellent workshops and also today the scientific program. Okay. And I must say that I'm very happy to be a part of this academic session. So my topic, conservative management of PPROM, fact or hype. The definition of PPROM, Now, if we take pre-labor rupture of membranes, it is defined as spontaneous rupture of membranes at 37 weeks of gestation before the onset of contractions. And preterm pre-labor rupture of membranes is defined as spontaneous rupture of membrane at less than 37 weeks of gestation, at least 1 hour before the onset of contractions. Now, WHO preterm birth categorization is extremely preterm is less than 28 weeks, very preterm is 28 to 32 weeks, and moderately preterm is a late preterm birth between 34 to 37 weeks. Now, pre-viable preterm PROM, which can happen in less than 24 weeks, okay? And mid-trimester premature rupture of membranes is between 16 and 26 weeks of gestation. Now, the incidence, PROM 5 to 10% of all term pregnancies, PPROM 1 to 5% of pregnancies, and that is 1/3 of preterm delivery. So it's more common in preterm deliveries. Now, incidence of PPROM in different gestational age, if we look at 1.5% at 34 to 37 weeks, 1% at 26 and 34 weeks, and 0.5% between 16 and 26 weeks. Now, the consequences of PPROM, maternal consequences, intrauterine infection before and after delivery is a potential threat. Clinical chorioamniotis, these are the criteria to diagnose this. Presence of 2 or more of the following. Maternal pyrexia more than 38 degrees centigrade or 100.4 degree Fahrenheit. Maternal tachycardia more than 100 beats per minute. Leukocytosis more than 15,000 count. Uterine tenderness, offensively smelling vaginal discharge, and fetal tachycardia more than 160 beats per minute. Histological chorioamniotitis, histological changes in the amniotic and chorionic membrane of the placenta, and that is called as phenocitis, that is leukocyte infiltration of umbilical vessel wall or even Wharton's jelly. Now, chorioamnionitis increases the incidence of cesarean section. There is 2 to 4-fold increased risk of endometritis, also increases wound infection, pelvic abscess, bacteremia, and postpartum hemorrhage. 1% of maternal sepsis, higher incidence with pre-viable PROM, okay, where the pregnancy is managed expectantly. Placental abruption, 5% of cases. Ischemic lesions in decidua cause decidual necrosis, vascular disruption, and bleeding. Increase the maternal risk of massive blood loss and maternal coagulopathy due to secondary disseminated intravascular coagulation. Now, preterm labor symptoms are always there, and there are multiple factors like infection, inflammation, uteroplacental ischemia, hemorrhage, uterine overdistension, stress, immunologically mediated processes, infections, and tobacco are more frequently reported. That is even smoking. Now, the fetal and neonatal effects. Intrauterine infection, bacteria enter the fetal environment by vaginal, transplacental, could be hematogenous, abdominal, or iatrogenic. Suppose if amniocentesis is performed. Earlier gestational ages and unstable lie of the fetus, non-descended position of the fetus, there could be a risk of cord compression as well as cord prolapse. Fetal inflammatory response syndrome is diagnosed where the fetal plasma you will find interleukin-6 level more than 11 picogram per ml. And histopathologically, again, there could be phenicitis and chorionic vasculitis, that is again infiltration of the amniotic membrane with leukocytes. Higher incidence of neonatal sepsis, bronchopulmonary dysplasia, and cerebral palsy. Most commonly causes respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, cystic periventricular leukomalacia. In women with uncomplicated PPROM between 28 and 33 weeks, prolonged latency increases the risk of adverse neonatal outcome in every gestational age. So if the latency is prolonged, there will be more neonatal risk. Now, if we look at this, chorioamnionitis is there, or there is phenicitis histologically. The maternal and neonatal sepsis can lead to even morbidity and death. Maternal inflammation, can increase the cytokines, chemokines, interleukin 1, 6, 8, tissue necrotic factor alpha and MMP, and that can again cause fetal inflammation. So if there is a maternal inflammation, there is again a fetal inflammation, and which is called as fetal inflammation response. Now, due to maternal inflammation, there is a prostaglandin release, cervical changes, weakened membrane, can lead to preterm labor and PPROM and preterm birth. Again, FIRS, fetal neonatal brain and multi-organ injury can happen if there is an inflammation in the fetus. Again, can lead to perinatal death and long-term morbidities, including cerebral palsy. So coming to the management, history of PPROM, previous PPROM again is important. It is the strongest predictor of PPROM. Preterm labor in consecutive pregnancies almost 17 to 32%. Other risk factors include short cervical length, cigarette smoking, drug abuse, low socioeconomic status, and low body mass index. With a previous PPROM history, longitudinal cervical length measurement of TVS must. If significant shortening at early gestation age, then we may have to go for either cerclage or pessary. On suspicious history of PPROM, sterile vaginal speculum examination is done. Abdominal ultrasound is done for amniotic fluid index. EF, that is assessed to fetal weight, biophysical profile, presenting part, as well as congenital anomalies. Digital vaginal examination is best avoided unless expected labor, because they have seen that with digital examination, the latency period was reduced by almost a week. So it is best to avoid digital vaginal examination, and it is associated with a shorter interval between PPROM and delivery when compared to sterile speculum examination. Now, on sterile speculum examination, you can find pooling of amniotic fluid during speculum examination, alkaline pH determination, microscopic evidence of burning, more prone false positives due to vaginal contamination, either with blood, urine, or semen. Insulin-like growth factor binding protein 1 can find, and gold standard is intraamniotic injection of indigo caramine. Now, hospital admission is advised between 24 and 34 weeks. Regular monitoring of maternal and fetal condition, non-reassuring fetal status, indication for delivery. Clinical chorioamnionitis, indication for delivery. C-reactive protein is not routine for accurate diagnosis of chorioamnionitis. Maternal biomarkers have not been better to predict the subclinical disease, and is a late sign in clinical chorioamnionitis. So when we are talking about biophysical profile in the fetus with chorioamnionitis, when the mother is not having clinical signs but the fetus is having inflammation, one of the important signs on biophysical profile is one should look at the respiration. And if the fetus has infection, if the fetus is infected, if the fetus has pyrexia, the first thing to disappear on biophysical profile is the respiration, and which is diagnostic of chorioamnionitis and affecting the fetus. So, absence of respiration in the fetus. Now, antenatal corticosteroids. Majority of female with PPROM will deliver within 7 days. Infection plays an important role as cause or consequences of PROM. Single course of corticosteroid is recommended from gestational age 26 weeks until 34 weeks in case of threatened labor. The optimal timing of corticosteroid needs to be planned because of duration of the effect of corticosteroid is approximately 7 to 10 days. And if the delivery does not occur within 7 to 14 days, a single retreatment course can be administered in case of persistent threatened preterm labor with gestational age till 33 weeks, except in maternal chorioamnionitis, is the recommendation by ACOG. RCOG recommends second course only, first course is given at gestational age less than 26 weeks. The choice of antenatal corticosteroids, betamethasone and dexamethasone, have both been acceptable options, offering differing by only one methyl group and cross placenta without getting metabolized by placental enzyme. Standard treatment consists of 2 12 mg doses of betamethasone given intramuscularly 24 hours apart, or 4 6 mg dosage of dexamethasone administered intramuscularly every 12 hours. Best effect is expected 24 hours after the last dose. And most trials globally have been done with celestazone, which is a combination, celestone ray, which is a combination of betamethasone acetate and betamethasone sodium phosphate. In India, the only preparation available is betnesol, which contains only betamethasone sodium phosphate. Hence, the use of this preparation is not expected to show similar results, and that is why we have shifted to dexamethasone. Antibiotics and tocolytics, the use of antibiotics routinely is not advocated. It has to be individualized. That is, depends on the clinical signs of infection or group B streptococcal status. National Institute of Child Health and Human Development and Maternal Fetal Medicine Unit study of PROM and the Oracle trial with IV antibiotics, that is ampicillin 2 grams 6 hourly and erythromycin 250 milligram 6 hourly, or oral amoxicillin 250 milligram 8 hourly and enteric-coated erythromycin base 333 milligram 8 hourly for a 7 days course of antibiotic therapy. The treated group had lower neonatal morbidity. Now, tocolytic therapy is used between 24 and 34 weeks in order to delay preterm delivery for a minimum of 48 hours to allow administration of antenatal corticosteroids for fetal maturation and maternal transfer to tertiary center. Now, there are some reports of membrane repair. Tissue sealants have become important in maintaining surgical hemostasis and stimulating wound healing. So, Deliger and colleagues have reviewed the efficacy of sealants in repair of fetal membrane defects such as ruptured membrane, but not many studies available. And tissue sealants are products that bind to and close the defect in tissue. Antenatal magnesium sulfate, mechanism of action. Magnesium is fourth most prevalent ion in the humankind, plays a major role in multiple physiological process. Mechanism involved in neuroprotection is anti-inflammatory and anti-excitotoxic properties of magnesium sulfate. By non-competitive inhibition of NMDA receptor, reduces the excitotoxic injury to the glutamase release by decreasing the influx of calcium. And the decreased influx of calcium reduces apoptosis of neurons, and magnesium sulfate causes reduced expression of glutamate in the ischemic region of brain. So the use of antenatal administration demonstrated the positive effect on the incidence of cerebral palsy. Optimal dosage still need to be determined. WHO, ACOG, NICE have adopted the administration of MaxSulf in preterm birth for fetal neuroprotection. The recommended dose is 4 gram IV followed by a maintenance dose of 1 gram per hour for 12 to 24 hours. Coming to the plan of care, which is very important. Gestational age less than 24 weeks, incidence 0.5%, induction of labor or elective delivery, and neonatal risk. Yes, perinatal mortality, serious neonatal morbidity due to prematurity. Inexpectant management can lead to intrauterine infection, neonatal sepsis, cord prolapse, intrauterine death, placental abruption, pulmonary hypoplasia because it's a very early gestation and contractures. Counseling, you need obstetrician and neurologist. Hospital admission, if it is a mild leak, you can ask the patient to observe at home. Corticosteroids are not recommended. Antibiotics, there is an incomplete data on use in prolonging latency. Magnesium sulfate is not recommended. Tocolysis, there is no consensus. So options, expectant management or termination of pregnancy. If it is a very late gestation, you will have to look at the amount of liquor because if it is anhydramnios, then there is no point in continuing the pregnancy, and you will have to also watch for signs of infection. 24 to 33 weeks, incidence 1%. Induction of labor or elective delivery, neonatal risk are perinatal mortality, serious neonatal morbidity due to prematurity, expectant management. Again, intrauterine infection, neonatal sepsis, cord prolapse, intrauterine death or placental abruption. Hospital admission is required. Corticosteroid single course is recommended. Antibiotics, yes. Again, group B streptococcal prophylaxis, magnesium sulfate until 32 weeks, tocolysis for intrauterine transfer, or if you are waiting for the corticosteroids to get effective. And management options are expectant management. 34 to 36 weeks, 1.5% incidence, neonatal morbidity due to prematurity if you induce or deliver immediately. Expectant management, again, intrauterine infection and neonatal sepsis. Counseling, yes, neonatologists also to be involved. Hospital admission, I will say must be 34, 36 weeks. Corticosteroids, some experts still recommend. Antibiotics, again, plus selected cases plus group B streptococcal prophylaxis. Magnesium sulfate after 34 weeks, no consensus. Tocolysis, no consensus. Management options, either expectant management or elective delivery. So specific management is determined by gestational age related to intrauterine infection and prematurity. There are two treatment approaches: expectant management with surveillance of maternal and fetal condition, and delivery by either induction of labor or cesarean section. If we look at the different studies, the risk factor and perinatal outcome associated with latency in preterm premature rupture of membranes between 24 to 34 weeks of gestation by Atale-Akin et al. On conclusion of this study, gestational age at PPRM or twin gestation, oligohydramnios significantly affected the latency period. Although a latency period of more than 72 hours was associated with chorioamnionitis, placental abruption, and adverse neonatal outcomes were not affected. That was between 24 to 34 weeks. Factors and outcome associated with longer latency in preterm PPROM. On conclusion of this study, earlier gestational age at the time of PPRM is associated with longer latency duration, in which in turn is not associated with increased neonatal sepsis or chorioamnionitis. Again, PPROM, does the duration of latency influence the perinatal outcome? By Tracy A. Manak et al. On conclusion of this study, latency does not appear to worsen the outcomes in pregnancy that are complicated by preterm premature rupture of membranes. Again, management of PRM before 25 weeks, very early. On conclusion of this study, expectant management can be widely suggested to patients. However, termination of pregnancy is acceptable in cases with a poor prognosis, including anamnias and premature rupture of membrane before 21 weeks of pregnancy. Again, this is the conservative management of PPRM between 18 and 23 weeks. On conclusion of this study, conservative management of PPROM prior to 21 weeks gestation associated with very poor pregnancy outcome. Although survival improved significantly after 22 weeks, all infants suffered major neonatal morbidity. And not only the survival rate, what is important in this is the taking home the intact baby, and most of the babies died after 1 year. And also they found that there was so much of neurological deficit. Induction versus expectant management in PPRM with amniotic fluid, with mature amniotic fluid, that means the lung maturity, a randomized trial at 32 to 36 weeks by Brain and Mercer. Among women with PPRM at 32 to 34 weeks with mature suspectant profile, immediate induction of labor reduces the duration of hospitalization and infection in both mother and neonates. So what is that we have seen here is that definitely there were studies where they found that in patients with less than 25 weeks, they could gain 11 days. In that, 41% infants survived to age of 1 year, 27% were neurologically normal. Liman and Associated found no improved neonatal outcome with expectant management beyond 33. McElra and co-workers found prolonged latency after membrane rupture was not associated with an increased incidence of fetal neurological damage. And Carroll and co-worker observed no cases of pulmonary hypoplasia in fetuses born after membrane rupture at 24 weeks or beyond. So this suggests that 23 weeks or less is the threshold for lung hypoplasia. And Levis and Associates found that expectant management of women with preterm ruptured membranes and non-cephalic presentation was associated with increased rate of umbilical cord prolapse, especially before 26 weeks. So on the overall conclusion of the studies, with the limited extensive studies available, the expectant management of PPRM in early gestation age less than 24 weeks is not associated with significant neonatal benefits. Between 24 to 34 has a significant benefit with expectant management in the form of improved neonatal survival, irrespective of the latency period from rupture of membrane, but had increased incidence of chorioamnionitis and placental abruption. From 32 weeks onward gestational age, there was no increased advantage from expectant management. So, less than 24 weeks, no significant neonatal benefits. 24 to 32 weeks, significant benefits with expectant management. And more than 32 weeks, there is no increased advantage of prolonging the latency. So, these are the facts and which are evidence-based. Thank you very much for your patience here.
Thank you, madam. May I invite sir to comment on?
Yeah, okay. Deepak Bhatt there. Thanks, Pankaj. Am I audible?
Yes,
Yes, sir, you are.
Yes,
Oh,
sir, very much.
Sheila, that was hi, Sunita. Thank you very much for
You are very much audible.
getting me here, and Pankaj and everyone.
Sheila, wonderful.
Okay, Sheila, that was a fantastic thing. Yeah, it was wonderful. Say, she was very clear before 24 weeks and after 32 weeks, deliver. My question is about between 24 and 32 weeks. 24 and 40, I mean 24 to 28, I'll still be very skeptical, you see. I really don't know
Yeah,
whether I will really
particularly
go for expectant management.
See, if we have
In
to
our
say
country.
less than 28 weeks, for our country, it is still a pre-viable stage, because it all depends on the NICU care and taking home an intact baby.
Yes,
Okay?
so I think you put that very rightly, intact baby. And your study only showed that only 27% were neurologically okay. So, we are taking risk with another 73%. Is it really worth it?
Yeah.
Second thing is, okay, I would like to discuss a case. There was a twin pregnancy, IVF conceived, 42 years. She had a premature rupture around 26 weeks. One of the babies delivered, say it was a dichorionic pregnancy. One baby delivered, and me being a bold person and having listened to people like you, that you go for an expectant management, I said, okay, fine, let's wait for this baby, we go for an expectant mother. I had a very catastrophic time, let me tell you. Patient almost went into a septic shock. Are we really prepared to take that risk, frankly, for a baby of 26 weeks? We are going to get only about 10 days, but in those 10 days, what can happen to mother? Can you really imagine that thing? Any setup, let me tell you. Okay, I was in a private setup. I'm sure there must be a better setup also. No PV examination, taken all the precautions, had cut the cord very short, so that, that also infection was not there. A sterile pad, TCDC every day, but then on 7th day, the patient really almost went into a septic shock.
That's what I said. That chorea amnionitis, my mother may not have fever, but still she will have chorea amnionitis.
So the question is, how much really you would like, at what stage would you like to go for expectant management? I personally feel,
between 28 to 33 is ideal for our country.
28 to 30, and not more than 48 hours. To me, I wouldn't really go for 7 hours or 10 days. Let me tell you very frankly, if I feel that baby is going to survive 28 weeks, I would not really like to take it. Yes, Dr. Alka is here, Sunita is here. I'm sure they will also tell whether would you really like to go.
They are IVF pregnancies. They are so precious,
Sorry to interrupt.
You have to admit them, you have to manage them.
Not
Last 3
more
minutes
than
left, ma'am. Thank you.
Yeah, that's fine. Not more than the mother's life, I'm sure about it.
No, that is sure.
Yes.
That is sure. See,
so
you
I
have
say,
to keep a low profile for sepsis. You have to keep a low profile for sepsis. You have to go on monitoring them regularly. Okay, as I said, C-reactive protein is not going to help you. So the tachycardia, the pulse rate of the mother is a very good indicator, and also the fetal tachycardia. And I told you on BPP, it is the respiration which is the first one to go away if the baby is also having hypothermia because of the infection. Now,
I think
and now there is always no infection of the amniotic fluid.
The steroids to work and deliver.
Yeah, and there is always no infection of the amniotic fluid. Sometimes it is just an inflammatory response.
Can you highlight something about resealing? Anyone has tried resealing?
I just found one study. That's all, and I don't think there are many studies, and I haven't heard of it.
So they said the cryoprecipitates and the platelets help. These things will help only in the patients when it is an iatrogenic. The other is infective. In those cases, it's not going to help. So iatrogenic substance may help. The other thing, what I found in literature was, if you are going to deliver a preterm baby, infuse some saline so that at least she has a liquor around the baby when you are delivering. Let's have that kind of thing. And what is your idea? The last thing is okay. Yes, it is going to be anadromous. And the last thing is, what is your idea about amnio infusion? The time is short. I think we'll cut it short. The idea of amnio infusion for a very preterm premature rupture of membranes. Amnio infusion.
See, for a very preterm baby with for amnio infusion, already if there is a chorioamnionitis and the no liquor left, I think it will be better to deliver by a cesarean section. Because this very preterm baby may not withstand the stress of labor. Okay, and already there is an infection. By introducing again doing amnio infusion, there will be more chances of infection. The patient will take more time to deliver. I will prefer.
Sheila, with my experience, I mean, for whatever little experience I have, I'm not going to wait for more than 48 hours for delivering that baby. But in these 48 hours, would you like me to amnio infuse this patient? Would you like me to put some saline in this patient?
If it is chorioamnionitis, no.
It's not a chorioamnionitis. It is not a chorioamnionitis. It is a simple PPROM. I'm going to wait for 48 hours. Would you like me to put saline in this baby for next 48 hours?
At least I will not.
I think it's not required. It's not required because those 48 hours are not going to make much difference, and probably you might.
That latency is not going to help you.
Yeah. Fine. Thank you very much, everyone. It was wonderful to be here. Sunita, thank you for having us here. And as usual, with Sheila, it was a wonderful session. Thank you very much.
Thank you, Dr. Alka. Nice
Such a nice interaction and enlightening discussion. And may I call upon our next speaker, Dr. Alka Kriplani, madam, for a talk on managing adherent placentas. Over to you, madam.
Hi, Alka ji.
Hi. What happened?
Ma'am, the PowerPoint is minimized down there at the bottom menu. Please click on that. Next to that, yes. Left, yes. Please click on that. Yes, please put it in the slideshow mode.
This is Pankaj helping me? Who is helping me?
No, that's Neerav Parmar from Conference.
Oh, thank
Please
you.
Go to the first slide, ma'am.
No, this is not the first slide. I was just checking the video. Are the slides moving?
Yes, they are moving.
Yes, ma'am. Very much.
Thank you so much. First of all, I must thank Sunita Tendulkar. It is not she the star. It is the Sunita. She is the star. What a exhaustive program. It's not program. It is an elaborated, project. And thank you, Dr. Pankaj Sarode. And I saw my friends Sheila and Deepak. It's a pleasure nowadays. हम तरस गए हैं अपने दोस्तों से मिलने और देखने के लिए. Thank you very much, my dear student Amol, who helped me in getting this link. And without wasting time, since it is getting late, it is 4:11 already, I will start with the topic given to me is adherent placenta. So this is, everybody will agree with me, is a new problem and in obstetricians nightmare. So much of research because of necessity is going on. I was at All India Institute. I was getting every week a case getting referred from far off, India, international. They were so scared. They were coming and getting admitted for weeks and months till they delivered. And now I'm in practice. Still I'm getting so many adherent placentas and we cannot keep them admitted. So I will just discuss my own experiences. So nowadays we call this placenta accreta spectrum because so many cases are coming thanks to increased cesarean section rates. So we all know it can be accreta, increta or percreta. And it is not a new problem. From early 19th century it is there. But what is happening now, it is getting common and common. Am I audible? Everything okay?
Yes, ma'am. Yes, ma'am.
Thank you so much. So now we have coined this term past, placenta accreta spectrum. In fact, today only I was sitting with my MRI people because I got a patient referred with past 3B with bladder involvement. So I was sitting with my radiologist trying to learn from where the blood supply is coming. He said that anterior uterine segment lower is totally deficient. So it's very important you assess and understand what you are going to go in for. Nowadays, ultrasounds, they give you a good clue. MRI may not be very necessary or available, but finalities, you can have a good idea of what you are going to deal with. It's not an uncommon problem, as you can see here. Which patients are high risk for placenta accreta? Now people are delaying fertility, so many IVF pregnancies, they are getting in initial years so many MTPs, hysteroscopic adenolysis, history of manual removal of placenta, hysteroscopic surgery. All these manipulations or anything which is, you are doing something to endometrium may make it vulnerable in the next time when the conceptor comes, there is, abnormal adherence of the conceptors and adherent placenta. And this is very important, the topic so close to my heart, cesarean scar pregnancies. If you nicely do ultrasound, the problem is our colleagues, radiologist colleagues, they write in it, but they fail to, interpret that how serious is the situation. Many obstetrician friends, and they don't take note of cesarean scar pregnancy because these only isthmosine leading to scar pregnancy, that leading to placenta accreta is a very common occurrence which we are facing. Majority of patients have history of 1, 2 or 3 previous cesarean section. So why we fear so much this problem of placenta accreta? Because these are the problems which may occur. Huge blood transfusion need, bladder injury, ureter injury, patients need for ICU admission. Today only I have counseled that couple, then you have to tell them you might have to call for a urologist. At All India Institute, it was not a big problem. You just go in the nearby theatre and catch hold of anybody. So you have to really prepare before taking a case of placenta accreta to give optimum outcome. Need for ICU admission, and if it is past 3B, as I said today, I saw. So you have to really counsel the patient. There maybe we remove the bladder wall along with the involvement that we have seen gives better results. And then if you do very, very mammoth surgeries, venous thromboembolism, surgical site infection, and certain risk of mortality is also there. So this is a huge list of complications depending on how serious is the situation. So colleagues, it's very important that any previous scar patient, you get a good ultrasound and reasonably, make the diagnosis whether it is accreta, increta or percreta. So antenatal diagnosis, then you can refer her to a person who is used to doing it. It is not for an occasional, it is not for a youngster. You really have to have a good team. By good team, you may be a very good surgeon. A patient was referred to me at 37 weeks. So I told everybody this is not the way. She may go in labor now. So you have to, and if she goes in labor in the night time, you need to have good blood bank where you can have good amount of blood available all the time. You have to have very good experienced anesthetist team. And at All India Institute, we were blessed. We have all those radiologists who are willing to do their projects with balloon inflations and embolizations. But I'll discuss in a minute. Those things may not be as necessary as your understanding surgical and the teamwork. So MRI is not very necessary, but MRI really helps you making a reasonable diagnosis what you are going to find. Today they told me midline there are a lot of vessels. If you give incision at the fundus on the left side, you may encounter less blood loss. So these are the things which prepare you. So prenatal diagnosis, I won't go into diagnostics. Everybody knows there may be loss of lower segment. Always get a color Doppler done. This will give you an idea how much are the size of the vessels and from where they are coming up. It is not the uterine, I fear. It is the pelvic floor. All those colleagues who are doing these cases in reasonable number will agree with me. Sometimes it is very simple and sometimes you are in a mess. And the mess is when blood supply is coming from the pelvic floor. The moment you touch bladder, that coagula goes away and she starts pouring. So these things are very important. MRI, as I said, is gives you a little better information, but we cannot make it as a rule because we know these cases in the periphery also, so MRI may not be available. And you may diagnose a minor degree at vaginal delivery where placenta, refuses to come out, and it is type 1. So that every obstetrician knows. And diagnosis at laparotomy. Then, if you are not, confident, don't go ahead if you see the lower segment like in this photograph, totally lost. You can still refer the patient to a team where it is a good team available for take care so that the life can be saved. And this is what FIGO has given in 2019, the classification. Again, we all know these classifications. Only thing, grade 3, one really has to think how competent and how good the team availability is. 3B, 3C is a real disaster at All India Institute. I used to get in 3C, you keep cutting and you see placenta is in the vessels, in the perimetrium, really bleeds. So one really has to have. Now, once you have diagnosed, your ultrasonologist tells you that your placenta is adherent, what is special in the antenatal care of this patient? You have to correct anemia. This is the crux of the matter. Take her hemoglobin beyond 12, try with injectable, give her down with vitamin C, all so that her hemoglobin at the top, because the blood becomes very, very precious. They lose liters in minutes. And avoid rigorous physical activity, antenatal steroids, because you never know when she will bleed or you have to terminate it early. So this is very important. What is the best time to do MRI? Between 28 to 32, so that it gives you a reasonable idea what you are going in and getting it. As I said, we used to admit, but in practice, you see everything. Money is also important. And you admit or not, patient should be able to, they should be able to understand that they have to be near the facility and within minutes, because our patients, they tell, husband was not there, so I could not come, I was bleeding at home. That thing you have to educate your patient that they have to be near the facility, otherwise admit them. And what are the pre-op considerations? Experience, surgeon, multidisciplinary team. I showed my patient to the urologist. I very rarely call urologist. But if required, they should be there. Many people used to say that get the ureter stented. I think that is also overkill, but one has to see the situation. I am talking of serious cases, milder cases, there is no problem. So multidisciplinary team, good ICU backup, when to deliver. This is a very important question. ACOG, RCOG, whosoever says, you have to see what is the weight of the baby, how much precious it is. You want a reasonable maturity, because in grade 3, in all likelihood, you are going to do hysterectomy for the patient. So that may be the only chance for this baby. So you have to balance your decision between the maturity and reasonable maturity for live baby. And if you keep on prolonging, she may end up in emergency. Usually they do not, but I have seen with the passage of time, the size of the vessels also increase, and there may be more bleeding. And as I said, the placenta was not percreta at 24 weeks. But today when I reviewed her MRI again, they say now it is percreta. So things get worsened with advancing gestation. So keep these things in mind and then take a conscious decision when you want to terminate. In my practice, usually 34 to 35 in a severe patient. And we always give Dexacovan. Then comes what should be the surgery. Usually when life is at stake and it is severe degree, earlier decision to do hysterectomy will save more lives. Otherwise, you have so many conservative techniques also depending on patient's situation. And anesthesia, I think anesthetist is the most important member of the team, because we can cut anything, maybe 2 or 3 more blood transfusions. It is the anesthetist, who is responsible for waking her up. Patient position, we do it in lithotomy, because I believe from below we put a sponge and we follow that technique of posterior many a times. I will just show my video. And skin incision, liberal incision, no minimal. So uterine incision, always give a classical incision if you want to save blood. So routine ultrasound in majority of OT is not available. It is basically to go away from the blood vessels, that is the thing, and away from the edge of the placenta. Whether you should total or subtotal, we believe in total if patient's condition permits, because if placenta is low down and you leave a bit of it, your patient will keep on lingering with spotting and bleeding for months. So do a complete job if possible. And these are the surgical pearls. When you open, incision should be liberal, above umbilicus, and always give a fundal incision to remove the placenta. And what we do, immediately suture that in the upper segment, put the cord, tie the cord and put it in. Don't touch the placenta. And well packing we don't do. Uterotonics, if you are going to do hysterectomy, don't use any oxytocin because it will make it contract, and if partly it separates, you will be in more trouble. Tranexamic acid, there is evidence at the start of surgery, give 1 gram, it helps. So surgical steps, I think I'll be showing in the video clip. But the practice points, I know people are very, very good in obstetrics, but I also have reasonably good experience. As I said, used to get, and still I'm getting lot of referrals that the patient is sent to you with the diagnosis of placenta accreta. Take care. So always preserve ovaries. Retroperitoneal dissection you should be competent in doing, and bladder dissection, very important, because it is the time of bladder dissection when they bleed. There is so much of vascularity there. Yes, 2 things I have learned. One is Pelosi's technique, retrovesicle. You see, colleagues, you will agree with me, the moment you touch the vesicle peritoneum and put it down, they start bleeding like, tap. So go by the side of the bladder in the paravesical area, go below the scar, and then come up retrograde. It all depends on case to case, what type of case you are getting, from where the vascularity is coming. But if you are well versed with all these pearls of wisdom given by senior colleagues in a particular patient, after I put up my video on YouTube, so many colleagues rang me up that it helped them, and I'm very happy and thankful to God that I'm able to help some people. So one approach is always open paravesical area laterally, go below the scar, and then gradually come up. And second, I'm very fond of is posterior approach. I'll show you the video. What happens posterior approach? This I have learned these things over the years by a lot of mistakes. So what happens? You are not able to reach the lower limit and she keeps bleeding. You keep applying clamps. If you really want to go to the lower limit, tell your assistant with a sponge holder, push the posterior fornix, just give a nick over it as you do in TLH, and then hold the cervix and come from the side up. You will find you are able to tackle the uterine so much better, and really blood loss is less in many cases. So posterior approach, so these 2 things, retroperitoneal and dissection below the bladder, and posterior approach, depending on the situation what you are getting. And this is, I would just like to show the video clip of a patient who was referred to me with central placenta previa percreta, and they said bladder is involved, but many times we don't find it involved, MRI overdiagnosis. Give a liberal incision, vertical incision, so that an open fast. And first, very important step, colleagues, first take out the baby by classical cesarean section. Don't go for lower segment. And that saves you a lot of blood. It takes minutes for patient to exsanguinate. So this is what, upper segment, fundal incision, take out the baby, hand over the baby to pediatrician. And this is in the YouTube, the whole family has given interview, and see, even in that process, I lost so much of blood. So you have to be really, because vascularity may not be only low down, from all over. Now, I told today my MRI person, please map out the vessels for me. He said, you don't give fundal center. You give on left side, madam, you will encounter, less vessels. So these are the things you learn by your own experiences. So go in an area where vessels are less. That is what people say per op ultrasound or pre-MRI. They give you, go much above the placenta. Don't touch the placenta. The moment you touch placenta, she starts scoring. And then stepwise devascularization. Don't remove ovaries. And this is a better way, if you have these advanced energy sources, they just, they make you little more comfortable. Otherwise, it is the technique which is important. So don't hush bush, stepwise devascularize. And muscularity comes from 4 places: on 2 sides, tubo-ovarian, and on 2 uterines. They are not so important as is the collateral circulation from below in these patients, which is a problem. So now, second is after taking care of uterines, dissection of the bladder. You see this patient had MRI that there is percreta. Many times you will get patients who have started having hematuria. So you have to be, and this is what we are dissecting the bladder, which is flattened over whole lower segment, where the lower segment is so thinned out. So each and every vessel is, it's so much of blood loss. So you have to be very gentle with the tissues. Go lateral, go below the bladder, then come up and pay. Don't worry if the patient is bleeding a lot about bladder injury. A living problem is always better than a dead patient. So take out. Bladder injury hardly matters, and usually there is fundus. See how the muscularity is coming from the below. So painstakingly tackling each and every vessel. You will see the lower segment is the size of the upper segment, and below you will see the perforated wall. So you have to, and then put clamps. If you can put clamps below the placenta, there is nothing like that. In 3C, when the parametrium is also infiltrated, then once I had a patient where I had to give 16 blood. See how the placenta in the lower part is. This is the bladder. Probably this is the place they said that the bladder is invaded. It was not. So many times with your, proper going in correct length, see the placenta is perforating the uterine wall anteriorly and is coming out. So having little patience, and then if you are able to apply clamps below, nothing better than that, and then you take it out. So systematic devascularization and stepwise hysterectomy. If it is very low central placenta, please remember incomplete removal of placenta gives you so much of trouble. So go below the placenta. This is when I have total control. So I'm dissecting and doing total hysterectomy, because I have seen when you do subtotal, some placental tissue is still lying, patient keeps coming with some bleeding problems. So, and then total hysterectomy avoids cancer, as in our country background incidence is high. So this is the case where don't go if your patient is moribund. If it is subtotal and bleeding is controlled, then don't chase the cervix. So it all depends on what is the situation you are in. And as I said, you have to really take care of the hemostasis in these patients. So this is what was badly adherent placenta. And many times we do segmental resection. And there are so many ways of doing segmental resection, especially when we were doing, I had a very big, follow-up with hematology OPD. So ITP cases, I learned decades back by my own mistakes, then ITP cases, they bleed so much. Give those square knot sutures. Square sutures, segmental devascularization, which really helps.
Sorry to interrupt, ma'am. Last 3 minutes left. Thank you.
I won't take 3 more minutes. Don't worry. So, massive hemorrhage, how to transfuse. Everybody has their own formulas. We follow 1-1-1. So you don't give only blood. Now, FFP is very important to be given. Then, what are the measures you can take to control massive hemorrhage? And these are the ways. Internally, like artery ligation, don't go hunting for it if you don't have much experience. We people have, lot of oncology done whole of our life. Otherwise, There is no clear evidence that hunting for internal ilia may be of much help. You can always ligate ascending uterines, and you must be well versed with the procedure of internal iliac ligation if the uterines are very big. Aortic compression. Again, we tried a lot when patients used to bleed aortic clamps. We took our patient to cardiothoracic. I have a lot of experience. I don't think I go deep into it, but if anybody is interested, I have lot of experience with all kind of aortic clamps, and Dr. Piley has so much of experience. We have given up. We don't give after dissection aortic clamps in routine. And pelvic tamponade, it is in a hopeless situation because you leave pads and then your patient is intervention radiology. As I discussed with you, lot of our patients in All India Institute, they used to come very easily. You give a call, tomorrow there is a case, they will come, they will put balloons and they will inflate balloons. You operate, they will deflate. If she is not bleeding, they won't embolize. But to my mind, it is the surgical expertise, and even literature says it may not be very, very helpful, except when collaterals are coming from internal iliac, because as I said, it is basically coming, the bleed usually is from the pelvic floor collaterals. Delayed hysterectomy, many people believed initially, but more literature is coming that you leave the patient, she may bleed or may go in septicemia. But if you are not confident, leave it for secondary stage. And conservative approach, as I said, if it is, patient is not having any alive baby on a situation, it is not very, very severe degree, and it is partly adherent, you remove that segment along with placenta and then suture. As in myomectomies also, there may be loss, as in isthmosil repair also. So the outcome is better when the placenta adherent area is removed and sutured with the fresh one, and then you can put Bakri balloon and all these things. So hysteroscopic resection, I have lovely videos, but it is not at that time when there is so much of commotion. It is for patients who are coming late. And conservative triple P procedure is very popular. Principle is the same. Peri-op localization, pelvic devascularization, and placental non-separation. Don't separate the placenta, it bleeds a lot. And triple P, they have shown very good results. Prophylactic UAE may not be. Patients become pregnant after conservative managed. From the very beginning, get ultrasound and be clear that whether it is diagnosis, early diagnosis is very important. And to take home message, it is an obstetrician's nightmare. Incidence is rising. I don't know why we were doing cesareans for so long. Maybe I have skewed practice because everybody is sending scar ectopics and placenta data to me. So I have large data. Multidisciplinary team is very important. Adequate blood and blood product availability is very important. Today only I told patient 8 blood transfusions I need ready. You may need, you may not. If patchy, conservative management. If severe degree, 3B, 3C, life-saving hysterectomy. Earlier decision taking will save lot of morbidity and mortality. So don't make the patient once she collapses and then only late decision of hysterectomy may not be. Thank you very much for your patient hearing. Thank you.
On this topic. May I invite Dr. Atul Ganatra sir to comment on this?
By the time Atul gives a comment, Alka, on endoscopy platform, we always meet your passion, but in obstetric platform, I know with your M's and all, you have huge authority on Akrita, and that's why when we discussed, me, Parag, Vaishali, Nilesh, Pankaj, we thought none other than Alka and Atul to ask you the questions.
And I used to say that it is a blood bath. It is the day of blood bath when you are going for placenta acrita.
What happens?
Yes.
When people are listening to this, you said 16 blood transfusions you gave, your minute tips of going how to reach to the bladder. When they will handle this case, that will give them a double confidence to handle.
So, well, it's an honor to be here. First of all, I must thank Sunita, dear friend. Sorry?
तुम्हारा वीडियो देखना है. Atul is
My video is on. I don't know why. Yeah. I don't know why you're not able to see me.
We want to see our charming leader.
Our charming leader in women
मुझे
dominated.
लगता है it has been shut off from that side because मेरी तरफ से तो चालू है.
नीरव पहले चालू करो अतुल जी का वीडियो.
सर आपका कैमरा कवर्ड है क्या, कुछ है ऐसा?
नहीं यार, कुछ नहीं है, बिल्कुल नहीं है.
We did not say.
I have two placenta Creta lined up. One is 3B and other is 3A.
Anyway, I think it doesn't matter. It's well, it's an honor to be here on this stage. Sunita, first of all, thank you very much. My brother was discharged yesterday.
Thank you.
But there are 14 members of my family positive with COVID. Right now, my brother-in-law has come positive. So that's besides the point. But I have to thank Sunita on this platform because I think my brother got admission only because of her. It's a double and a triple honor to be chairing a session which is managed or which is on which the orator is Dr. Alka Kriplani. I think we must give her a 2-day conference. Only Dr. Alka Kriplani and the clinical scenarios. Madam, I am also managing a few cases and I have given 132 bottles of blood and blood products to one patient. That's the maximum I have done. But
I know, Atul, I have learned so much from my own mistakes.
Yeah, madam, you are in.
You learn after every case that where you faltered, and you know next case comes with more challenge.
Madam, अगले जन्म में मुझे आपका MBBS और MD का स्टूडेंट बनना है.
How sweet! That's the biggest compliment ever I have received. Thank you so much.
Whether it is BOH profile, bad obstetric history, whether it is endoscopy or it is PPH, I think you are an institution.
You know the secret of this thing? My students, they keep teaching me.
So, it's an honor and a wonderful, wonderful lecture. I think, I hope you get time to make an atlas of your experiences, both in endoscopy and in obstetrics, and make a book out of it. I think students will really learn. Just 2 days back or 1 week back, I have managed a patient with 2 grams hemoglobin, dumb and deaf, husband and wife. She came to us after an OH. And fortunately in Fortis, we could do a CT angio in 5 minutes. She was not tested. We saw post-OH, the ovarian artery was bleeding. We embolized her and gave her 12 FFPs, 20 cryos and 20 FFPs and 12 bottles of blood. She went home in 3 days. I think it's a teamwork. And I think Madam works in a fantastic, it's a teamwork. But excellent videos, Madam. I think excellent videos, excellent photographs. And my request, Madam, hold a 2-day conference on 1 day on endoscopy, where you are the only speaker with your team of anesthetists and their experiences, and 1 day on obstetrics.
Atul अगर president बन रहा है IIG का, Atul will definitely do that.
God willing, Madam. वो तो मुझे लोग बना के छोड़ेंगे, मैं भाग नहीं सकता उससे.
Great idea.
You are the most appropriate person. इतना अच्छा काम कर रहे हो. ये सुनीता को देखो. She the star नहीं है, Sunita the star है.
You know, but let me tell you, I still remember in 1998, we gave 318 blood, including, and in addition, FFPs and everything. The patient in obstetric GIC, Dr. Shashi Apte, the hematologist, patient in Pune Hospital and Ruby Hall residents sitting in a blood bank and sending it over the period of 10 days I'm talking about. But Shashi Apte kept on saying, Ki Sunita, nothing doing obstetric GIC, we don't lose the patient. Today, her daughters have married. So it's, you know, such a important thing in obstetric, having hematologists, having intensive unit, having fantastic blood bank support, everything you need to be. And these cases has to be done in the institutional level with the good friends there.
Madam, one question to you, Dr. Alka Kriplani.
Yes.
Patient is bleeding actively. What is your choice? Would you like to put a balloon in the iliac vessel? Would you like to do an internal ligation, or would you like to do an embolization? What is your first choice?
Very good question. Initial dozens of cases I did that at All India Institute. Ultimately, Atul, I have realized with my data, these things do not help much.
Absolutely.
I stopped getting balloons and embolization done.
So I think it takes about 3 to 4 minutes to do internal iliac on one side, and I think in a patient like this,
even internal iliac, I tell you, even internal iliac is just ligate ascending because blood is coming basically from the pelvic floor,
Absolutely.
and you see the bladder and all those superior vesicle. So mostly the blood is from those areas.
Last 1 minute left. Thank you.
Cases it is internal iliac.
Absolutely. Thank you very much. I think classical incision for a accreta or a
Classical
percreta
is
is the
very
golden
important
rule.
that I have learned.
I have lost one patient when I took a lower segment incision, but this was about 20 years ago.
I admire you for giving this telling in open, because everybody in my video which is on YouTube, so many colleagues say that it has really helped us. Be totally away, be at the fundus, don't touch the placenta.
Absolutely.
The moment you touch placenta, the coagulation gets disturbed, and the way she bleeds, in minutes you lose liters.
Your vertical incision was also so obvious in your video. That's a very important message you gave.
Thank you very much.
And posterior approach really helps in many patients. I have started operating them in lithotomy. Put your assistant, I used to say, Garima, put your hand from below, so that you can delineate where is the end of the cervix. That really helps you in that situation. And immediately put clamps.
Absolutely. Absolutely. I think that's perfect. We should, I think, clap for Madam's presentation. You all can't see me, but thank you very much, Madam.
No, you cannot close the session before I again appreciate Sunita and her, this is not a conference or webinar. This is a project she has made today. And Atul Ganatra, of course, you are, Atul and Pankaj Sarode. And my dear student Amol, who gave me all the links when I'm very novice with these things. Thank you, everybody. Thank you, Team Pune. And Sunita, you are what to say. Great leader.
Thank you, dear. Thank you. Always great to listen to you. And now we have another dynamic lady, Archana. Pankaj, please carry on.
Sunita, I'm going to log out and log in again to see if my video comes on.
Oh, okay, dear.
Dr. Pankaj, we can't hear you. Again.
Hello?
Yeah, we can hear you now. Please continue.
May I invite Dr. Archana Baset to speak on early versus late FGR, practical evidence-based management, and Dr. Chinmay Ratha to moderate the session.
Shall I start or Chinmay? What will I say, madam? First of all, thank you, Sunita ma'am, for this opportunity to be here. And it's been really nice listening to Dr. Alka. It was like going back to your classroom and remembering that such, ma'am, really nice points that you brought about. And now we'll move on to a more obstetric part of and a more fetal-oriented problem in obstetrics, which is fetal growth restriction. And none other than Dr. Archana Baset to address this condition, because the fetal growth restriction is by far one of the important challenges of a preventable stillbirth or a perinatal mortality and morbidity. And if we can address that issue by identifying early and late IUGR in time, I'm sure will give a rational outcome to the pregnancy. So I'll not stand between the audience and Dr. Archana. Madam, please start your deliberation.
Thank you, Dr. Chinmay, for the kind words. At the outset, let me thank Dr. Sunita Tandulwar for inviting me on this platform, and let me congratulate her for a really wonderful scientific deliberations and innovative ideas she has. And she has secretly told me the faculty who will wear the star badge all the time during conference, she has a special prize for them. So I'm wearing my badge, Sunita, here. And it was really nice listening to Dr. Alka. And may I be allowed to share my screen, please? Topic for my today's presentation is early versus late FGR, practical evidence-based management. What I am going to be covering in my talk is something, first of all, is we have to introduce to the problem, definition of early versus late IUGR, identification of the problem, evidence-based gestational age-wise management, and practical management in low-resource settings. We all know that three things which obstetrician fear is related to the baby is: one is the prematurity, second is FGR, and third is the stillbirth. And what if you have preterm FGR? I think that really multiplies your problem to many folds. So evaluation of fetal growth is one of the key objectives of prenatal care, and impaired fetal growth is associated with an increased risk of perinatal mortality and morbidity and long-term adverse outcome. And developing countries, incidence of FGR is as high as 25%. And prenatal recognition of fetal growth is a major factor identified in strategies which are aimed at preventing stillbirth, in which up to 30% of cases are associated with FGR or small for gestational age in the late third trimester. So it is very important for us to understand the difference between FGR and SGA. They are different things. SGA are constitutionally small fetuses. They are small normal fetuses. There is no intrauterine environmental adaptation needed in SGA fetus, and perinatal outcome is similar to average for gestational age fetuses. While in FGR, they are small compromised fetuses and they have Doppler signs of hemodynamic redistribution. They need adaptation to hypoxia, and there is an increased risk of preeclampsia in the babies who are FGR. There are two phenotypes of FGR. That is being recently we have started to understand that early onset FGR, when a FGR sets in less than 32 weeks of gestation, there is a problem of management because you have to balance between prematurity and growth restriction. They have high mortality and morbidity, though the prevalence is low, almost 20%. While the problem with late onset FGR is they are more than 32 weeks of gestation, the problem is diagnosis, because we don't know the actual cause of the late onset FGR. So they at times get missed, though the mortality is less, but they are the most common cause of late stillbirth, and there is a poor long-term outcome which affects large fraction of population. Almost 80% of FGR are late FGR. So what are the tools which we have to diagnose and do the surveillance and management of fetal growth restriction? I think by now, having so many platforms to learn, we know that ultrasound is the main basic thing for fetal growth identification and the problems. So fetal growth velocity, that is done routinely, customized growth charts, Doppler velocimetry, biophysical profile scoring we have cardiotopography which is routine, as well as computerized CTGs are available at some places, and you can do the short-term variations there, and biomarkers. But before we really go on to how to diagnose, let's have a consensus on definition of fetal growth restriction, because there are so many definitions of FGR that at times it becomes very confusing whether I'm dealing with FGR or I'm not dealing with FGR. So the Delphi criteria is the one which is associated with an improved prediction of adverse neonatal outcome, and the definition by Delphi's criteria is the most recognized definition of FGR. So what is that there in Delphi's consensus? They had 108 consultants, out of which 56 responded to their survey, and they all have come to this consensus that in early IUGR, where the gestational age is less than 32 weeks, in absence of congenital anomaly, if you have any of these three solitary parameters and any of these four contributory parameters, you will label it as a early FGR. So three solitary parameters are abdominal circumference and estimated fetal weight less than third centile, or there is absent of umbilical artery and diastolic flow. And contributory parameters are AC and EFW less than 10 centile, combined with uterine artery pulsatility index 95 and umbilical artery PI more than 95th centile, so more than 95th centile. While in late IUGR, gestational age more than 32 weeks, two solitary parameters, AC and EFW, if it is less than third centile or at least 2 out of 3 of the following contributory parameters, that is AC and EFW less than 10 centile, and AC, EFW crossing centiles more than 2 quartiles on growth centiles, or the CPR, which is the main thing in the late IUGR, is less than 5th centile, or uterine artery PI more than 95th centile. So the very clear distinction in late IUGR, the CPR is the good measurement where you can say that yes, it is a late IUGR, and in early IUGR you have all these parameters which you have to take into consideration. Now, how do you monitor? Once you have defined the your IUGR definition, you have made it a protocol. Well, this is a growth restricted fetus. Now we require is the monitoring. A very close surveillance is needed for these babies, because these babies are really notorious. They can succumb intrauterine, or they have a problem even immediately after birth. They can have difficulties in breathing, and all sorts of the problems are there. So we have to be very well prepared and monitor them very well. So there are evidences from randomized trial. The TRUFFLE trial shows that monitoring and delivery timing according to a specific protocol should be done. And for early FGR, they have said include ductus venosus Doppler and computerized cardiotocography, which provides better than expected outcomes. So how do you screen women who are likely to get FGR? You have women have medical problems and they have past obstetric history. These are the women you will be doing an extensive survey and surveillance. You can make your own history checklist. In your you can have a set pro formas where you can just put the tick mark, and then you can put a red dot or a alert for your staff and team members that yes, these are the women. If they are in OPD, they have to be really taken special care, because they are likely to develop maybe hypertension, and there is a problem of the growth restriction, and the baby may be in the danger. So special histories is if there is a history of high blood pressure, diabetes, anemia, or previous FGR and stillbirth, very low weight mother. So all these factors are very, very important in identifying women who are likely to have babies which are growth restricted. Now, how do you determine fetal size? I think all of us know that there are biometric evaluation. You do head circumference, biparietal diameter, abdominal circumference, femur length, and estimated fetal weight computed by different formulas you can do. But what is the most important thing is, if you are doing your sonography, or even if you are sending your sonography to your sonologist, please ask for growth trajectories plotted on a scan which you are asking as a growth scan, because many a times it is seen that the data are written this many centimeters. It is difficult for us to put in a graph, and the machines, modern machines, have this graph inside them, inside its software. So you have to otherwise return the report if it is not supported by this kind of graphs, where you can just eyeball and you can say, yes, here is a problem and this baby needs more closer monitoring. So how frequently you will be monitoring your FGR babies? There is no universal consensus. It should be based on severity of FGR and umbilical artery Doppler. While MCA Doppler is one of the first parameter that becomes abnormal in early FGR. And remember, 70% of women with early FGR will develop hypertensive disorder of pregnancy, mainly preeclampsia. So it is very important, if a woman you are identified that she has early FGR and still she doesn't have hypertension, closely monitor her blood pressure, because it is likely that she might develop hypertension. Frequency of monitoring depends on gestational age. You will be doing Dopplers. If it is less than 34 weeks, if the Dopplers are normal, monitor them 2 weekly. If that is more than 34 weeks, 2 weeks. It is the same for both less than 34 or more than 34. If your SD ratio is raised, do weekly monitoring in less than 34 weeks and even in the more than 34 weeks. If there is an absent flow, then you have to do the twice weekly monitoring in less than 34 weeks, and more than 34 weeks of pregnancy you have to do daily monitoring or terminate the pregnancy, because baby is mature enough to be delivered. If there is end diastolic flow reversal less than 34 weeks, still you feel that it is not good time to deliver because of extreme prematurity, thrice weekly you have to monitor, while in 34 weeks, more than 34 weeks, you do daily monitoring or deliver the baby, and in ductus venosus problem, you have to monitor daily. So this is the sequence of events, changes in umbilical artery. If your SD ratio is less than 3, we all are happy. SD ratio rate less than 3, baby is doing well. If SD ratio is more than 3, you already have 30% reduction of flow, and if 60% reduction of flow, if there is absent end diastolic flow and there is a reversal of end diastolic flow, I think this is a terminal event, you have to deliver the baby. Biophysical profile scoring also can be done, which is combined with evaluation of fetal tone, gross body movement, breathing movements, amniotic fluid volume, and heart rate reactivity. Biophysical score can predict both fetal pH and outcome. And suppose if there is a low resource setting or where there is not availability of frequent Dopplers and sonography, I think you just put a high risk patient, mark with the red dot, and give them a chart that you have to do a homework and do the daily fetal movement counting. They are still relevant and doable at all levels of care, where the tertiary, primary or secondary level care is being given. So do you give prophylaxis in FGR? Yes, you have to give corticosteroids. Even in early FGR, it is recommended. There are several guidelines available suggesting that you have to give corticosteroid prophylaxis. But what happens with corticosteroid prophylaxis in early FGR, and especially when absent and reverse end diastolic flow, there is a reduction in the fetal movements. So you have to enhance your daily surveillance while you are doing the steroid administration. It might be worthwhile admitting the patient for corticosteroid admission if patient is not trustworthy to, they will not note the fetal movements and come in time to you. Just to save the baby, you may be good to admit them when you are doing corticosteroid. And magnesium sulfate, there is a good evidence for efficacy of magnesium sulfate for fetal neuroprotection in context of premature delivery. Next question is, you have done your frequently monitoring, now when and how to deliver. Indeed, for extreme prematurity, when it is less than 27 weeks, an extremely low birth weight, less than 600 gram, each day of prolongation of the pregnancy improves neonatal survival by 2%. And after 27 weeks, ductus venosus Doppler parameters emerged as primary predictor of neonatal outcome. The first randomized control trial on timing of delivery in FGR was the GRID trial. And Truffle study is the largest randomized trial on timing of delivery in early FGR. It was based on 3 randomized arms: early ductus venosus Doppler changes, late ductus venosus Doppler changes, and reduced fetal heart rate STV. So if you look at the timing and mode of delivery, delivery timing should be based on combination of Doppler velocimetry indices, mainly ductus venosus before 30 weeks, and conventional CTG or BPP where this is undertaken. And presence of repeated spontaneous unprovoked deceleration is an indication for delivery. Considering the strong association with several severe placental insufficiency, plant cesarean section is indicated in majority of early onset cases of FGR. So if I summarize the early onset FGR, at present there is no effective therapy for early FGR. Though efficient recognition and management of severe preeclampsia may prolong some pregnancies with early FGR. So what you have to do is timely use of steroid followed by magnesium sulfate, transfer to a tertiary care center where there is a good neonatology backup is available and good Doppler fetal medicine experts are available to regularly do the surveillance of the fetus by Doppler studies, and consider the safest mode of delivery. That is the key concept in early FGR management. And this is a very good guideline by ISIOG, which is being published in 2020 on ISIOG practical guidelines, diagnosis and management of small for gestational age fetus and fetal growth restriction. Very exhaustive and very good guidelines. It tells you like how really to manage your early and late FGR. In late FGR, how to monitor, we will talk about corticosteroid prophylaxis and when and how to deliver. The salient point in late FGR, which I want to bring here to everyone's notice, is the fetus is term with birth weight below the third centile have the highest risk of stillbirth. It is approximately 1 in 100. This is a very staggering number. And this pregnancy should not exceed 37 plus 6 weeks of gestation, independent of Doppler findings. Once you have identified on the growth trajectory, just convince the couple for the delivery. Now in a practice which I have faced is, the biggest challenge is to convince couple for delivery, because in most of the late FGR cases, pregnant women doesn't have any symptoms. She does not have any problem usually. So their biggest question is, why you want to deliver? Can you not prolong my pregnancy a little further? Baby's weight is low. And what happens, your sonography report, the expected delivery date changes, because when you are putting according to the graph, so they take the date which they feel is convenient, and they will say, well, the date is now moved further, so why we deliver? I think it requires a lot of, you have to remain updated. We have to convince them, we have to show them graphs that no, there is a problem and we need to deliver it in time. So how do you monitor late FGR? I think CPR is the real resuscitator. Alteration in umbilical artery Doppler are rare, and they fail to identify the vast majority of late FGR cases or to predict adverse outcome in these fetuses, while in early FGR, umbilical artery Dopplers are quite early. They can pick up the problem, and you can monitor them, and you can take decision depending on umbilical artery Doppler, while here in late FGR, this is the difference. The rationale for using the ratio of MCA-PI and UA-PI, that is CPR and umbilical cerebral ratio, is that they can identify subtle changes between placental and cerebral blood flow perfusion, and that may not be appreciated by evaluation of a single parameters. That's why you need ratios. So CPR is done by MCA-PI divided by UA-PI, and it is not very difficult to calculate. You have ready calculators available where you have to just put your patient's gestational age, umbilical artery PI and middle cerebral artery PI. This is an FMF calculator which is very handy. We are regularly using it. You can just download it in your laptop or in your mobile, and this gives you a very beautifully CPR. And if your CPR is less than 5, definitely
almost 30 to 40% of patients who are just shuffling between all specialties.
The placental
and the only thing which take my mind there.
I'm sorry, there's a
patient who is not able
yeah.
to explain her symptoms.
There's some lecture.
A patient who comes with this big fold of file, you know, जहाँ पे husband पीछे से बैठ के बोलता है सब कुछ कर दिया मैंने इसका.
I think there's another lecture which is interfering
too
here.
much of depressive symptoms, a place where they cannot even.
Can the technical support help us?
So the moment they say pain and a urine culture is negative and UTI has been excluded, treat it. That's the first thing. Even on first visit, I suggest
console is unmuted.
I advise cystoscopy, which eventually, even if I'm managing overactive bladder, down the line in 2 visits, I come to a conclusion that this patient is not responding to anticholinergic, not responding to estrogens, not responding to fluid management, is persistent urge and a pain which worsens with bladder.
Yeah, I think we're sorted now.
No, thank you so much. So we have several studies and research, and that cerebroplacental ratio has been proposed for routine surveillance of pregnancies with suspected FGR. It is not very difficult to learn how to calculate CPR once you know how to do your Dopplers. That really can be of a great help, and it predicts with accuracy your suspected growth restricted fetuses. And this is another publication in ISIOC journal on CPR, that CPR is emerging as a marker of placental insufficiency. That was published in 2015 by Asma Khalil et al. So frequency of monitoring of late FGR. Again, you really need to do a frequent monitoring of pregnancies with late FGR, same as you do for early FGR. The biggest problem is fetuses near term seems to have reduced tolerance to hypoxemia, possibly because of their relatively high metabolic rate compared with fetuses at an early gestation. And we do not know still the pathophysiology of late FGR. So their identification remains lower, and that is why it is very, very important that frequency of monitoring. Once in your growth trajectory you find that AC is below what we do is, even if it is below the 10th centile, we start calling them frequently, because sometimes they may not take it that seriously, and you cannot be waiting till 3rd centile. So start monitoring them more frequently. And when to deliver and what should be the mode of delivery. At any gestational age after 34 weeks, deliver if one of the following is present.
Sorry to interrupt, ma'am. 3 minutes left. Thank you.
Thank you so much. If one of the following is present: spontaneous, repeated, persistent, unprovoked fetal heart deceleration, or there is an altered biophysical profile, or if there is any maternal indication of preeclampsia or HELP syndrome. And 36 to 37 plus 6 weeks, deliver if your umbilical artery PI more than 95th centile or ACEFW is less than 3rd centile. And 38 to 39 weeks, deliver if there is evidence of cerebral blood flow redistribution or any other feature of FGR. And in absence of contraindication, you can do induction of labor. Not necessarily you have to do cesarean section. Identify the problem, rectify the problem, deliver in time, and choose the right mode of delivery. That is the management of the late FGR. And during labor, you have to do the continuous monitoring that is recommended. There was a large retrospective study which has shown that FGR pregnancy after 34 weeks, the median interval between a low MCA PI and stillbirth was less than 5 days. These are quite alarming figures. So that suggests if delivery has not been indicated by that time, twice weekly doctor surveillance may be required after 34 weeks. And 90% of stillbirths occurred within 1 week of normal biophysical profile score in the presence of cerebral vasodilatation. So that suggests BPP may have poor value in determining frequency of fetal monitoring. So you really have to resort to the Dopplers when you are managing. And we know that Barcelona criteria for stage-wise management protocol, and how we decide timing of delivery depending on gestational age and Dopplers. So this is if you have severe smallness or mild placental insufficiency, monitor weekly, severe placental insufficiency bi-weekly, and then when you're suspecting fetal acidosis, every 1 to 2 days, and high suspicion of fetal acidosis, 12 hourly you have to monitor the fetus. There are different guidelines, RCOG guidelines suggesting how and to choose when to deliver. Pregnancy below 32 weeks of gestation, termination should be done with abnormal ductus venosus waveform. 32 to 34 weeks, termination is done with reversal of diastolic flow. At 34 weeks, it is ideal to terminate with reverse end diastolic flow in umbilical arteries, and beyond 34 weeks, delivery is mandatory with absent end diastolic flow to prevent possibility of sudden intrauterine demise. So you have to balance between delivery and a sudden IUFD and patient's expectations in late FGR. If I have confused you enough, this is the last but one slide of my presentation. So when you take in, like in a low resource setting, when you do not have a lot of, accessibility to the Doppler and all, this is a very simple algorithm for FGR diagnosis and follow-up. The first and foremost thing is established correct dating. That can be established by one good ultrasound in the first trimester, measuring the CRL correctly so that you know it is a delayed conception, or it is FGR, or it is IUG, or it is small for gestational age, and assess biometry and plot serial growth chart. It is not difficult, it is very simple, very straightforward. Measure the Dopplers and amniotic fluid volume and placenta, that how it looks like, whether it is more calcified or grade 3 placenta. So these are the simple things which can be done, and I think most of the unit nowadays have CTG available to them. So if that can be used along with it, you can pick up most of your FGR. And our ultimate aim is to give a proper care bundle where we can really reduce the unexplained stillbirths, and not unexplained, we can reduce the stillbirths and extreme prematurity. So the fetal growth restriction, it is a dilemma, because there is a decision dilemma in delivery. So there's a fine balance between iatrogenic prematurity and stillbirth. We are always, as an obstetrician, walking on a tight rope, that if you suggest delivery early, prematurity, baby ends up in NICU, ventilator, you are in a trouble. And if the baby, you are providing the care for good, like say 34, 35 weeks, and you suddenly end up in stillbirth, I think that's a nightmare. So early diagnosis, appropriate monitoring, timely delivery, you can really help prevent the morbidity and mortality. So thank you very much for your kind attention, and I invite you all to AICOG 2022 at Indore as an organizing secretary of AICOG. Thank you, Dr. Chinmay, for moderating the session, and thank you, Dr. Sunita and team, for giving me the opportunity.
Thank you, madam. And do we have any questions from the audience in this session? If we don't have any questions and we still have time, I would just like to congratulate madam on a beautiful presentation. And I think you made it very clear that the early and late onset growth restrictions are two different presentations of similar kind of pathophysiology where the fetus is unable to grow because of an adverse intrauterine environment. But the cause of that environment starts deteriorating before 32 weeks in the early onset and after 32 weeks in the late onset. So would you think, madam, as all the evidence that you've presented, if we translate it into practical management, that we should time at least one growth scan at 32 weeks and one at 36 weeks so that we do not miss out on the late IUGR?
I think I agree with you, Chinmay, since you have been also involved with a lot of fetal medicine, and we've been doing teaching and training and on several platforms. I think it is very, very important that a growth scan has to be done around 32 weeks, maybe earlier, if a woman has a history of, like previous prematurity, stillbirth or hypertension. So in my practice, what I normally, when the couple is coming for first consultation, like at least 4 sonographies we will be doing. I know many places it may not be practically possible. That one is the viability scan, that is the dating scan. Second is a very good nuchal translucency scan, that is the first trimester anatomy. And depending on what are the conditions between 28 to 32 weeks, one growth scan is offered to all the couples, and then one is a late once if you know that it is going towards IUGR, then you do a late, like around 35-36 weeks.
Because it's important to be alert throughout. I mean, when you see growth restriction early, of course, all of us get anxious, and then the early IUGR is actually not such a big problem in terms of diagnosis like you presented, because there will be a cascade of Doppler changes and it will catch everyone's eye. So there you know what to look for, you don't know what to do. But in late IUGR, the problem is you know what to do. If there is IUGR, you will deliver that baby at an appropriate time, but you don't know what to look for because the findings are not very obvious, they're very subtle. So I think after your talk, all the audience would be enlightened on this issue, and we will start looking at our babies much more concertedly, and we will not, I mean, we won't be jeopardizing our management of IUGR. Thank you very much for this brilliant talk, ma'am, and thank you very much the organizers for this opportunity. Over to you.
Fabulous as usual. You were fabulous, fabulous, and thank you, Chinmay. But don't log out. You can also, because Pankaj is for the mega quiz, and mega quiz is a huge thing.
Thank you, Sunita. Your words matter a lot, and it is really a great opportunity to present on this platform, and you are star of stars.
I am one of the star with you all, with my team POGS. Let me tell you, Parag has joined. Parag has taken huge efforts for this CME. He is a CME in charge. He knows who are the pioneer in which field, and he has handpicked everyone. And that's the reason the success we are all watching. Thank you, Parag. Thank you for your time.
Thanks, Parag, for putting in word to Sunita to include me.
Oh, it's a pleasure, Archana, to have you with us, and of course, Chinmay, you are really good at it.
Thank you.
Thank you.
Archana and Dr. Chinmay. And I request all the delegates to please log in to Obstetrics and Gynecology for a mega quiz where we are giving out precious prizes. And this is a time to announce winner of the Star Hall Quiz 3 is Dr. Vasanti. And Dr. Vasanti, congratulations, and our organizing team will contact you soon, and we will see to it that your prize is delivered. Thank you so much.
Please.
Please log into the obstetrics and gynecology.
Prize which is going to be given for the obstetric hall for the mega quiz is a CTG machine, and for the gynec hall there's an gynec endoscope, laparoscopic endoscope for the quiz, mega quiz. So please log in to the obstetrics and gynec hall to participate in that mega quiz.
And don't forget to join tomorrow 9 a.m. back.
Yep, and log in the gynec and obstetric hall because we are starting mega quiz there soon. Thank you all.
Thank you all.
All tomorrow.
Thank you, madam.
Chaitanya, you are amazing. You will rock in Foxy. The way you are working is amazing. Love to see you. And Pankaj, you are always with a great smile. Archana, thank you, dear. Thank you.